past president.
So, after the amazing 3D session, we move on to the next segment, and that is the continuation of ocular oncology and pathology. This is the session 3, and we have with us our kind chairs, Dr. Abhijit Kaur Chabra and Dr. Neelam Pushkar ma'am. Welcome, ma'am. And Dr. Abhijit Kaur Chabra is the head of the department and professor at KGMC Lucknow. She's also the past president of OPI. Thank you, ma'am, for coming all the way from Lucknow for sparing time with us. And Dr. Neelam Pushkar, ma'am, is professor ocular oncology and oculoplasty at RPC. So see, again, this is a very great platform. They've come all the way for you, so make the most out of it. And we start with the first talk of this session. That is by Dr. Sridhar Naik, sir. And his talk is on approach to contracted socket. And sir is an experienced surgeon and a great teacher. You've all met him yesterday, like on Sunday with the hands-on course, and he has explained so beautifully. I was actually there standing around and listening to sir. He took all his time to teach you even hurdles and even small nitty-gritties of how to handle the patient. So over to you, sir. He's a consultant at Center for Sight with us ourselves.
Thank you, Rolika, for all those kind words.
Close that light.
Well,
It's very bright.
my topic for today is approach to contracted socket. So before we go to contracted socket, let's just understand what an adequate socket is. So basically, an adequate socket is a socket which retains an adequate prosthesis with free upper and lower fornixes, and it is covered normally by moving the prosthesis gets covered normally by moving upper and lower eyelids. Now, so you should know what is a normal adult orbit and the socket volume. It's about 7 to 9 ml, and 2/3 of the volume is replaced by the implant and 1/3 by the prosthesis. Now, inadequate socket is one which is unable to perform its intended function as much as the adequate socket. Now, inadequate socket again can be a restricted socket or a contracted socket. Restrict socket is one where there is the presence of fibrous bands, as you can see in the picture, that tends to slip the prosthesis out of the socket during the movement of eyeball. And now contracted socket is one when there is a shrinkage or loss of conjunctiva. Now there will be various etiology for contracted socket. One of the common things is when you do not implant after enucleation, or post an enucleation evisceration, if there is any delayed use in using conformer. If at all you're wearing prosthesis, there is patient is not wearing prosthesis for throughout the day, or patient is not using a prosthesis. So these are the most common ones. And also when you're using prosthesis for a long duration, there may be a recurrent infection or inflammation of the socket itself. In spite wearing the prosthesis, there might be infections like conjunctivitis and inflammation within the socket. Now, prior injury, as in the loss of globe because of a severe injury and causing a lot of tissue loss, can itself cause a contracted socket. And where the history being an acid or alkali burns can cause a contracted socket. Post-irradiation for enucleation in intraocular tumors such as RB can cause a contracted socket. If there is too much of excision of conjunctival during evisceration or enucleation procedure, it can result in contracted socket. And sometimes once you've made a surgery, but there is migration or extrusion of implant, and that itself can lead, and which has not been treated, can cause to contracted socket. Now, these are two patients with, on the right, you can see that there is a severe contracted socket in the left globe post irradiation for retinoblastoma. And on the picture on to your left is a contracted socket showing following enucleation without implant. Now then contracted socket again can be of different types. One which is post-enucleation or evisceration, such called as an ophthalmic socket, or with a normal size globe with obliteration of fornices, it's called an ophthalmic socket. Sometimes patients have microphthalmos or presenting with microphthalmos with cyst where there is a smaller globe, and they can also have microcornea and smaller bony orbit. Sometimes there may not be a normal globe itself, as in there might be a rudimentary globe which results in deformity of its socket, and there may not be a properly defined orbit or development of eyelids, which is called as hypoplastic socket. Now, how we grade a contracted socket, this is one of the important things that you know. The most famous is the Gopal Krishna classification. They are divided into 5 grades. Grade 0 is when there is well-formed fornices and the socket is well lined by conjunctiva. There are deep and well-formed fornices. Grade 1 is when there is shallowing or shelving of the lower fornices. Grade 2 is when there is both upper and lower fornices are shallow. Grade 3 is when there is loss of all fornices, all the 4 fornices. And grade 4, when there is, along with the shallowing of all fornices and reduction in palpebral aperture. Grade 5 is when there is a surgery has been done and there is recurrence of contraction. Byron Smith has also classified contracted socket as mild, moderate, and severe. Mild is when there is a shortening of the posterior lamina leading to entropion, but the fornices are normal. Moderate contracted socket is when there is contracture and obliteration of the superior and inferior or both of the fornices. Severe contracted socket is when there is loss of all fornices associated with volume deficit. Reduced palpebral aperture causing blepharophimosis may also be present. Now, you should know about one entity called as malignant contracted socket. This is a very severely contracted socket, especially after chemical burns. Severely contracted socket, which has been operated on several times before, and the interval between 2 surgeries has been very less, or maybe like 1 or 2 months period. And also contracted socket with severely damaged eyelids. Along the examination, you should also measure the palpebral aperture. You can see acquired blepharophimosis. There may be recessioning or deepening of supratarsal sulcus, ptosis or entropion of upper eyelid. You can also, in the lower lid, you can see entropion or ectropion of lids. So this is a patient who is having a shallowing of inferior fornix and not able to hold the prosthesis, leading to contracted socket. This is an old gentleman having a contracted socket causing superior sulcus deformity in his left orbit. So examination is that you measure the palpebral aperture both horizontally and vertically, and also measure the fornices. So the normal fornicial depth in the upper lid being about 10 to 12 millimeters, in the upper being about 16 millimeter, and the lower being about 10 to 12 millimeters. So these can be measured, and also the volume of the orbit can be measured. So the management is, in terms of mild contracted socket, in the early stage, you can increase the size of socket by increasing size of conformers, so that the conjunctiva itself expands, so that you can put a well-fitted prosthesis. If there is a symblepharon or you have a fibrous band, you can break the adhesions and do a Z-plasty and place a conformal which will correct the contracted socket. If there is a shallowing or shelving of inferior fornices, you form the fornix or put a fornix formation suture. If there is a shortening of posterior lamella which is causing entropion in the lower eyelid, do a Wies procedure. Wies procedure is a transverse blepharotomy with marginal rotation. And if there is significant lid laxity, you can do a Wies procedure with horizontal lid shortening as a lazy T procedure, or a lateral tarsal strip procedure can also be done. Sometimes if there is the posterior lamella is shortened, you can always put a ear cartilage graft so that the posterior lamella is thickened and the entropion gets corrected. So this prior patient, which is he's having a lower laxity and not able to retain prosthesis. The lower lid laxity has been corrected with horizontal lid shortening by doing a lateral tarsal strip procedure and fornix formation sutures. The moderate contact socket, there is shortening of both superior and inferior fornices. This may result in posterior migration of the implant and causing poor motility. So this mainly moderate contractile socket where there is shortening of the conjunctiva and there is very less fornices available, we can resort to a mucous membrane graft or a skin graft which can be split or a full thickness skin graft, which gives surface to the socket and a prosthesis can be placed. So the most commonly taken site for mucous membrane graft is the buccal mucosa. And other sites can also be used. The buccal mucosa is most commonly used. So you also avoid lip margin, gums, and opening of the parotid duct for a mucous membrane graft. So the mucous membrane graft itself has to be larger than the size of the defect or the size of the contracture once released. It has to be about 30 to 40% larger than anticipated and ideally about 0.5 millimeter thick. So the technique itself involves the incision along the center of the socket and you dissect out the contracted tissues so that the fibrous tissue is removed and the fibrous bands are removed and the defect that is formed, you can place an MMG and about 30% larger and the graft itself is taken from a lower lip or the cheek area. And when you are taking from the cheek area, try to avoid the parotid duct opening. Now, the graft once taken is placed in position and 4 sutures at the corners of the graft are placed and interrupted sutures are used to fix graft to the host bed. And post that, the upper fornix and the lower fornix are formed using fornix formation sutures. Once the fornix is formed, you just place a conformer which is fitting snugly and adequate pressure is maintained on the graft so that the graft host junction is firmly placed and the graft is taken up well. Post the graft surgery is done, after placing the conformer, what tarsorrhaphy is done so that the conformer is in place for a longer period, for about 3 to 4 weeks, wherein the graft host junction is developed and the graft is taken up well, and you can remove the conformer and give a patient for prosthesis trial. Some of the complications associated with mucous membrane graft are sometimes because you've removed the fibrous band and fibrosis, the implant itself might extrude or the implant may migrate anteriorly. And there might also be a recurrence of the conjunctival shrinkage and contractions. And problems with skin grafting are that there might be infection and the graft sometimes may not take up and there may be growth of lanugo hair and sometimes there may be a foul smelling discharge. So these are pictures wherein mucous membrane graft is harvested from the cheek and sutured to the socket. The case wherein left eye there is ill-fitting prosthesis and with contraction, you can see in the adjoining picture there is entropion and shortening of inferior and upper fornices. This patient was managed with a mucous membrane graft. Post mucous membrane graft, you can see that the conformer is in place and about 4 to 6 weeks later, you can give him a prosthesis. In severe contracted socket, apart from the surface contracture, there is some volume deficit also. So for volume replacement, you can do a socket reconstruction wherein you give graft which gives both surface and volume. So mainly dermis fat graft is used, the donor side being an upper and outer quadrant of buttock. So you take the upper outer quadrant of buttock and the skin is marked and the epidermis is removed with a razor blade and the dermis and the underlying fat is dissected out. The size of the graft itself is about 25% more than the defect. When you are removing the fat, you just make a note that you are not damaging the underlying fascia or the gluteal muscles. So the graft which is taken out, it is transferred to the socket after excising the fibrous tissue and achieving complete hemostasis. The graft is then sutured to the remaining conjunctiva, and fornix formation sutures are placed, and post that a conformer is placed. Conformer is left in the socket for about 4 to 6 weeks, and then a prosthesis trial is given. Post-op, sometimes the dermis fat graft itself may not take up. There might be a necrosis, or the graft may graft itself may fail. And graft shrinkage is the most common cause. Whatever graft, the dermis fat graft that you put, it may not be enough. You may have to repeat the procedure, and there might be some socket infections too. So these are the pictures. The upper and outer quadrant is marked. This is where we harvest the graft. So once infiltration is done, and at the marked site, and the epidermis is scraped out, and the dermis along with the underlying fat is excised. Once you have harvested the graft, you go to the socket wherein you have already released the fibrous bands, and you place the dermis fat graft into the host. Now, this is a patient of RB in his adult life. You can see that the right side of the face itself is bony development is reduced because of post-radiotherapy for RB. Now he's got shrunken fornices, and there is also a lot of volume loss. And the prosthesis is not fitting. So once a patient has undergone dermis fat graft, you can see the dermis fat graft with fornix formation sutures. He's able to, conformer is able to be fixed. Now this conformer will be removed about 4 to 6 weeks later, and a prosthesis trial can be given. So one thing, these we are talking about all vascular sockets. Sometimes you can get, especially after radiotherapy in RB kids, you can get an avascular socket, wherein you can take a pedicle flap of the temporalis muscle, which will give you vascularity, and post that you can either resort to a MMG and DFG at a later date. So this is a schematic diagram just showing raising a pedicle flap of temporalis fascia. The temporalis fascia which is taken, the pedicle flap is tunneled through from the forehead into the orbit, and then you can just place the pedicle, and you can remove the pedicle at a later date once the socket is vascularized, and post that you can resort to a MMG or DFG, and you can be able to put a prosthesis later on. So these will be a staged procedure. So that completes the management. So summarizing, contracted socket is mainly for cosmetic rehabilitation. Here already the patient has lost his vital organ, but you are giving better self-esteem and improving the psyche of the patient by doing a proper cosmetic rehabilitation. You also have to take a relevant history in these cases, because what is the insult that has been caused? The insult will be mostly in terms of trauma or an acid-alkali burn, or there might be an intraocular tumor for which, or some infection like panophthalmitis or endophthalmitis. So you should know a relevant history, and history should also include what are the past procedures that he has undergone, so that you don't plan your surgeries one by one, and it should be adequately timed and staged. So also address expectations, like wearing a prosthesis also improves the psyche, but you should understand what is the expectation of the patient itself. Sometimes it's an event expectation, like many of the times the patient has an event for which he needs a prosthesis, but in some cases it is throughout life. As in some patients who are having a lot of public life, they want to have a proper cosmetic appearance throughout their lives. But in some patients, it is just an event for a wedding in the family, or wedding of the grandson or grandkids. So these are some of the expectations which you have to address, and plan your surgery accordingly. And just because if you have too much of volume deficit and contracture, you just don't advise dermis fat graft to about 78 years old male. Okay. So what I'm trying to say is you have to see what the patient needs, and do a customized approach, so that you can manage the contracted socket. Thank you. That finishes my presentation. I had some MCQs. Right. If anybody has any questions regarding socket, you can please feel free to ask before I ask my questions myself. So just 5 or 6 MCQs. The first question is, which of the following is less likely to cause a contracted socket? Oh, yes. So everybody knows the most important thing is if you are doing an enucleation without an implant, it's a big crime. You know, being in oculoplasty, a enucleation with implant is one which ensures that contracted socket will not happen. So chemical injuries, not wearing a prosthesis, post-radiotherapy for RB will, most cases will lead to, or you should be ready for contracted socket. So a question on mild contracted socket. Mild contracted socket can be managed by option is fornix deepening suture, entropion correction, larger conformer, all of the above. Yes. So one of the beauty is when the topic of contracted socket was given, so it is plasty. I always think that is 4 aspects. One is the eyelids, 2 is lacrimal, and third being orbit, and 4th being socket. So socket is the topic that I have discussed. Since you are putting implants, putting grafts, so you are entering into the socket and the orbit anyways. And contracted socket itself causes a lot of eyelid deformities. In the upper lid, it causes ptosis and entropion. In the lower lid, it can cause entropion, ectropion both. And also, because you're wearing prostheses, or can also cause lid laxity. So the managing eyelid procedures like ptosis correction, entropion of the upper lid, entropion of lower lid, ectropion of lower lid, and managing lid laxity has to be known. Yeah, so I'll just take 1 more minute, please. So the question, all of the above, you know the answer. And now, PMMA, silicone, hydroxyapatite are different types of grafts, implants, flaps, sutures. Yes. So the question here, the point that I wanted to make is you should know the different materials of implants, and again emphasizing the point that post a districtive surgery of evisceration enucleation, I would expect that the implant has to be put. So that was the intention of this question. Now, Z-plasty. Z-plasty lengthens the scar, rotates the scar tension line, both of the above, none of the above. Both of the above, none of the above, A, B. Both of the above. So the Z-plasty, so is usually made to, if there is a linear scar, you can just lengthen the scar and rotate the scar tension line. That will correct the scar. Can also be used in the conjunctiva to remove symblepharon, can also be used in skin to correct linear scars, also to correct ectropion caused by linear scars. So, which of the following is not part of socket examination or investigation? A, palpebral aperture, B, OCT, depth of fornices, CT scan. OCT, yes, OCT is an intraocular examination. CT scan can be used to see what the bone, because the orbit itself is made by a bony framework. So you should know that CT scan has to be a part of socket examination. Right. Now, question on DFG. DFG is a composite graft, gives surface and volume, needs a vascular socket, D, all of the above. Yes. So again, emphasis on DFG, that it is a composite graft. It is made up of 2 components, that fat and epidermis. It also gives surface and volume. And to need DFG, you need a vascular socket, or else it will fail. Right, that finishes my talk. Thank you. Thank you for your patience. I thank chairpersons Dr. Neelam and Dr. Aprijit, and I thank Dr. Santosh Honavar for giving me this opportunity.
So much before you actually wind up, I will conclude your talk by saying that a contracted socket is best treated by avoiding its occurrence. Because once it occurs, you're not sure whether you require 1 procedure, 2 procedures, 3 procedures, how many. So it's best treated by avoiding its occurrence.
And one more thing, Dr. Sridhar, I think you should tell a little bit about the types of, artificial eye. For these students, they should know customized eye and, the ready-made, what is the difference, just in 1-2 lines.
Right. Yeah, so the prosthesis can always be customized, or you can have a stock eye. So the stock prostheses are available with the ocularis or even at the institutes. The stock prostheses may not match with the other eye, and so that is one. Customized is where it gives you better cosmesis, and since it is customized, the prosthesis and the implant, there is better motility post implanting. So giving a customized prosthesis is much better, and stock prosthesis itself may cause or a long duration of wearing a stock prosthesis itself can lead to sometimes contracted socket because it's an ill-fitting prosthesis. So that is one. Thank you. Thank you.
Thank you so much. So we move on to the next topic.
Okay. All right. So I would like to invite Dr. Abhijit Kaur. She is head of ophthalmology department in KGMC, Lucknow. And she'll be taking lecture on evaluation of proptosis, and this is going to be an interactive session.
So I'm supposed to be speaking with you about evaluation of proptosis. Honestly, tell me how many of you are comfortable when in the OPD you get a patient of proptosis? Back at home, अरे ये क्या गया इसको तो प्लास्टिक क्लिनिक भेज दो. That is the general response. And I actually feel that the orbit and consequently proptosis is one condition which is like mathematics. If you know what is placed where and what moves how, what pushes and what pulls, if that concept is clear, I think the best case to ask for is proptosis in the exam. Because most examiners won't know it, and you would know it well. So some of the diagrams and textual photographs are from the internet, and patients' photographs have been taken only after their prior consent. This is very basic. We all know that the orbit is made of 7 bones, right? Now, interestingly, we are at a junction. Above us is the cranium, below us is the sinus, the maxillary sinus. Medially is the ethmoid, and on our outside is a very important fossa. ऐसे कहते हैं ना बुद्धिमान. But there is no buddhi here, but there is the root to the buddhi. Why? Because we have important nerves and very important blood vessels in this area. So just to list, frontal, zygomatic, ethmoid, sinus, sphenoid, maxilla, palatine, and lacrimal. Other than the specific characteristics of each bone, I'm not going into those details because of constraint of time. The orbit is pyramidal and the bones are curvilinear. What does it mean? What does curvilinear indicate? That the roof is not flat. It has a convexity. The floor is not flat. It has a concavity. The medial wall is flat, but it is tilted. And the lateral wall is straight, but it is tilted. The height of the orbital margin is the most. Where? Where is the height the most? Just behind the rim. The width of the orbital margin is 35 millimeters. Depth is 40 to 50. Why do we say 40 to 50? Because it's not a uniform pyramid. The medial wall is straight. The lateral wall is at an angle of 45 degrees. The interorbital distance is uniform. The volume is 30 centimeters square. And the child's orbit is rounder than the adult orbit. There are lots of fissures and foramina. I won't go into detail, but I will tell you why they are important. The superior orbital fissure transmits 1, 2, 3, 4, 5 sets of structures. Why is it important? It is affected by fractures, it is affected by inflammatory edema, and it is affected by hematoma. And all the structures that pass through it can get affected, right? So if you see the cranial nerves, there are the third, the fourth, and the sixth. All of those which are important for motility. So if they are being sort of strangulated because of the fracture, edema, or hematoma at the entry point, what do you think is going to happen? Anybody? They will lose their function. So if they lose their function, you get what is called as external ophthalmoplegia. This is what is referred to as the superior orbital fissure syndrome, right? Now very close is the inferior orbital fissure. And this inferior orbital fissure has its importance right from the orbit to the face. Because unlike the superior orbital fissure, the contents of which finished within the orbit majorly, the inferior orbital fissure has its content coming onto the face, right? So 1 centimeter posterior to the inferior orbital rim, if it gets injured, you get what is facial anesthesia. Now come to the optic canal. Very close to the superior orbital fissure, may or may not be affected in isolation. If it is affected in isolation, vision is the only thing that goes. But if it is affected along with the superior orbital fissure, then what happens? So if there is a patient who says कि साहब दीदा भी नहीं घूम रहा, दर्द भी हो रही है और दिखाई भी नहीं दे रहा, what does it mean? Orbital apex syndrome. Because here the fissure and the optic canal both are involved. And this is what is called the orbital apex syndrome. So you have a superior orbital fissure syndrome and you have an orbital apex syndrome. Now these bones are different from the other bones of the body. They are papery thin, so they are prone to infections. They have thick margins, so they are protective. They have a curvature which is congenial to the muscle action. They are flat bones, they allow hemopoiesis. And the floor is the most vulnerable to fracture. Why? Because it is thin and unsupported. But you would say that the ethmoid is thinner than the floor. Ethmoid has so many foramina. Why doesn't that fracture? It gives way. It allows the forces to pass. When there is a disparity in the structure, there is a thick strut in the inferior orbital fissure, along which there is a thin bone. So a disparity is what causes the fracture. Access to orbital contents can be done without actually breaking the bone. So now we hardly do osteotomies. This is another very important structure of the orbit, the periorbita and the orbital septum. You have an upper respiratory infection and you say, there's retrobulbar pain. Why? Why do you get retrobulbar pain when there is sinus infection? Because the entire base of skull is supplied by the trigeminal nerve, the V1, the V2, and the V3. So your sinuses share the nerve supply with the periorbita. The periorbita extends to the lid as the orbital septum. So it is one continuum. The meninges, the periorbita, the septum, it's all one big fibrous continuum. There are 4 important ligaments. The Whitnall's ligament, which runs from the trochlea to the lateral wall of the orbit. So it's like a horizontal suspension. The suspensory ligament of Lockwood is the thickened part of the Tenon's capsule, and the medial and lateral checked ligaments, which are the posterior lacrimal crest to the Whitnall's tubercle. Now this is another very important part which has of late gained a lot of importance, the orbital fat. Up until now, we knew that orbital fat provides the cushion. It does. But it is also the most proliferative part of the orbit in disease processes, especially inflammatory disease processes and autoimmune disease processes. And that is why in thyroid ophthalmopathy, the adipose tissue that increases is actually now addressed as the first wall for a decompression. It also has its importance in blepharoplasty. There is an extensive arteriolar anastomosis of the internal and external carotid system. We have to remember this. And the venous drainage from the external to the internal venous drainage system. The face is connected to the brain through the orbital venous system. Lymphatics in the orbit are sparse, and they are particularly around the lacrimal gland. Apprehension looms large. What does this mean? Proptosis का patient आ गया, अब क्या करें? Anatomy तो आ गई. How do we go about when there is a patient? So this is the second part of the talk. The scenario is that orbit has a lot of structures, and they are all suspended. There is a scaffold. You know, when the masons and the people who do the painting of buildings, they build a scaffold on which they stand. Similarly, orbit has a scaffold, and everything within the orbit is held by that scaffold. All orbital tissues can produce neoplasm, whether it is fat, there is blood vessel, there is the nerve, there is the muscle tissue, anything. So all etiologies can affect all structures. So when you have to list, you know that the itis is inflammation. Myositis, muscle inflammation. Myoma, benign muscle tumor. Myosarcoma, malignant muscle tumor. Similarly for all structures of the orbit, all conditions cannot be clinically diagnosed. Why? Because clinical diagnosis in the orbit is a result of the primary nature of the disease and what that particular thing is doing to the structures around it. Suppose there is an inflammation at the superiotemporal quadrant, right? Now, this inflammation will affect the structures in the superiotemporal quadrant. What is the most important structure of the superiotemporal quadrant? Lacrimal gland. So the clinical picture of the lacrimal gland is going to be quite similar, other than the pain, to a tumor of the lacrimal gland. So dacryoadenitis, other than the pain component, would cause a displacement quite like the lacrimal gland tumor. So you may not be able to diagnose all conditions clinically, and radiology will definitely help you, and you have Santosh who's going to teach you about the radiology. Histopathology will confirm the diagnosis. That doesn't mean that clinical examination is not important. You will reach the site of lesion and the nature of lesion only based upon your history and examination. 60% of diagnosis from history, 30% from examination, and 10% based on radiology. We need to find out whether what we are dealing with is proptosis or something which is looking like proptosis. What looks like is called pseudoproptosis. It is a simulation of abnormal prominence or a true asymmetry which is not the result of increase in orbital contents. See, proptosis, you have to understand that if you have a container and that container has some contents, right? If anything pushes from any direction, you will get what is called proptosis. Unfortunately, there's hardly anything that pulls the contents of the orbit. So everything from the orbit is pushed. if you can imagine the force of pushing and the consequent displacements, proptosis is very easy. So causes of pseudoproptosis would be enlarged globe, contralateral enophthalmos, asymmetry of orbital size, and asymmetry of palpebral apertures. Now look at this child. Eyes are closed. There's huge swelling. If the child does not open the eye, how will you say it is a proptosis or not? It looks like a proptosis. But actually, on radiology, the eyeball is at the same level. It is just the lid which has a huge vascular tumor. Adequate eyelid closure should be ensured even before you start your treatment. Because no matter what treatment you do, if the cornea has gone, then your treatment is of no use. So what are the criteria for proptosis? The anterior displacement of one or both globes within the bony orbit, protrusion of more than 21 millimeters or a difference of 2 millimeters on hurtles, and on scan, globe protrusion more than 21 millimeter anterior to the interzygomatic line on axial scans. Proptosis without displacement is referred to as axial. Right from behind, something is pushing. And what is behind is the conal space. Conal space is bound by all the 4 recti. It includes the fat and the optic nerve. So asymmetry is the most crucial part. Quickly, the spaces of the orbit. Why are they important? Because we need to know the contents. The intraconal, extraconal, subperiosteal, and tenon space. This is a diagrammatic representation. So let's consider axial proptosis. Direct push from behind. What can give it? Commonest is cavernous hemangioma, optic nerve glioma, optic nerve meningioma. Large extraocular muscles, when all 4 of them are symmetrically enlarged, as occurred in thyroid ophthalmopathy. You see axial proptosis. And here what do you see? The fat is so much proliferated, along with huge bellies of the muscle. Another patient, this orbit is full of this optic nerve sheath meningioma. You see the typical tram track sign. Non-axial proptosis. Where is this eyeball? It is inferiorly displaced. So something has to be there superiorly. Or else then something is pulling it from below. Right? So here in the scan you see that there is a huge whitening in the upper area. And you can see that white sharp point. This was a cysticercus with a huge inflammatory granuloma around it. What do you see here? Where is the eyeball? Down and in. So where is the lesion? Up and out. What is there in up and out? The clymbral gland. Lateral displacement. This is true lateral. See the way it's pushing it. Right? Where is the lesion? In the medial orbit, either primary medial orbit or it's come from the ethmoid. Superiorly displaced eyeball, either from within the orbit or transmission through the floor from the maxilla. Enophthalmos. We talk of proptosis, we talk of tumors, and why do we talk of enophthalmos? Because there are 2 tumors which, despite being space-occupying lesions, cause enophthalmos. And which are those 2? The venous varix and the metastatic serous carcinoma of the breast. You see this patient? You see the upper image, left eye? What a deep superior sulcus he has. And once he does the Valsalva maneuver, see what's happened to the lid? And see the position of the eyeball. This is a typical orbital venous varix. So for assessing the case of proptosis, you have to remember these P's, 6 P's. The first 2 in the red are from history, and the 4 are from examination. So whenever there is history of pain, it is either inflammation. Inflammation could be infective or non-infective, or it is from pressure. There's so much of pressure within the orbit that it's hurting the periorbita and it's giving you pain. And the third is what we had talked in the morning about the perineural spread of lacrimal tumors. Progression. Rapid progression, something which occurs within hours to days, is hemorrhage. Intermediate progression, something which occurs in weeks to months, and slow progression occurs in months to years. This child went out to play, came back after 2 hours crying with the eye pushed downwards, such rapid proptosis. He had banged his head while playing on a stone. You see this huge hematoma, blood was sucked. Rapid onset, bleed, right? You may or may not get the evidence of injury. So when you examine these patients, what do you need? A torch, 2 transparent 6-inch scales, the Hertel's exophthalmometer, cotton, fluorescein, and some noxious and pleasant smelling substances. So now we come to the examination P's. So first is proptosis. Identify whether it is axial or abaxial and the amount, and it is to be recorded in millimeters. These are the different techniques you can use: the Hertel's, the 2 scale, the 1 scale, or the Lewis. Second P is the palpation. What all do you palpate? The rim and periocular tissues, orbital tonometry. The vasculars are soft. How do you do the orbital tonometry? So also called as retropulsion. You ask the patient to close the eyes, sit comfortably, not to squeeze. Put your thumb on the eyeballs and just push backwards. Equal amount. Don't do this. It's gentle push. If it goes inside, it is a soft mass. It is vascular. Anything that does not yield to your pressure is firm, right? That could be anything. So as is done in general surgery, mass is described under the standard headings of site, size, surface, consistency, fixity, tenderness, temperature, and transillumination. So this is how orbital tonometry is done. Can I get a signal of my time? How much time? So why is transillumination important? Cystic. How do you do transillumination? You need a pen torch. Don't take that big white Jeep torch and shine. No. It's a small pen torch which you will apply on the lesion. The third P is for pulsations. So there are 2 types of pulsations. One is the true pulsation. Means that there is a direct true connection between the arterial and the venous system of the body. Commonest site is the cavernous sinus. Carotico-cavernous fistula, CCF, right? What does it give rise to? Pulsatile proptosis. The other is the transmitted pulsations. What else in the body pulsates other than the heart? Brain. Brain has inherent pulsations. So if there is a defect in the cranial vault, in the cranial base, it communicates with the orbit, right? And the cranial pulsations are then transmitted. So meningoencephalocele, that's one. The second is neurofibromatosis. Why should neurofibromatosis pulsate? Yes, sphenoid wing dysplasia. When the defect is large, the cranial pulsations get transmitted, the brain pulsations get transmitted. This is a patient typically doing her Valsalva maneuver. Periocular changes. These are the ones that will give way to what could be the possible diagnosis. If there is pigmentation, it's either a melanotic lesion or a neurofibroma. If there is a temporal flare, thyroid ophthalmopathy. Eyelid positional changes, again thyroid ophthalmopathy. If there are dilated veins and the patient complains of headache, the cranial venous sinus system is involved. If there are telangiectatic vessels, there is vascularity. If there is lymphoma, you will get a typical pinkish color salmon patch. And if there is temporal fullness, you know that the bones of the lateral wall are involved, and most common, this is the sphenoid wing meningioma. So this is a large cafe au lait spot on the right upper lid, the typical S-shaped deformity of neurofibrosis. Now this lady had been traveling between ophthalmologists and ENT surgeons and neurologists. And nobody noted this huge knuckle on the medial part of her upper lid, which was connected with a dilated vein on the forehead. We got her venography done, and she had a superior sinus thrombosis. Bluish discoloration, rapid onset proptosis, and you see the bluish color discoloration. There is no cut mark, you can't see any injury mark, but this is suggestive of trauma. This is a typical salmon patch, temporal fullness. So you examine the neighbors. Who are the neighbors? The cranium, the size, sutures, and any other irregularities. You see cranial nerves 1 to 7, 8, 9, 10, 11, 12 are not so important from ophthalmological point of view. You need to do a sinus examination. So you see the nasal cavity, you see the cutaneous sensations, and you see the contour of the palate. The oral cavity, again, you see the palate and the mouth opening, and you have to examine the ear. I'll show you some pictures where the cranial signs were the giveaways. This boy has proptosis of his right eye. You see that the right forehead is fuller than the left. This was a typical patient of fibrous dysplasia. This little young boy had bilateral lesions. He was a case of bilateral Ewing sarcoma. Huge forehead mass, paranasal sinuses invading the orbits. Maxillary mass, secondary orbital tumor. This boy was unable to open his mouth. He presented with orbital cellulitis. An infected pinna in a case of orbital abscess. You see subperiosteal abscess here. So examination of the entire system is very important. You see skin lesions from neurofibromatosis, skeletal deformities in cases of secondary orbital tumors. So let's run through all the checkpoints. What are the checkpoints? Ensure that you have addressed all your P's. Right? You have checked your neighbors, and you have done a systemic involvement, evaluation. Right? Thank you for your patient hearing. And I will use this platform to invite you to Lucknow for the OPAI midterm one-day conference on 25th of June. Hope to see you all there. Thank you.
Thank you, ma'am, for that wonderful talk. Very patiently, you explained each and every point which are, important in the evaluation of proptosis. So just one question from my side. Sitting in the OPD, what are the clinical tests which you do to check whether there is a proptosis or in ophthalmos? Anybody? When you don't have exophthalmometer with you? And? Excellent. That's great. Okay, now we move on to the next talk, which is by Dr. Santosh Honawar. He needs no introduction. Under his dynamic leadership, I think this iFocus national level program has taken such a beautiful shape, I must say. I must congratulate him for this program. So he'll be teaching you about the CT and MRI, how interpretation you can do.
Thank you so
Over to
much.
you. Dr. Santosh.
Thank you. After such a lovely talk by Abhijit, I think it's one of the best proptosis evaluation talks. My job is very simple because I simply have to tell you what to look for in CT and MRI. Now let me keep this interactive. Let me ask you, if this patient were to be in front of you and this is the scan that you have, with a history of sudden onset drooping of the upper eyelid, I wouldn't say which eye, and extraocular movement restriction, sudden onset, what would be your diagnosis? Tell me which eye is abnormal, right eye or left eye? Right eye, why? Superior oblique, what happened to superior oblique? Superior ophthalmic vein, okay. So which one is superior ophthalmic vein? This one, right? That's the left eye. And where is the superior ophthalmic vein in the right eye? Can somebody guess where is the superior ophthalmic vein? This one, you think? Okay, so what is wrong with the superior ophthalmic vein? Dilated. Yeah? Okay, so what is your diagnosis? CCF, sudden onset ptosis in a patient who is slightly disoriented and he has ocular motility restriction as well. Ptosis, proptosis, ocular motility restriction, disoriented patient. No trauma. Can you say that, can you give that diagnosis from looking at the scan? Yes, you can, because this superior ophthalmic vein is enhancing with contrast. This superior ophthalmic vein is not enhancing with contrast, it is dilated. So dilated superior ophthalmic vein filled with contrast would be keratoconus or dural cavernous fistula. When a dilated superior ophthalmic vein is not filled with contrast, then there is thrombosis, which indicates that there is cavernous sinus thrombosis. So the entire diagnosis, which is a life-saving diagnosis, was possible just by looking at one coronal CT scan, nothing else. We didn't do anything else except just looked at it, and the diagnosis is right there, and that is the patient. She scratched the nose, there was a boil, and landed up with this complication. That is the dangerous area, right? So such a dangerous clinical situation, and you could diagnose just with one CT scan. Now what do you think is this? What do you think will this patient have? Pulsatile proptosis, right? Abhijit already told you that brain is something that inherently pulsates, and you can see pulsatile proptosis. And the diagnosis becomes very apparent when you look at the CT scan that the patient has dysplasia of the sphenoid wing, and that is the reason why he has the brain protruding encephalocele, which is causing this. Indication for imaging are many: unexplained proptosis of any etiology, neurogenic ptosis, ophthalmoplegia, palpable orbital mass, infection in the orbit, orbital trauma. All these are indications for MRI or CT scan, including eyelid and conjunctival tumors with orbital extension, and also intraocular tumors. So what do you know from MRI and CT scan? You know the exact location of the tumor or the lesion, extent of the lesion, effect on adjacent structures such as optic nerve is displaced medially here by this dermoid. You know that. You know the tissue composition because you know the Hounsfield value. Based on that, you can guess what tissue the tumor might be containing. You also know whether the lesion has extended elsewhere, and you come to a clinico-radiological correlation and a tentative diagnosis that will help you plan the surgical approach. So advantages of imaging are plenty. Now when you ask for a CT scan, if your professor says, get the CT scan for this patient, right? Do you order a CT scan or request a CT scan? You request a CT scan, right? So what all would you write in the prescription? One of you can loudly say. One, anybody who knows how to write a prescription for a CT scan can get up and say, or sit down and say, whatever. What all do you write in a CT scan prescription? Part, okay. Part? Okay. How many cuts? Then? Alright, so you more or less covered everything. So you have these many parameters that are to be mentioned when you request a CT scan or MRI. MRI, of course, slice thickness doesn't matter, but CT scan generally, slice thickness is important because for orbit, we have to do 2 mm cuts. And for optic nerve, 1 millimeter cut. Available range is 1 to 10 millimeter, and it really doesn't matter because now it is all spiral acquisition and the radiation exposure to the patient is not really high if you ask for 1 or 2 millimeter scans. But conventionally they may do with a 5 millimeter scan as for screening, and a tumor may be just 5 millimeter in the orbital apex and you will miss it between the two slices. So ideally for the orbit you need 2 millimeter scan. The next is contrast enhancement. Orbital fat itself is an inherent contrast, but at the same time, if you want to know whether the lesion is vascular and plan surgery, you should ask for a contrast enhanced CT scan. So looking at the clinical picture, if you feel that it is a vascular tumor, then you should definitely advise contrast enhancement. The next one is imaging plane, axial and coronal. Both are extremely important. Axial is, this is called orbitomeatal or the Reed's line. The inferior orbital margin joining the external auditory canal, the upper edge of it, it's called the Reed's line. Anything that is parallel would be axial scans. Coronal scan is not perpendicular to the Reed's line, but it is at an angle of about 75 degree. If you were to be perpendicular, then it will have artifactual shadows because of teeth. Teeth generally have fillings. Earlier they used to have metallic fillings that causes artificial shadows. So coronal is at about 75 degree to the Reed's line, and parallel to this would be coronal scan. So you should need both axial as well as coronal, and sagittal would be reconstruction. The next thing that you would ask for is whether you want a soft tissue cut, soft tissue window and a bone window, or both. Now in soft tissue window you see the soft tissues in all vivid shades of grey. You see the eye well circumscribed and the lesion is seen in shades of grey. Whereas in bone scan you find that the internal architecture of the bone is visible, but all the soft tissue is a mass of grey. You will not be able to differentiate the wall of the eye from the lesion and the internal architecture of the lesion. So if you are suspecting a lacrimal gland tumor, for example, with bone infiltration, you should ask for both, because you want to know the internal consistency of the lesion and its relationship to the extraocular muscles. At the same time, you want to know if there is any bone change or not. So soft tissue and bone window are important. The next is modifications of the procedure. If you feel that the patient has orbital varices, then while the scan is being done, the patient has to do Valsalva maneuver. Otherwise, patient lying supine orbital varices collapses and you will get a negative scan. Absolutely no information on that scan, right? So this is one such patient. And 3D reconstruction is important for trauma reconstruction. Currently, 3D reconstruction is used for many surgical procedures as well, mirroring, etc. So you definitely need 3D reconstruction. So what is the diagnosis here? 3D reconstruction. Quiz. Implant? I thought that's the eye. Which eye is abnormal? Right eye is abnormal. And what is that in the center of the right orbit? Implant. Because eye is missing in 3D bone reconstruction, and that's a solid implant which is very well done, and it is right in the center of the orbit. That's an anophthalmic eye with an orbital implant. Now 3D reconstruction is also important in patients who have a dermoid. This lady has a very small dermoid, but it is not moving at all. So to know why is it not moving, before we excised it, we did a 3D reconstruction, and you see that there is a small defect in the bone, and you can see an attendant defect there. So she has a small extraorbital component of this dermoid. If you were to excise it without doing this scan, you would have discovered it intraoperatively, that making it more difficult. And also if you were to leave this component behind, it will form recurrence and fistula. Then you can get the vascular tree as well. Okay, now you have requested for a CT scan and the patient has come back with a film or a CD. What all do you look for? These are the components of a CT scan. Some of the information is important, some of the information is not important. But before you begin, you have to always match the patient data with the scan, so that sometimes it does happen that the scans get exchanged in a busy radiology facility. You should look at the patient data. Then these are some of the information that you have. This is called window width and window level. I'll come to that. Slice thickness is also mentioned as a parameter. Here it is 2 millimeter. Then whether contrast or plane is also mentioned in the scan. Plane does not come with a label, but contrast comes with a label, which is C, or they will say contrast CT. Now laterality is important. This patient has an older generation CT scan where coronals used to be transversely flipped. So this patient has a right orbital lesion, but on the coronal it looks as if he has the left orbital lesion. This is true with older generation CT scan machines, but currently that doesn't happen. Now this is the axial scan orientation. When you have a film in front of you, in front of a viewing board, you will find the scan looking exactly like this. So how are the scans arranged? Scans are arranged always from bottom to top. So there's a lot of air here, that is sinus. There's a lot of gray tissue here, that is brain. So it's always arranged from bottom to top, and this is called the scout film. There are parallel lines here, and if the tumor were to be here, so for example, if the tumor were to be here and the scout film would have lines only at the bottom of the tumor, that means that it has not been completely imaged. So you should always start looking at these parallel lines and see that these parallel lines cover the entire area of your interest. And rest of the scans are arranged from bottom to top, from the first parallel line to the last parallel line, in that order. That is the axial scan orientation. Now let me show you some typical axial scans. This is a normal lower axial scan. So what is this structure? Nasolacrimal duct. And what about this? Inferior orbital fissure, and that is the eyeball, and that's the maxillary sinus. So you see all this in normal lower axial scan. And mid axial scan, what about this? Superior orbital fissure, and that is optic canal, that is sphenoid sinus. And you see medial rectus, you see lateral rectus, you see the optic nerve, you see the lacrimal gland, and you see lot other structures in normal mid axial scan. This is normal upper axial scan. You start seeing a structure that crosses over like that. That is the superior ophthalmic vein. You see superior rectus LPS complex, you see the orbital lobe of the lacrimal gland, and lot of brain. Now coronal scan orientation is always from anterior to posterior. Again start looking at the scout film, and this is the anterior most and that is the posterior most. Again looking at normal anterior coronal scan, you find that the superior oblique is here, superior ophthalmic vein would be here. This is superior rectus LPS, medial rectus, orbital lobe of the lacrimal gland, lateral rectus enmeshed there, inferior rectus, and sometimes you see the inferior oblique as well. That is the ethmoid sinus, and that's the maxillary sinus. And you can also see the infraorbital nerve canal in many of the scans. Now normal posterior coronal scan shows, what is this? Inferior orbital fissure, and you see rest of the extraocular muscles and a big maxillary sinus. Most important cut is coronal scan through the orbital apex. You see the sphenoid sinus, you see the inferior orbital fissure, you see the superior orbital fissure, and you see the optic canal. Disparate size of the optic canal indicates that there is possibly optic nerve enlargement, such as optic nerve sheath meningioma increases the size of the optic canal through which it passes. These technical parameters may not be important, but most important information that you want from a CT scan would be Hounsfield value. So unless you ask for it, the radiologist will not give it. So in your CT scan prescription, you should mention that you want Hounsfield value, and if it is contrast, you should mention I want pre-contrast and post-contrast Hounsfield value to know how much is the enhancement. If Hounsfield value doubles post-contrast, that means it is strongly enhancing. If it only increases by about 50 to 75% or 100%, that is mild contrast enhancement. Less than 50, moderate contrast enhancement. Less than 50% is mild contrast enhancement, and there is no change in Hounsfield value, then there is no contrast enhancement. That shows the vascularity of the lesion. Now what is important for you to realize is that air has minus 1000 Hounsfield value. So air would appear jet black, bone would appear pearly white. In between that, there are a lot of other tissues that have different Hounsfield values. Soft tissue Hounsfield value ranges from 30 to 40. Blood, depending on how old it is, ranges from 70 to 80. Metal foreign bodies about 300 Hounsfield units. So air is jet black, bone is pearly white, and rest of the Hounsfield values are somewhere in between. So there comes the value of window width and window level. Now window level is the midpoint on either side of which window width is distributed. Example, here window level is 50, so you mark 50 here, and window width is 100. Across 50, 100 is distributed, so 0 to 100 is the Hounsfield value, and the grayscale is depicted to that extent. So you see the internal architecture of the tumor, because we realize that soft tissue Hounsfield value ranges from 30 to 40. So internal architecture of the tumor and the difference of the tumor from the eyeball are vividly described or shown if you have a soft tissue window with this window width and window level. You don't have to specifically mention which window width and window level you want. Radiologists have their own settings, but just for you to understand that wider the window width and broader the window level, worse is the soft tissue view on a CT scan. Alright, so how to read a CT scan systematically? You need a viewing box, you need a divider and a scale to measure. You start with the bone, then you look at the eyeball, then you look at the extraocular muscles, then the extracorneal tissues, intracorneal tissues, and finally cellular and paracellular lesions. So all this you have to look at dimensions of the orbit, orbital walls, apex, superior, inferior orbital fissure, and the optic foramen. Let me just ask you some, show you some pictures, typical pictures from the exam point of view, and ask you what you feel is the diagnosis. What do you think is this? Which orbit is abnormal? Left orbit. So what is wrong with the left orbit? What happens to the medial orbital wall? Abhijit said it is absolutely straight. Is it straight on the left side? No, it is bowed internally. And what is happening to the medial rectus muscle, which is supposed to be straight and following the course of the orbit? It is bowed in there. So there is a medial wall fracture and the medial rectus is simply bowed into it. So it's a medial orbital wall fracture and an ethmoid sinus fracture that this patient has. What about this? Teardrop sign caused by fracture of the floor of the orbit. You can see a protrusion of soft tissue content into the orbit. That is the inferior rectus muscle which follows the curve of the orbit. Now the inferior rectus is distorted and it is found in the maxillary sinus. What do you think is this? Coronal and axial of the same patient, where paranasal sinus is involved. Ethmoid sinus is full, but in an addition there is something which is protruding into the orbit, which is nothing but a subperiosteal abscess. So this patient has purulent ethmoidal sinusitis with a breakthrough into the orbit, which is subperiosteal abscess, and these patients need drainage. Coming to the eyeball, what do you think is this? Bilateral retinoblastoma. So what is wrong with the left eye? So what is wrong with the right eye in addition to retinoblastoma? There is soft tissue edema you see here, isn't it? So possibly this patient has aseptic orbital cellulitis resulting in necrotic tumor, and that is the reason why he has eyelid edema as well, whereas the left eye eyelid is absolutely flat. What do you think is this? Smaller eyeball on the left side, but the optic nerve is thickened and this calcium is intraocular. Now how do you differentiate it from phthisis bulbi because of trauma versus phthisis bulbi because of retinoblastoma? Very simple. In phthisis bulbi because of trauma, there is dystrophic calcification which is in the coats of the eyeball. Suppose calcification were to be here in the coats of the eyeball, which is sclera choroid, then that is dystrophic calcification following phthisis bulbi because of whatever else is the etiology. But if you find calcification right within the core of the eye, vitreous cavity, then that is most likely retinoblastoma. That's how you differentiate in a phthysical eye. What do you think is this? That is bilateral choroidal osteoma. What about this? Drusen, optic disc drusen. And what do you think is this? Foreign body. Left eye, pseudophakic. Right eye, total cataract. This is Cogan's plaque. Absolutely right. That's a Cogan's plaque. That is calcification of the extraocular muscle insertion in an elderly patient. Cogan's plaque. So that's one more example of a patient with bilateral Cogan's plaque. What do you think is this? Foreign body with reverberation echoes. In extraocular muscles, we look at the configuration of the muscle to make a diagnosis and also whether the insertion of the muscle is enlarged or not. What do you think is this? Thyroid eye disease. So obviously this patient has bilateral extraocular muscle thickening with tendons sparing. In thyroid eye disease, you also need to know what is Barrett's muscle index. That is the proportion of superior rectus plus inferior rectus thickness divided by the interorbital distance in that area multiplied by 100. And it can also be calculated horizontally by doing the same for medial plus lateral rectus and interorbital distance, medial to lateral wall, divided by 100. And if it's more than 67%, that means that the patient has a high risk for dysthyroid optic neuropathy. And what about this? Inferior rectus is thickened, but look at the thickness. It is extending right up to the insertion. So this is possibly myositis. This patient also has exactly similar picture, but is beyond the age group for pseudotumors or orbital inflammation. He is 80 plus and he has solid chemosis of the conjunctiva as well. Okay, so this patient has a lymphoma of the extraocular muscle. And whenever you biopsy along the axis of the lymphoma. What about this? Thickened extraocular muscle with a nice cysticercus sitting right in front of it, in the middle of it. So that is myositis because of cysticercosis. In optic nerve scans, of course, you have to ask the radiologist for an optic nerve scan. Optic nerve scan is always taken in an oblique direction like that to get the entire optic nerve. Otherwise, when you take optic nerve scan like this, since the optic nerve has a kink, part of the optic nerve may go missing. So you have to mention whether you want a good optic nerve scan. And here you see that the optic nerve is thickened on the left side, indicating that there is optic nerve infiltration by retinoblastoma. Now, what about this? Tram track sign. That is optic nerve sheath meningioma. So you see the core of the optic nerve here and followed by tumor on either side, which exactly looks like a tram track in Calcutta. Okay, now what do you think is this? This is called tenting of the optic nerve or vertical stretching of the optic nerve. This is called stretch neuropathy in thyroid eye disease. What happens because of intraorbital content being under a lot of pressure, optic nerve gets stretched and there is coning of the eyeball. So if this angle is about less than 120 degree, that means that there is some amount of stretch neuropathy, and when it becomes critical like 90 degree, then the stretch neuropathy is imminent to cause optic nerve dysfunction. So as long as it is about 150 to 180 degree or 120 degree, you are not okay with it because there is no stretch neuropathy. The moment this coning, which is measured as an angle between the medial wall of the eye and the lateral orbital eye, becomes less than 120 degree and approaches 90 like this, see it's almost 100 degree and you can see consequent stretching. It's almost 100 degree consequent stretching, whereas in the other eye it is almost nice and rounded, 120, 140 degree. So that's stretch neuropathy. Intraconal tissues, this is dilated superior ophthalmic vein indicating keratico-cavernous fistula. This I already showed. Cellular and paracellular lesions are important. That's a cavernous sinus lesion. In MRI, very quickly, T1 and T2 you need to differentiate. T1 vitreous appears black, T2 vitreous appears white. That's how you want to remember. And both these can come with fat suppression. That means intraconal spas, which is supposed to be white, can become black when you fat suppress it. T2 with fat suppression, again this intraconal fat is grey, that can become black. That helps you differentiate the internal structure. And coronal and sagittal with the same. So basically you remember in MRI, T1 indicates anatomical details and T2 indicates pathological details, and you simply can take a picture of this. Most of the lesions are hypo on T1 and hyper on T2 except metastasis, except melanoma, which is hyper on T1 and hypo on T2, and hematoma, depending on the age of the blood, can be hyper on T1 and hypo to hyper on T2. Calcification is both hypo on T1 and T2. So that is the tissue characterization on MRI scan. MRI is better than CT for many reasons, but primary indications of MRI would be optic nerve lesions, orbital apical lesions, any neurological lesions which you suspect, neurological visual field defect, etc., sudden onset cranial nerve palsy, any intracranial lesions and congenital lesions are primary indications for an MRI. It gives much better morphologic and metabolic information. So in conclusion, I would say that CT scan and MRI are extremely useful imaging tools. Decide CT versus MRI based on clinical correlation or clinical differential diagnosis. You have to set appropriate parameters and request CT scan and MRI with appropriate parameters so that it will help you differentiate. If you want more information, we have 2 articles on MRI, part 1 and part 2 in IGO, both of which are very detailed. You can read it. These are review articles with a lot of pictures. You'll easily understand this. This is in the recent issue of, recent in the sense last year's issue of IGO. October, November, one issue, both the articles were carried. And 20 years ago, we had written a similar article on interpretation of CT scan, which is still used. And my lecture is based on, part of it is based on this particular review article. This is again very useful. This was written in 2002 by one of my fellows, Dr. Nayak, who was a fellow at that time. So this is a very useful article where the entire interpretation of CT scan is described, and not much has changed beyond this in terms of interpretation of CT scan. MRI, whatever that is recent, is given in the last 2 review articles. Thank you so much.
Thank you, Hello. Thank you, Santosh, for the very elaborate talk. I now invite Dr. Kasturi. She's heading the Department of Orbit, Oculoplasty and Aesthetics at the Sri Shankar Deva Netralaya, Guwahati. And Kasturi will be speaking on blepharoplasty and overview of periocular aesthetics.
डायरेक्टली कनेक्शन करने से हो जाएगा. Is it okay? It's coming? Respected chairs, at the outset I'd like to thank Dr. Santosh for having me here, and Rolika and all the team CFS. So I'll be talking something little light, something different from the serious stuff that you have been hearing since morning. So today we'll discuss basically the concepts of in blepharoplasty and a little bit about the periocular aesthetics, so no financial interest. So let me start with a definition where we say that blepharoplasty is a surgical procedure where variable amount of the skin, muscle and fat are either being excised or redraped or sculpted. It has come from the word blepharon, which means the eyelids, and the plasticos, which means to mold. So today is the most time-tested surgical procedure having both cosmetic and aesthetic indication. So let me ask you, how many of you think it to be more of a functional indication, and how many of you think that it has got only aesthetic indication? So hands up for the functional indications. So very few, around Ferus, it's at least accepting it has functional indication. And aesthetic, so rest all of you aesthetic. So now let's go briefly into this. So my earlier speaker today has mentioned that with the improved quality of lifestyle, there has been increased in the longevity, and what we see that we also see the senile disease. And one of the most common condition that we see in the eyelid is dermatochalasis, and blepharoplasty has today become one very common indication for dermatochalasis. So what are the indication? Basically the functionals more of a dermatochalasis and epiblepharon. Why dermatochalasis? Because we get the lateral hooding. And why epiblepharon? Because we get the lashtosis. And there are very limited aesthetic indication. Basically, I should say there are only 2 aesthetic indication and 5 functional indication. So let me go to the functional indication. It has been reported that this dermatochalasis, where they have a redundant and overhanging skin, it definitely affects the quality of vision and definitely quality of life. How? It is by reducing the peripheral field of vision, where if you do a 60-4, you will definitely see, which we have already published in the Indian Journal of Ophthalmology. So not even that, there has also been reports that because of dermatochalasis, there is decreased in the contrast sensitivity. It also affects the corneal astigmatism, and also there is also change in the high order aberration. So because of the diffraction and the refraction caused by the lateral hooding, there are changes in the high order aberration, and the most common being the coma, where we have also published that definitely decrease in the high order aberration in patients having dermatochalasis before or after the surgical procedure. And it has also been reported that severe dermatochalasis is associated with altered corneal biomechanical properties, as has been measured by ORA. So these are some of the functional indications where we need to do a blepharoplasty for a dermatochalasis. Number 1, when there is a reduced visual field. Number 2, where the contrast is affected. 3, where there is affection of the high order aberration. And the fourth most important is the dry eye. So what happens when there is a lash ptosis because of epiblephron or because of dermatochalasis? It leads to a continuous irritation of the ocular structures, so release of the inflammatory mediators, and the most important is MMP9. In fact, we have done a study where we have tested the MMP9 before and after doing a blepharoplasty in dermatochalasis, and we have found a definite reduction in MMP9 following a surgical procedure. So what it does, because of all these inflammations going on, it increases the osmolarity and it leads to hyperosmolar state, and so the vicious cycle keeps on going it. So if you do this blepharoplasty, definitely quite a good amount of the dry eye is also being reduced. So what are the aesthetic indications? So aesthetic indication is basically to redesign the single lid fold and to convert it into a double lid fold. So this is a very common aesthetic indication, like if you attend the international meetings today all over the world, in any of the plastic meeting, this is the main highlight of all the meeting, that how do we do a very perfect Asian upper lid blepharoplasty. So this is what this is a common indication where a single lid fold is converted into a double lid fold. And the second most common aesthetic indication is the TPS, that is the tarsal plate show. This is what we say, the tarsal plate show. When you have a single lid fold or a very small crease, we do not have a good tarsal lid fold. So we need to have a tarsal lid space. So this is known as the TPS. So we need to increase the TPS, and also we need to give a good eyelid crease. And secondly, a combination of both functional and aesthetic in a situation like this, where you have the lash ptosis, you need to do the blepharoplasty not only to give a lid crease, but also to redirect the eyelashes. So these are some of the indications of blepharoplasty. But let us go to the zonal approach to the indications of blepharoplasty. If we divide the lid into three components, we have the central, we have the medial, and we have the lateral zone. So the central zone indications are basically, number one, to have definitely a lid crease in those who have an Asian eyelid configuration. Number two, if there's skin excess, you need to remove the skin. If there's volume excess, you need to remove the volume. And if there is associated ptosis, you need to do the ptosis surgery. And the medial zonal approaches are basically for when there's a nasal fat pad herniation. Many times we get hollowness in the medial part of the eyelid, where you need to transpose or transfer the medial fat to the central fat to the medial fat, and when there is a epicanthal fold. And the third, the lateral zone indications are basically in case of lateral hooding, in case of brow ptosis, in cases of lacrimal gland prolapse. So what are the markings? So the most important point in doing a step in doing a blepharoplasty is the marking. The marking is always a rule of 10. That means when you draw this marking from the lash line to the lower part of the marking should be 10 millimeter. From the eyebrow to the upper part of the marking is 10 millimeter. So we need to keep 10 millimeter of this, otherwise there will be leg of tumors post-operatively. Or if you see a very elderly patient with the skin very lax, we can keep, instead of 10, we can also go up to 8. So maximum 18 millimeter of the tissue of the upper lid must be there in order to prevent the postoperative leg of tumors. So this is the surgical procedure. As I have already mentioned, you first need to mark the lid crease. First you mark it approximately, in Indian we keep it 10 millimeter, but for Asian you can keep it even 8 millimeter, or also for the males you can go to up to 12 millimeter. So this is how we mark the incision. Following marking the incision, the first layer of the eyelid that we remove is the lid skin. Then we remove some amount of the orbicularis, because we find that especially in Asians or Northeast, we find that it is very thick, the whole of the upper lid is very thick. And next you need to remove titrated amount of the fat pad. So how do we identify the fat pad? You need to expose the orbital septum. You need to make an incision on the orbital septum, and basically in the upper lid we have got two fat pads, right? One is the central, one is the nasal. And when you look to the lower lid, we have a 3 fat pad, and sometimes we call 4 fat pad, because we have also a superficial fat pad in the lower lid, which is known as the Aschner's fat pad. So in the upper lid we have basically 2. The white is the nasal, because embryologically it has developed from the neuroectoderm. And the central is reddish in color because it is from mesenchyme. So white nasal is basically a stem cell, and that is what we see the lifelong. We see that the medial fat bed keeps on enlarging, whereas the central fat bed, it does not enlarge. So once you excise titrated amount of the fat bed, next you need to do a lead crease formation suture. There are different ways, as Dr. Santosh has already mentioned. If you want to have a dynamic lead crease, then in such situations, especially those patients who already they have a lead crease. So these are the patients where you have to go for orbicularis, LPS orbicularis. But if you want to give a very static, then you need to suture the LPS to the skin. And then the skin closure is always the monofilament. Either you use a proline or you use a PDS. Advantage of PDS is that it gets absorbed, and the proline suture you need to remove it. But always remember, we prefer to use a monofilament for the skin suturing because you do not want to have any scarring, you do not want to have any infection. So end point of the surgery is slight eversion that you have seen here. Is a slight eversion. Like if you see here, this is the operated eye, this eyelashes are everted, and you see this is unoperated, it's still straight. So that is the end point of the surgery. So when we look to the blepharoplasty combos, like as I had already mentioned, the central, these are the main indications zone-wise, the lead crease, skin axis, volume axis, and the ptosis. And when you have ptosis, there are two ways of doing a surgery. One is definitely from morning you have seen LPSR, which is a very common surgery that all of us do. But when you have a minimum amount of ptosis, this is how we do a molar muscle conjunctival resection. This is a very simple procedure. Very often we do combine with a blepharoplasty procedure, because you see every elderly, when they come to a room, when you give a dilatation drop to see the retina, most of the patient you see the lid appears little retracted, the eyes look bigger, because with age also the molars becomes weak. So if you have a positive phenylephrine test, then you need to do a MMCR along with a blepharoplasty surgery. So this is a very easy way. This is a posterior approach. Basically we know there are three posterior approach surgery. One is the posterior wide line advancement, other is the Fasanella servat, and third is the molar muscle conjunctival resection. So this is a surgery which we usually combine with the upper lid blepharoplasty in elderly patient having a positive phenylephrine test. And this is the PDS suture, or you can also use a cat gun. And once you put a double layer suture, then you need to excise it. And usually I use the 15 blade that we use it for the phaco surgery. And then you excise it and you exteriorize the suture, and then you see how much amount of the molars conjunctiva you have resected. For every 4 millimeter of MMCR resection, you correct 1 millimeter of ptosis. This is how you see the patient before and after the operation. And if the patient has a weak LPS, then you have to do a LPSR. So in situation like this, when medial zone, the most common indication is the epicanthal fold. And what is the pathology behind the epicanthal fold? This is basically a redirection of the preseptal orbicularis, where instead of inserting into the MCT, it inserts into the skin. So this is because of the whole vector gets changed. Normally we know the orbicularis has got a two part, right? The palpebralis and also the orbital part. So what happens, this palpebralis part, which is above the septal region, instead of being inserting into the MCT medially, it gets inserted much anteriorly, and this leads to a different types of the epicanthal fold. And this is what we see. This is the preseptal orbicularis gets inserted, and because of the change in the vector, we get the four types. Can anyone of you tell me what are the four types of the epicanthal fold? Do you know that? Okay, one is the epicanthus superciliaris, where you see a fold coming from the eyebrow down to the lacrimal sac. The second is the epicanthus tarsalis, where you see the fold coming from the upper tarsal plate to the medial canthus. Third is the epicanthus palpebralis, where you can see the caruncle very well, but it comes from the tarsal plate down to the lower orbicularis muscle. And then we have the epicanthus inversus, which we see in blepharophimosis syndrome. So what happens here, normally, as I have already mentioned, the preseptal orbicularis inserts into the MCT, But what happens in some situation, instead of inserting into the MCT, it inserts much anterior to the skin, and along with it there is lateral expansion of the MCT, and this gives the different kinds of the epicantral fold. So the surgery is basically designed to redirect it, and we need to stitch the skin to along with the excision of some amount of skin orbicularis tissue, and then we need to place the this orbicularis in the proper position. So based on the lengthening of the medial canthus, we divide the epicantral fold into mild, moderate, and the severe. In the mild, you will see a skin coming here, but always the caruncle is seen. In the moderate, you may or may not see the caruncle, but in severe, the caruncle is always absent. So the best way of managing the epicantral fold is a Uveitis. What you do, you design it in the form of a V, excise the excess amount of skin and the subcutaneous tissue, plicate the MCT, and suture it in the form of a V. So it is called the Y incision, and then you convert into V by excising some amount of the excess skin and the subcutaneous tissue, and this is what you see, the plication of the MCT. And then you suture it, as you can see here, it is being sutured in the form of a V. But the most common surgery that we are doing today, or which is internationally recognized, is a Z-plasty. And the other name of the Z-plasty is known as a re-dripping technique, where you need to mark the 4 classical points. The point 1, where you try to push the medial canthus where exactly medially how much amount you want to come. The point B is at the apex of the epicantral fold. The point C is just 2 mm medial to the lecus lacrimalis, and a point D which lies along the subciliary line. And in case you have some amount of epicantral fold superiorly, you need to put a point E. And then once you join all these 4 points, this is the Z that you have been creating, and this is the surgery how you do. So the point A is where I want to push my medial canthus. The point B is the highest point of epicantral fold which is already present. Point C is 2 mm medial to the lecus lacrimalis, and a point D is along the inferior line which goes along the lower lid. So once you mark these 4 points, you cut the 4 points, excise some amount of excess tissue. If you find a long MCT, you need to plicate and shorten the MCT, and then you do not need to excise the skin because it gets re-draped. Because it gets re-draped without much excision of the skin, that's why we call it a re-dripping technique. So this is a very common surgical technique for a medial canthal, for epicantral fold, which is also known as a Z-plasty or a medial canthoplasty or a re-dripping technique. So, and especially when you have a epicanthus inversus in a situation like blepharophimosis, then you need to be more challenging. So these are the situation where we do a Masadi Z-plasty, where along with the YV-plasty, you make 2 additional flaps at 60 degrees to each other. Once you make the flap, excise some of the subcutaneous tissue, and as I've already mentioned, the grade of the epicantral fold, mild, moderate, severe, these are the patients who usually have a 5 mm or more lengthening of the MCT if you measure from the lecus lacrimalis. So here you need to shorten the MCT, and once you shorten the MCT, you transpose the flap and you suture the flap, and you will see a much better correction. So you can see the Z got transposed in, and this is how you transpose and suture the flap, and this is what we do for a blepharophimosis syndrome, and you get the adequate good correction. So what is the next in the lateral zone? I have already mentioned the indications are the lateral hooding, when you have an excessive orbicularis contracture or a proptosis, or when you have a lacrimal gland prolapse. So these are the situation where along with the blepharoplasty, you need to reposition the lacrimal gland, and this is done very nicely. Once you cut the orbital septum, this is a gland that you can see, and this yellow is the fat. So you try to push and see, and it is usually advisable to push it as deep as possible, and then you use 2 types of suture. Many people use Prolene, but I prefer using polyester because it doesn't cut through the periosteum. Sometimes in the long run we find that it cuts through the periosteum. Can any one of you tell me what is the most common cause of lacrimal gland prolapse? Where do you see a lacrimal gland prolapse? Involutional, okay, no. Anyone else? Blepharochalasis, right? So invariably these patients, many of them will have a blepharochalasis. So you do a blepharoplasty along with repositioning of the lacrimal gland prolapse. So once the lacrimal gland is prolapsed, you excise titrated amount of the fat and then you close the suture. And this is what you see before and after the surgical procedure. And if you look from the side, this is, you can see the thin skin of blepharochalasis and the gland being prolapsed, and this is after the procedure. But when you have something called a droopy hood, when we see the whole of the lateral region has been drooped down, these are the situation where you need to do a extended blepharoplasty. Everything is same. When we do a aesthetic blepharoplasty, we do not give the incision beyond the lateral limbus, or maximum we go to the midpoint between the lateral canthus and the lateral limbus. But here we go just beyond the lateral canthus, we go to the lowest point of the droopy hood, and so it is called the extended blepharoplasty. And then the rest of the steps are same that I have already shown you, and you get all details in this article which we have already published in the Indian Journal of Ophthalmology in 2017. So these are some of the patients. If you look very nicely here, you can see the incision goes much lateral to the lateral canthus. So these are the situation where when we have a droopy hood, so blepharoplasty is an indication not only to increase the temporal field of vision, but also to give a aesthetic correction. And sometimes when they have a brow ptosis, we can do on the table along with blepharoplasty, you can do a internal browpexy, or you can do a external procedure which is known as the external browplasty. Internal browpexy is something very simple, where all this, the roof, that is retroorbicularis oculi fat, along with the subcutaneous tissue, you push it and you suture it with a 5-hour Polytech or a 5-hour Proline to the periosteum so that it doesn't come down. This is basically a temporary procedure which lasts for a maximum 3 to 5 years, but the external browplasty, where you need to cut some amount of skin above the brow, is a more permanent procedure. So these are some of the lateral zone indication for doing a blepharoplasty. Now we know about the upper lid blepharoplasty. So we know there are 4 functional indication, 2 aesthetic indication. Functional is increase the peripheral field of vision, improve the contrast, decrease the high order aberration, decrease the corneal astigmatism, and also the dry eyes. Aesthetic is to the lid crease, and number 2 is the TPS, to improve the TPS. Now let us go to the lower lid blepharoplasty. When we talk about the lower lid blepharoplasty, we know that it is basically to remove the fat. But before removing, you should know to differentiate whether it is only fat, a combination of fat and fluid, or only fluid. So you ask the patient to look straight, and then you ask the patient to look up, and then followed by asking the patient to look down. So when the patient is straight, you can see this bulging here, right? When she looks up, it becomes more prominent. And when she looks down, it has not disappeared. That means this is a combination of both fat and fluid, okay? Look at this patient. This patient is looking straight. When she looks up, it is prominent. When she looks down, it is almost gone. That means this is more of a fat, okay? When we look down, the orbital septum contracts. So it pushes the fat back, so the fat bags are not very prominent. So before taking up the surgery, you should be sure whether it is a fat or a fluid. And all these changes, all these periocular changes, is basically the conversion from a positive vector to a negative vector. So the question is, what is a positive vector? Anyone can tell me? Okay, so when a very simple way of knowing what is a positive vector is when we have a malar eminence much anterior to the plane of the corneal plane, this we call it positive vector. But when we age, what happens? The maxilla is retruded. So what happens? The malar eminence goes much behind the plane of the corneal plane. So this is known as a negative vector. So as Dr. Abjit had already mentioned how the pyramidal shape of the orbit, what happens with aging, the shape, the pyramidal shape, the asymmetrical pyramid that we have, it changes into more of a square type. And this is because of a differential bone resorption, where because of gravity, the superior and the inferior resorption is much more, and then because of this resorption, there is lateral expansion. So the orbit becomes more squarish, along with the soft tissue changes. All this leads to the negative vector. So what are the signs of the negative vector or the aging change that we have? Number 1 is the eyelid bags, which I have already mentioned. Number 2 is the malar mounds and the festoon. Number 3 is the double convex deformity, which is formed by the bags and the festoon. Number 4 is what you see here is basically the horizontal lid laxity. Number 5 is the dermatochalasis. Then what else do you see? We see a prominent tear trough and then the periocular skin rhytidosis or the wrinkles. So you can write these are the periocular aging changes that we see as we age. So once you have all these changes, then how do we treat it? Our intention is to do a blepharoplasty and you treat the lower lid bags, right? But do we treat all the bags? No, it can be managed conservatively. Like if you have a patient, if you have the fat bags, which is much behind the plane of the anterior lacrimal crest, or you see this fat doesn't go laterally, this can be managed even conservatively by injection dermal filler, non-operative way of correcting the fat bag. But if you have the fat bag, which is very prominent, and this fat bag, along with the lengthening of the lower eyelid, and you see the fat bag much anterior to the plane of the anterior lacrimal crest, these are the situation where the dermal filler will not help you. You have to go for a lower lid blepharoplasty. There's a very interesting paper by Fessa et al. Where they have mentioned that as calculating the length of the lid, if the lower lid is less than 13 millimeter vertically, then you can go for directly fat excision. But if it is medium, between 16 to 19, you can go for fat excision during the blepharoplasty procedure, but you have to augment it by injection dermal filler. But if it is too much of lengthening, more than 19 millimeter, then along with the fat, you need to do a very good effacement of the lid cheek junction by transferring or transpositioning of the fat, where the fat, your own fat, is being used as a filler. So I'll just show that basically when we do a lower lid blepharoplasty, one is through the conjunctiva, the other is through the skin. So the transconjunctival blepharoplasty is what we usually prefer. As I have already mentioned, the upper lid has got 2 fat pads, the lower has got 3, and the 4th is the H nurse, which is a very superficial fat pad. And amongst the fat pad in the lower lid, the central is very superficial, the medial and lateral are quite deep. So you give a nice transconjunctival incision, try to expose the orbital septum, then give little bit of anesthesia so that it doesn't, and most of the surgery we do under local anesthesia. Then you make a nick on the orbital septum till you see the fat coming out. Once you have all the 3 fat bags, just design it in 3 flaps. The longer the flaps, it is better. Try to maintain the fat pedicle, but you have to be very sure of a very important structure that lies between the medial and the central fat pad, which is the inferior oblique muscle. So this muscle you cannot injure during the surgery, otherwise you'll have a post-operative diplopia, whether you do through a transconjunctival approach or through a transcutaneous approach. So once you have the 3 fat pads, and these are the 3 pedicles, and these pedicles will now be transposed. And this is same like the concept of using a dermal filler. Instead of using a liquid filler, we are using a fat filler, and we are trying to fill up the tear trough, and for which you need to release the ligament, which is known as laterally orbitomalar ligament, and medially it is known as a tear trough ligament. This is a true ligament. It is a osteocutaneous ligament which arises from the periosteum and inserts into the skin. So you have to release the ligament in order to transpose this orbital fat deep down as far as possible, as beyond the maxillary region up to the nasolabial region. So once you transpose it, and then you fill up, and you post-operatively you'll see a very good effacement of the lid cheek junction along with the removal of the fat bags. So nowadays we try to preserve the tissue. We do not want to excise the tissue, because too much of excision after 10-15 years you will see the prominence of the tear trough and you will see too much of hollowing. So once you are done with this, and this is also, we had published a review article in the Indian Journal of Ophthalmology. You will get all information, all indications, contraindications and complications, where you can see a definite conversion of this negative vector to a positive vector following the lower lid blepharoplasty along with the transposition of the fat. So other approach is the skin approach. This is a transcutaneous approach. So this is the same procedure where you go to the skin. One advantage of the skin approach is that you can also do a mid-face lift. What? Because we have very important structure known as SMAS. Can any one of you tell me what is SMAS? Submuscular aponeurotic system. So this mass can be lifted, which lifts the whole of the face along with the simple procedure of the lower lid blepharoplasty, which is inserted around the eyelid to the orbicularis muscle. So along with this muscle, along with this orbicularis and along with the SMAS, I don't know whether I have shown it here. Yeah, this is the SMAS. Can you see? You'll see this whole region is a SMAS orbicularis where you need to separate deep down, and then you can suture it a much higher height, and this will give you a very good mid-face lift. So these are some of the patients before and after the operation. And when you have a laxity of the lateral canthus, there are two ways of doing. One is internal, the other one is external. What is the internal? Internal is very simple. It is a basilar canthopexy where you need to pass a suture through the lateral lower crust of the lateral canthus, and you suture it at a much higher height. And externally, you need to make a canthotomy and you need to expose the lateral canthus. Then you either placate it or you cut it and you suture it, trim it, and you suture it at a much higher height. So these are the two ways of managing the lateral canthus, and which can be done with a lower lid blepharoplasty. It is not that this doesn't have complications. There are lots of complications. You'll get it in all the textbook. And also one major complication, especially in the lower lid blepharoplasty, can be a orbital hemorrhage and loss of vision. So it's very essential that whatever bleeding that you get, because you know the blood vessels, it retracts when it goes inside the fat. So you should be very careful when you excise the fat. You should cauterize it very well. A little very shortly about the periocular aesthetics. It basically includes the four which we, like what we oculoplasty surgeons are doing. One is injection botulinum toxin type A. Second is a dermal filler. Third is a facial thread. And the fourth is a facial and a periocular laser. And we all know that Botox has come from the word botulus, which means a sausage. It has been derived from Clostridium botulinum. This is basically a purified exoprotein. There are 7 different types. And if you look here, when you do any of this periocular rejuvenation, you should have a very clear understanding about the muscle, because most of the muscle are interlinked. The whole muscle of the face, the upper face, the mid face, and the lower face. Like if I stop it here, if you look to the muscle of the face, this is a muscle for of the upper face. The only elevator of the eyebrow is one, that is a frontalis muscle. The rest, all the orbicularis, the procerus, and the corrugator, these are the depressors of the eyebrow. Okay? This middle face are the elevators of the face. So they are known as a smiling group of muscles. And the lower muscles are the depressors of the face. So they are known as a sad group of muscle. And when we make any expression, like if you look here, any expression you make, all the muscles are interlinked. Like when you see this lady smiling, what you will see, you see, okay, see this has a sad face. You can see the eyes look smaller. This is being pulled down, this is being pulled up. So this group of muscles are all interrelated. And even if you make an expression, like if you make an expression of being happy or surprised, what you will see, the eyes will open up. Like here, if you can see the eyes open up, why I want to show you, you should always remember that this are the muscle where is responsible for elevating the eyebrow. So many indication you cannot touch this muscle. These are the muscle were responsible for closing the eyebrow. So whenever we give a botulinum toxin for a blepharospasm, what happens? The muscle activity decreases. So we get a leg of thymus, right? These are the levator labii elegans, levator labii superioris, zygomaticus minor, and the major. These are the 4 happy group of muscle which pulls the lip. So if you touch, while giving a botulinum toxin, if you touch any of this muscle, the activity will go down and it will give a lip ptosis. It will give a mid-face ptosis. And this lower group of muscle, the sad group of muscle, their aim is to pull it down. So these three muscles, the mentalis, the DAO, depressor angularis oris, and the depressor labii inferioris, these three muscles are basically the sad group of muscle. So every muscle has an agonist and an antagonist. So coming back to the botulinum toxin, if you look here, basically we know it has a heavy chain and a light chain. The heavy chain, what is it? It binds to the presynaptic membrane of the nerve terminal. But the most important work is done by the light chain. It is a light chain which enters inside by a process of endocytosis, and then what it does, it breaks the snare group of protein. You know there are basically three snare group of protein. So the SNAP25 is the most important. So this will lyse the SNAP group of protein, and then it will prevent the release of the acetylcholine. So now just look at this slide. Basically how many we have? 7 types, like A, B, C1, D, E, F, G. Look to the color code. All the white, that A, B and E, they are basically having activity in humans. Now, if you look to the color code red, that is A and B, they have a long in vivo potency. And when you see the different types of botulinum toxin type A, there are 4 types which we get in the market, which is known as onobotulinum toxin A, which is a Botox. Abobotulinum toxin type A is a Dysport. INCO is the Xeomin, which we use very frequently nowadays. And the prabotulinum toxin type A is the Juvea. So these are basically, all the red ones are basically the botulinum toxin type A. And the type B has also come in the market, which is also known as a myoblock and the neuroblock. And all the pink one, both type A and B, these are FDA approved. And if you look very carefully, the non-FDA approved, which we get it in Indian market, that is a botulinum, is basically a biosimilar. And when there is tolerance to one subgroup, we can switch over to the other. And you should always remember that doses are not numerically interchangeable, and a type B is more expensive than a type A. So this is the history. I will not go much into details. It is only in 1989 we got the FDA approval for the function indication, and 2002 we got the FDA approval for the cosmetic indication. And these are the units. For cosmetic, every 0.1 ml is equivalent to 4 units. For therapeutic, every 0.1 is equivalent to 5 units. So this is how we do the dilution. These are all the aesthetic indication. I think I should go fast, right? Finish it just 4 minutes. So these are the aesthetic indication. The most common aesthetic indication is for the crow's feet that you can see here. Before and after the surgical procedure, it gives a very good wow effect. Others being the forehead lines, but for the forehead lines, do not cross beyond the mid-pupillary plane, otherwise you'll get a proptosis. The glabellar lines, this is how we mark for the glabellar lines. This is the 5 classical points. Then the forehead lift, eyebrow lift, these are the points. And these are the some of the side effects and the contraindication that all of you must be knowing. And this is what you should not do if the person has a neuromuscular disorder. It is always better to avoid Botox. Little bit about the dermal fillers. The dermal fillers are basically 2 types, what's temporary and the permanent or the semi-permanent. Temporaries are basically the collagens and the hyaluronic. The semi-permanent are the calcium, the PLLA and the fascia. And the permanent is basically what we use, the Radici one. So the hyaluronic acid, it is basically in the liquid form, it's basically a monomer, it is not cross-linked. So we cross-link it to make it a gel form. That is how it increases the duration of action of the hyaluronic acid. And these are the different types of the hyaluronic acid that we get into market. It really gives a very wow effect, but for us as an oculoplasty surgeon, we should know the main indication is for the prominent tear trough. So what is this tear trough? It is an oblique fissure-like concavity, which we see just below the eyelid. And this is an extension. This is an orbitomalar ligament. This is one of my patients who had a lymphoma in the other eye. But when I seen this, you can see this is the orbitomalar ligament that I was mentioning, where medially we call it a tear trough ligament. And you should know to differentiate what is a true tear trough and what is a false tear trough. When there is a separation of the palpable part of the orbicularis muscle from the orbital part, that is a true tear trough. But when we get a nasojugal groove, that is separation of the orbital part of the orbicularis muscle from the levator labii elegans, that is known as the incorrect tear trough. So once you know what is a tear trough, it can be best managed by the different techniques that we use to give the injection dermal filler. And the best way of giving the injection is either with a needle or with a cannula. So this is how we inject. We inject directly with a needle. We inject it along the infraorbital rim. And you will see the results are just instant. Like this is on the right side that I am injecting, that you can see. And immediately after the procedure, you cannot see the bag. Can you see the bags are not seen on the right side, but still there on the left side. So this is an instant result that we get. And this can also be given with a cannula that you can see here. Then the whole of the tear trough can also be given with a cannula. Advantage, the bruising is much less, and this is what you see. The bags are much dissipate following the injection of the tear trough. So there are adverse effects, but you should be very careful of a vascular complication. There are 1 in every 10,000 cases having a vascular complication, either in the form of a necrosis, and also there is a complication leading to loss of vision. So you should have a hyaluronidase always with you. Hyaluronidase is the antidote of the hyaluronic acid, and this is what will prevent you from any of the vascular complication. And when we talk about the lasers, we should just remember there are 2 types of lasers. One is ablative, non-ablative. Both are basically used for different types of wrinkles, the hyperpigmentation, the scarring, and also for the face rejuvenation. Non-ablative is better because it gets deeper. Ablative is superficial. But disadvantage of non-ablative, because it is deeper, more energy is used, the chances of all blister formation or a hyperpigmentation following the laser is much more. So there are different types of lasers that we use, and each having different complication. And another thing which we use nowadays is the face thread. These threads are PDO, which is the polydioxazonone. And these can be different types. These are also used for all the indication that we use for either botulinum toxin or the dermal fillers. But what we basically use is a cork thread for lifting the face, the mono thread for the collagen synthesis, and the twin thread, which is basically for both volume and for lifting. So this is very simple that I want to show you, which we use it. I'll just, last one I'm showing you. This is what can be used for the lifting of the face, and this is a very good procedure because it's a office procedure. Number 1, you do not have the swelling effect that we get with hyaluronic acid, and the results are instant, and it lasts for pretty long. It lasts for more than 9 months to 12 months, and it leads to a very good collagen synthesis. So these are the threads which has got different indication. You can use it for the lifting of the face. You can use for the face rejuvenation, which the first that you have seen is basically a cork thread. These are the twin thread. The twin thread advantage is that it can lift and also it gives volume. So these are the twin thread, and twin thread is always in the direction of the vector where you want to lift it, and the cork thread should be placed always opposite to the direction of the vector. So with this I conclude my presentation. So we should always remember that all aesthetic procedures have functional indication, and many functional procedures have aesthetic requirement. And we should always document it very nicely, not only for the follow, but also for the medical legal purposes. And we still have COVID still continuing, so we should follow the COVID guidelines. So thank you very much for your patient hearing. So once again, I would like to thank Team CSF and Dr. Santosh, Rolika, and the chairperson for giving me an opportunity to speak to these beautiful young generations of ophthalmologists. Thank you.
Thank you so much, ma'am, for that comprehensive talk. I'm sure we enjoyed it. I'm sure the young students also would be interested to pursue this when they move out of their cocoons. So now, next I invite Professor Neelam Pushkar, ma'am. Ma'am is a professor of ocular oncology and oculoplasty at RP Center, AIIMS, New Delhi. Over to you, ma'am.
Good afternoon, everyone. I would like to thank Dr. Santosh Honavar and his team for giving me the opportunity. So I'll be teaching you about orbital infections. Do you have a pointer? तो इसमें करना पड़ेगा ना हाथ वाला नहीं हाँ जी अच्छा पर वो मेरे से कई बार ना नेक्स्ट स्लाइड हो जाती है. चलो ठीक है, I'll see if I can use it. So orbital cellulitis or infection, as we understand, is post-septal inflammation of soft tissues, which is basically fat, extraocular muscle, etc. So before we go on to orbital cellulitis, it is important that we should understand how to differentiate between preseptal cellulitis and orbital cellulitis. The reason being that preseptal cellulitis one can treat on OPD basis just by oral treatment, and orbital cellulitis is an ophthalmic emergency. So you as PG students should know how to differentiate preseptal cellulitis from orbital. In both the conditions you see eyelid swelling, but in addition to that, in orbital cellulitis, you see conjunctival chemosis, you see extraocular movements are restricted, proptosis is very important sign, and RAPD or decreased vision may or may not be there. Then another important thing is the Chandler classification. This has graded orbital cellulitis into 5 stages depending on how much threatening it is to the vision and to the life. So the grade 1 is periorbital swelling, grade 2 is orbital cellulitis, grade 3 is subperiosteal abscess, grade 4 is orbital abscess, and grade 5 is cavernous sinus thrombosis, which nobody wants to happen, because if this happens, then patient fatality, goes very high. So this is just some pictures to show the preseptal cellulitis. The picture which you can see on your left side is dacrocystitis, which is ruptured, and you can see the surrounding inflammation, but you don't see any conjunctival chemosis, proptosis, unlike in the other picture of orbital cellulitis. Clearly you can see that there is inflammation of the lids are so tense, conjunctival chemosis, proptosis, and restriction of extraocular movements. So these are very important signs which you should keep in mind. So the topic I have to cover is the infective etiologies. So I'll be basically covering all these areas. So the commonest cause of orbital cellulitis is a bacterial. Both in children as well as in adults, it is the gram-positive cocci, and it is mainly Streptococcus, Staphylococcus, though any other organism, gram-negative anaerobe, can also lead to bacterial cellulitis. The major worry in these cases are the two poles. The anterior pole is the cornea. Because of proptosis, they can be exposure or they can be extension of the infection in the cornea, leading to corneal melt. And posteriorly, we have optic nerve. We don't want optic neuritis or any compression. So these are the two important poles we have to take care of. Then in very few cases, a patient can develop meningitis or say intracranial abscess or even cavernous sinus thrombosis. So already said clinical sign, but you should know what are the important clues which will help you in diagnosis these cases of bacterial orbital cellulitis, say sitting in a casualty. So history-wise, if you see, there is acute presentation, just few days history of painful proptosis with swelling like this, conjunctival swelling, periorbital swelling, proptosis, associated fever, malaise. We know what we are dealing with. So the first differential should be bacterial orbital cellulitis, and these patients, they need admission, and immediate empirical broad spectrum IV antibiotic should be started in these patients, and you should look for meningeal signs, and also for URI, sinusitis, any dental infection. Basically you have to look for the source from where the infection has come. So these pictures are just to show the restricted ocular movements which typically you see in patients with orbital cellulitis. So from where this infection comes, the commonest site is ethmoid sinusitis. And as Dr. Abhijit Kaur explained, that the medial orbit, there is a lamina praepatia, which is the thinnest bone of all the four walls of the orbit. From there, direct extension, or because of the valvulus, the venous channels which are there in the midface, from there the infection from the sinuses can go into the orbit. So that is the commonest reason for orbital cellulitis, both in adults as well as in children. Though there are other causes also like endophthalmitis or hematogenous spread from dental infection, from any pyoderma of the face from where the infection can go in the orbit, or implantation like trauma or some kind of surgical procedure or injection which we give. So again, this picture you can see this is child with bilateral periorbital swelling with proptosis in the right eye. And in the below picture, you can see that there is ethmoid sinusitis, there is maxillary sinusitis, and there is orbital inflammation. The other side you can compare with there is contrast in the orbit, there is fat stranding. So this was a patient with bilateral, orbital cellulitis more on the right side. And the other picture you can see, it is in the superior orbit, there is a foreign body. It was the cap of the pen which was stuck there with localized inflammation all around, which you can appreciate in the CT scan below. So orbital cellulitis is ophthalmic emergency. We have to admit these patients. We have to get a thorough workup and investigations, but one should remember that we should not really wait for all the reports to come, the baseline investigation, and start patient on broad spectrum intravenous antibiotics after doing some baseline investigations. So the important investigation, of course, blood test for sugar and other important parameters. Then pus, if you see any draining pus or conjunctival discharge, it's very important as a resident also that you should take a swab before starting the intravenous antibiotic. Take a swab, send for culture, both aerobic, anaerobic, and fungal cultures. And very important thing generally people miss is when you see a pus, please make a gram stain slide, which is very important. Instantly it will give you the organism, whether it is bacterial, and if it is bacterial, whether it is gram positive, gram negative. This is something which one should not miss, because culture will take at least 3 days for the report to come. So this is very important thing which I want to highlight. And then of course ultrasound nowadays, it's available at most of these centers. So do ultrasound and look for abscess pocket. In trauma patient, look for any foreign body. And if you see abscess pocket, it will help you in monitoring the case, just seeing the size of the abscess pocket, because every time we cannot do a CT scan. Then on urgent basis, you you do the contrast enhanced CT scan. CT scan is still, I must say, is the baseline imaging which we do in all patients with orbital disease and trauma, that you should remember. MRI will help you if you want to really look for optic neuritis or say cavernous sinus involvement or any intracranial involvement. But CT scan is like a baseline imaging which you people should know. This is just to show that this is a CT scan coronal cut, and superiorly you can see the subperiosteal collection over here, and there is another collection which is there in the intracranial area. So on clinical suspicion, as I said, start the patient immediately as soon as possible on broad spectrum intravenous antibiotics. And the combination which we prefer at our institute is the intravenous vancomycin, which has good coverage for the methicillin-resistant Staph aureus, and ceftriaxone. And both these drugs, they have good CNS penetration, because we know that the closest thing is the brain, which is where the infection can go. Though there are other antibiotics preferred by doctors, the second line we generally prefer is linezolid and piperacillin, and also AMP, Amox, and there are many more antibiotics. So anaerobic infection in these acute patients, generally we suspect if a patient is diabetic or has undergone tooth extraction or organic foreign body, or patients not responding to your broad spectrum IV coverage for say 24 to 48 hours, you can start patient with the anaerobic coverage also. And commonly we use metronidazole, but yes, clindamycin can also be used. Then close monitoring has to be done in the ward every day, morning, evening. One should look for the eye status, any systemic issues, and of course you have to see very important thing, which is extension into the cavernous sinus. If there is a spread of infection in the cavernous sinus, you will see in the other eye. Can anybody tell? What are the early signs in unilateral patient, in unilateral case of orbital cellulitis? What are the early signs of cavernous sinus involvement? What exactly you want to look for? A clue in the other eye. Anji? What will happen in the other eye if there is cavernous sinus involvement? Yes, very good. One is the sixth nerve palsy, the other is that you see periorbital puffiness or conjunctival chemosis. So mainly because of stagnation of venous outflow. So these are the early signs, because late signs anybody will pick, but early signs if you pick, you can do so many things, you know, because it's almost becoming like a life-threatening condition. So close monitoring is very important, systemic workup very important to look for any other focus and immunocompromised status. The optimal duration of antibiotic, which is basically intravenous to begin with, and then we switch to oral. So average duration is around 2 to 3 weeks. The role of steroids is still controversial. Surgical drainage, not all the patients with orbital abscess will need surgical drainage. Large abscess with so much pressure that there is vision loss, either because of significant exposure keratopathy or optic nerve being compressed, or if there is progressive proptosis with abscess, then you would like to do drainage. And if you feel that there is retained organic foreign body, then it has to be removed. That is a must, whether it is a wooden, vegetative, any organic foreign body, because sooner or later patient will have, either again recurrence of cellulitis or probably will not respond. Then sinus drainage is ENT area. They take a call about this. Generally around 70 to 80% patients, they need sinus drainage. This is just example where the drainage was done, both these children. And CT scan, if you see, there is a roundish, significant size abscess. So in these patients, you need to drain. And as I already highlighted, pus when you see, you should not miss the chance to make a smear, do gram staining, and to send for all cultures and drug sensitivity and fungal also. Coming to necrotizing infection, this is again can be because of bacterial, fungal, but if you see the picture here, how it is different from the orbital cellulitis I was talking about. Anybody? Yes, there is loss of tissue, there is gangrene which is seen as black color. So it's like there is a complete loss of tissue all around, and if this progresses, then this can even lead to complete loss of the eyeball when it is involving the orbit. This is a case of Pseudomonas infection following peribulbar Brock elsewhere. So one should be very careful what you are injecting, what is the expiry of the drug, how the solution is, and everything. Like, so this patient finally, nothing we could do, we had to exenterate, because debridement is along with the IV antibiotic, which should have a proper aerobic and anaerobic coverage, should be started in these patients as early as possible. These necrotic tissue, no antibiotic will enter, and if you leave it, it is only going to progress. So it has to be done as early as possible, remove all the necrotic tissue. Sometimes repeatedly we have to remove the necrotic tissue in these patients, which can be even done bedside, because generally the sensations are not there. So you should remember that how they present is like, it's a very rapidly progressing thing. Organism generally is beta hemolytic streptococcus. Those Staph aureus, other organisms can also lead to this infection. Just within 1 to 2 days, you will see that the areas wherever the infection is becoming cyanotic, and just in another few 2 to 3 days, it will become absolutely black. So it is that fast. It spreads along the facial planes, in the subcutaneous plane. So sometimes on face you might feel that no, it is not extensive, but once you start debribing, you realize that you have to debribe it almost till the cheek or say the temple area. So that is the extent of necrosis that it can spread. So disfigurement is almost there in these patients to some or the other extent. Mortality is very high if you don't promptly treat it. Coming to fungal orbital infections, it's a relatively rare, and I'll be talking about the two important infection. One is the mucormycosis and the other one is the aspergillus. We know that the spores of these fungi, they are present everywhere in the environment, and most of this infection, they infect first the sinus and then they come to the orbit. So talking about the mucormycosis, it is basically seen in immunocompromised individuals, generally patients with uncontrolled diabetes or patient with ketoacidosis. And if you remember during the COVID-19 pandemic peak, there was, epidemic of mucormycosis. So in this, what happens is that this fungi, it becomes angioinvasive, it leads to thrombosis and finally death of the tissues. So these are some reports, at that time media labeled this as black fungus infection, but you should remember that mucorales are not black fungus. All right, so it was mainly because of the appearance, as you can see here. If you see the picture on your left-hand side, there is a cyanotic area in the upper lid, and just within 24 hours, it became absolutely black. And the lower down picture, you can see the facial, complete facial involvement by mucormycosis. So the clinical features, you should remember that mucormycosis has acute presentation. It is an emergency, patient has to be admitted. So what you see is, since it arises from the sinus area, nasal area, so what you see is the sinusitis, there is facial pain, there is a cyanotic skin, then there is foul-smelling mucopurulent discharge from the nose. Sometimes if you try to see the nasal cavity, you can even see the black necrotic eschar. So this examination of nasal cavity, even we as an ophthalmologist can do. So one should not just restrict our examination to the eye area. Even we can see that the nasal cavity has got black eschar. Just few days history, patient is having vision loss or proptosis or movement restriction. One should think, plus in a patient with diabetes or any immunocompromised condition, one should think towards mucormycosis. So CNS involvement in these patients is seen in 60% patient, and if there is CNS involvement, mortality is very high. Ophthalmic signs, early signs, as I said, can be, ptosis, can be facial pain, can be restriction of movement, diplopia, even sudden loss because of CRAO. But in advanced stage, as you can see in this picture down, that in advanced stage, there is the whole orbit is filled with the necrotic tissue, and the globe is absolutely frozen. The orbit is extremely tight, and if you do the retropulsion test, anybody can tell me what is retropulsion test? Yes? Okay, very good, excellent. So basically when we push the ball with the closed eye, we push the eyeball, we feel the resistance. If it is soft orbit, you will feel that there is softness, you can, push the eyeball behind. But then as you learn, you will realize that yes, the orbit is tight, and it is mildly tight, moderately tight, or it is strongly, strongly positive retropulsion. This test is very important. Okay, so as I said, this arises from the sinus nasal cavity, so the role of ENT surgeon is here. And we have to refer these patients to ENT surgeon or endocrinologist or medicine, because it is something one should avoid admitting in the ophthalmology department, because these patients, they have associated systemic problems, and which has to be dealt by, it's a multidisciplinary approach. Unless you have a good team, you should not really admit in your ophthalmology department. It's better to refer the patient, for the ENT or for endocrinologists or infectious diseases people, and we can always help them in doing the further management of the eye. So what ENT people, they do is that they do nasal endoscopy, and the black eschar area you have to take out, and you have to do KOH staining. And we use calcofluor white stain as a brightener. And if you see the picture here, this is under fluorescent microscope. That what you see is broad ribbon-like, hyphae. These hyphae, they are aseptate. And what exactly we look for? This is for me. because I didn't hear this before my lectures, you know. It's been, you know, for more than half an hour, and since I started my talk, as the second time I'm hearing this. Is this for me? Okay, thank you. Okay, so what you see is the broad ribbon-like, you know, hyphae. They are at 90 degrees and they are aseptate. So the thing which we ask the ENT people is whether it is septate or aseptate hyphae. If they say it is, you know, aseptate, we know that we are dealing with mucormycosis. So when I'll talk about aspergillus, then you realize what is the difference like. So then you, of course, you have to send for culture, but you will not wait for the report. It will take almost 2 weeks. And ENT or MRI should be done, and this is what you see. The sinuses are completely opaque. The orbit, you see, sometimes there is no contrast in the orbit because the things are absolutely necrosed. So management is admit. It's a multidisciplinary approach, control whatever underlying problems. Liposomal amphotericin B is still the standard of choice. You have to start this, and then finally you have to switch to oral posaconazole. Wide surgical debridement depending on the extent of the necrotic tissue, whether it is in the sinus, oral cavity, or in the orbit, you have to debride. Now there is a newer drug you should know, which is intravenous isavuconazole followed by oral. Probably this will take over in few years. So this is something which we did during the time of mucormycosis epidemic. Because that time we saw many patients with early presentation. So they had localized, involvement. So we tried to save the eye as well as vision by giving intraorbital injection of amphotericin B. And we gave around, 10, 14 injections, just a desperate, attempt so that we don't have to do exenteration. Because once it becomes advanced, we are left with nothing but to exenterate. So in addition to the localized debridement from the orbit, which was generally done by the ENT people because they have to do the sinus debridement. So in addition to that, we used to give intraorbital injection also. But once it becomes advanced like this, as you see, tight orbit, completely filled, and no vision, frozen globe, and you can see the tenting here, which Dr. Santosh explained very nicely lower down in the MRI. So the intraorbital pressure is so high. So these patients are for upfront exenteration. You should do this procedure with the ENT people because giving GA twice is not possible because of the systemic problems in these patients. So you have to act very fast. So it's better that you combine exenteration with the sinus surgery. Talking about invasive aspergillosis, this is one thing which, in contrast to mucormycosis, the presentation is very subacute or chronic. Patient will give history of months, proptosis is there, very indolent course, the eye is silent, movement restriction might be there, vision loss might be there, but not very common to happen. It presents mainly as a sino-orbital disease, though it can be seen even in the immunocompromised people. But what we see, the sino-orbital invasive aspergillosis, it is mostly in the immunocompetent patients. So these are two patients' picture. You can see eye is absolutely quiet. There is proptosis, but if you see the imaging lower down, you see there is the sinus is completely filled, and plus there is a small orbital component in this. The other lady, if you see, ill-defined mass lesion is there. And this ill-defined mass lesion, generally they are the thing which you have to see, 2-3 things you have to see on imaging, which helps in, clenching the diagnosis. One is that it is ill-defined mass lesion involving the sinuses also, or extending in the temporal fossa or pterygopalatine fossa, and it's a hyperdense mass. Rarely you see calcification, which also helps in clenching the diagnosis. So unlike in adult invasive aspergillosis, children, especially infants, we see that it has little aggressive appearance, the invasive aspergillosis. Though the line of management is again the same, that we have to do the debridement little bit, but not to the extent of exenteration, because voriconazole drug really works very, very well. So in these patients, our CT I have already explained. The organism in the immunocompetent patient, generally we find is the Aspergillus flavus, and in immunocompromised patient it is fumigatus. And generally, because these patients, they have, you know, a history of months, so generally we, you know, keep this as one of the differential. So generally these patients, they are diagnosed on histopathology, but because what we have to do is to do a biopsy. So either ENT surgeon does it or we do it. So it's like we have to take a biopsy, and on biopsy what we see is the septate hyphae with 45-degree angle branching, which clinches the diagnosis along with granulomatous inflammation. A very important biomarker, serum galactomannan, which you people should know. This is one biomarker which helps in guiding the treatment in systemic invasive aspergillosis, where you don't even culture or find this particular fungus, but if galactomannan is raised and patient is sick, you have to start patient on antifungal treatment. So this is very important biomarker. I've done a study on localized sino-orbital disease, and 40% patient, we found that the serum galactomannan levels were raised, and it correlated with the response, clinical response to treatment also. So nowadays, even for sino-orbital or for our patients also, I'm getting serum galactomannan done. And before stopping the treatment also, I get it done. And if I feel there is a relapse, then again I do it. So I feel that this is really a very good biomarker even for us. So this is just a silver methamine stain showing the 45-degree angle branching, and this is the culture plate of Aspergillus flavus showing yellowish green color colonies. Treatment, of course, is voriconazole now become the standard of treatment, and it has replaced amphotericin B because of obvious reasons we all know. Then sinus debridement should be done in these patients, but yes, exentration or orbital debridement, I don't remember doing in any of these patients in past 15 years. So this is a patient of, you know, sino-orbital disease, as you can see here. And this is 3 months later, proptosis resolved. This is another patient with mainly orbital component, little bit sinus component. And this is, you can see, more than 50% reduction, and even the proptosis has gone down. Coming to orbital tuberculosis, we know tuberculosis is endemic in our country. So orbit is extrapulmonary type. The commonest presentation is with, you know, classical periostitis, which is seen as discharging sinus. I'll show you the pictures, you'll understand and probably never forget. And if you see a patient like this, where there is, you know, cicatricial ectropion with the sinus which is, you know, discharging, and there is a subacute chronic kind of presentation, please think about tuberculosis as the first possibility. So this is the presentation of classical periostitis, which is the commonest presentation of orbital tuberculosis, though it can present with tuberculoma also, with or without underlying osteomyelitis, where the patient you see is the cold abscess is there. So when a patient comes like this, with the temporal area which is involved, because it is usually the zygomatic bone. So because there is a hematogenous spread, so zygomatic bone or frontal bone, these are the two important bones getting affected by the tuberculosis. So when you see a patient like this, absolutely quite normal otherwise, and with abscess which is cold looking, the first possibility should be tuberculosis. So you have to do systemic workup, do a biopsy, incision curettage, get a histopathology also done, where you see the granulomas with caseation necrosis. That is very important. And culture and PCR also you have to send, but it's not, you know, generally very sensitive. So sometimes just on the basis of clinical suspicion and histopathology report, we start patient on ATT. So it's not that every time you will see culture or say, you know, PCR coming as positive. So we all know the treatment. So generally these patients have cicatricial ectropion. So this is a patient where skin grafting was done after the completion of ATT. But here I would like to highlight one thing very important, since there is so much, you know, cicatricial ectropion, severe grade, and there is lag of ophthalmos. So please, during the time of, you know, ATT course when going on, do permanent tarsorrhaphy. Otherwise, patient within 3-4 months will have cornealoplasty, and then you will be left with like, then there is no point doing much because patient has lost vision. So it's very important that when patient comes like this, when you are doing the debridement and other thing, please do a permanent tarsorrhaphy. and do the definite procedure later on. Coming to hydatid cyst, human is accidental intermediate host. It is caused by Echinococcus granulosus. Orbital involvement is seen in very few patients except in endemic areas. Generally seen in children and young adults, you see a proptosis like this of say 1.5 years duration and a huge cyst of 2-3 centimeter. And when you do the ultrasound, you see that there are anechoic areas. So that is the clue. When you see anechoic areas in the cyst like this, we know that it is hydatid cyst, until unless it's a meningocele. All right, which will present very early age, and they will be, since birth, some difference, some proptosis, until unless that is the thing. Plus in this, along with the anechoic areas, you might see some, echoic areas also because of the sand or because of the daughter cyst. Unlike in meningocele where you don't see anything, there are no echoes at all. So this is usually present intraconal, and this is post-surgical. So avoid FNAC in these patients, please, because if you do FNAC for diagnosis also, then it can lead to anaphylaxis or severe reaction. So avoid FNAC. Please first check what exactly it is. Is it hydatid cyst, or really you need to put in a needle there? So histopathology, we all know there is ectocyst and there is endocyst, and surgical excision is for the orbit. It is surgical excision is still the standard treatment. Post-operatively, if there is rupture, spillage of the fluid during surgery, you start patient on oral albendazole for approximately 3 months. This is a very short video. I thought I'll keep it just to make it little interesting, but I think it doesn't
can
want
we wrap
to.
up now?
Yeah. So this is conjunctival removal of the hydatid cyst. This is just to show how hydatid cyst looks like. So this is the same girl, and I'm cutting the pericyst. If you remember, hydatid cyst has a pericyst. So here I'm cutting the pericyst after decompressing the cyst, after aspirating. I put a cryoprobe, and if you see, this white is very much similar to the boiled egg white. And even the consistency and friability is like that. So very gradually then you take out the thing from the orbit, and usually it is not adherent that much to the pericyst, and you are able to take it out completely. So it has been completely taken out. Flush the cavity, see the color. So color is very much like boiled egg white. So this is ectocyst, what we are seeing, inside is the endocyst. Talking about cysticercosis. Cysticercosis is like human acts as intermediate host, and it is usually seen in young adults and children. So commonest site of orbital, I'm talking about orbital, not ocular, please. Commonest site of orbital is myocysticercosis. It can present as inflammatory orbital disease with proptosis, or it can present with ptosis depending on where the cyst is sitting. Like if you see here, you can see this scolex and the cyst over here. And plus here you see this is of the same child with ptosis. It is in the superior rectus region, and it can present like a pharyngeal cystic lesion like this. So this is again a presentation of myocysticercosis, or if it is in the apex, it can lead to orbital apex syndrome. So this was very interesting case which I had published also. So many cysts, can you see, and so many cysts in the orbit like grapes, all over, you can't even count them, and even in the CNS. So this was disseminated cysticercosis case, and fortunately this patient had no eye problem because these cysts were all live. So when these patients, they have symptoms of inflammation, anybody? When the? Yes, when the cyst is dying, it releases toxin, it causes, inflammation. So, and here you can see typical ultrasound with the high density scolex. Why it is high density? Anybody? This is my last slide, don't worry. So, because it has calcareous granules in it, all right. So the management for orbital, I'm talking intraocular, we know is surgical. But orbital, mostly we give oral albendazole under the cover of steroid to take care of the inflammation. But yes, if it is isolated purely in the subconjunctival area or lid area, you can even excise it. And near the optic nerve, you have to be very careful in giving albendazole, because again, if the cyst starts, when the cyst starts dying, obviously it will die. It will release toxin, can lead to optic neuritis. So in optic nerve area, you have to be very careful that if you really want to start. The two important things you should rule out before starting oral albendazole is that there is no intraocular cyst, okay, and the other is that CNS, there is no cysticercosis. Otherwise, it has to be done under the supervision of neurologist, and they also generally avoid albendazole. All right. So that is important thing. Thank you so much. So these are the references.
Thank you
Alright,
so much,
thank you.
ma'am, for the wonderful talk, and that was a very interesting video of the hydrated sisters.
I thought I'll keep that so that, you know,
Yes.
people sleeping here will probably get up or become more alert, you know.
Those videos are always interesting, and it was very nicely put up.
Thank
ma'am.
you. Thank you so much.
Thank you so much, ma'am. I request our next speaker, Dr. Feroz PM, to please come and talk on approach to orbital tumors. This is an interactive session, so I hope you guys enjoy it.
Hi everyone, wakey wakey. It's been a long day, I understand. So we'll just quickly go on to the tumors of the orbit, okay? Yeah, slides. Are you all fine? Yeah, okay. Many smiley faces. That means it's good. Okay. All right. So, tumors of the orbit. Okay. I'll try to keep it interesting for you. This is actually a tumor. Strawberry is healthy. What tumor is this? Gross pathology, huh? Hemangioma, right. Okay, I have no financial disclosures. Orbital tumors, as you all know, something that we talk about. Whenever we talk about orbital tumors in orbit, we say that it's a Pandora's box. And anything is possible in the orbit. You know, many things can masquerade. So it's so very important to do a good clinical evaluation. And ma'am has taken amazing class on how to clinically evaluate, you know, a case of proptosis in orbit, and sir spoke about imaging. Systemic evaluation will come to it, you know, pertaining to different cases and appropriate management. I'm not going into the anatomy, I'm taking this off. Ma'am has spoken about it. So why is it so important? Because every structure in the orbit and tumor or a lesion can originate, be it the neural tissue, be it the vascular tissue, venous, arterial tissue, etc. So depending upon the origin, you know, it can be a primary orbital tumor arising from the orbit. It could be benign or malignant like any other tumor. Secondary, arising from the adjacent structure. So whenever you see a lesion, first thing that has to go in your mind is whether it's primary or secondary, all right? And then whether it's benign or malignant. And of course, metastatic orbital tumors can also happen. Now, depending upon the tissue of origin, again, there is a classification. I remember one of my residents telling me a year back that their essay was orbital tumor, okay? So you have to start with the definition, then you have to start with the classification, etc., etc. So a classification, even if you don't know anything about the topic, you just put systematic headings and just jot down few lines, you're going to score marks. Okay, just have this main headings over there. So tissue of origin, neural, vasculogenic, mesenchymal, lymphoproliferative, arising from lacrimal gland, histiocytic, bone, cartilage, etc., etc. So this is how we actually classify, you know, like another classification depending upon the location in the orbit. It could be intraconal, it could be extraconal, and it could be both intra and extraconal. So intraconal, you should understand, are arising from the structures which is intraconal. So what are the intraconal structures? Although we don't have much time for interaction. Optic nerve is there, vessels are there, okay? And fat, soft tissue, right? Yeah. So anything that is arising, tumor arising from the optic nerve, like optic nerve glioma, meningioma is intraconal, hemangioma is intraconal, schwannoma is intraconal. So this is how you do it. Now extraconal, there are so many structures, right? It can arise from the muscle, it can arise from the fat, the nerves, everything. So that is extracorneal, and it could be both intracorneal and extracorneal. So this is yet another classification. So you got two classifications over here. So this is a very interesting case of a large series of 2,480 space occupying lesions, and what they have found is 68% were benign, fortunate, okay, and 32% of the orbital lesions are still malignant. So 30% of the lesions that you see in the orbit can be malignant and sometimes very lethal. So the 8 most frequent orbital tumors, one goes dermoid cyst, lymphoma, cavernous hemangioma, mucocele, etc., etc. So when you write a line, you should say these are the most common orbital tumors, and that's good enough. So we'll go on to the cases now, okay? So we'll start in a chronology, age-wise. These are pediatric tumors, few of the tumors. This was a 1-year-old girl, squinting, bulging of the which eyeball? Left eyeball, and slow progression. So mother came for the reason that the eye is squinting, okay? Now, is there anything that you see here? Apart from anything here? Child with proptosis, squinting, bulging. Yeah, there is a small tip over here, like, a tip of the iceberg for the diagnosis. Anything abnormal in the face? Nice skin, but there's a patch, hypopigmented patch. What is that? Cafe au lait spots, right, yeah. So she has more spots in the body, okay? So the diagnosis is there. So a child presenting with proptosis, it is supposed to be axial because optic nerve, but sometimes it can be a little bit of abaxial also, depending upon how large the tumor is. So this was a large tumor that she had. The optic nerve was so involved that it was twisted, okay? And that's why it was causing a little bit of an abaxial. And it's actually bilateral. So this was less involved. The right eye and the left eye was more involved. In fact, she was blind with optic atrophy in the left eye when she presented. Okay, and that's what you see here. Both eyes, yeah. And so there are certain intraocular other ophthalmic manifestations of optic nerve glioma. Sir has already spoken about it in the morning, retinal astrocytic hamartoma. So as an oculoplastic surgeon or an ocular oncologist, my examination doesn't stop in the external proptosis evaluation. We dilate, we see everything. Systemic evaluation again is so very important, and that's what this case shows you here. Combined retinal combined hamartoma can also be part of neurofibromatosis. Okay, now 1-year-old boy, bulging of the eyeball, deviated eyeball again. Where is the deviation now? This is called what? Dystopia. Okay, so there is a superior dystopia. When the eyeball is turned up superior, then there is something happening inferior, absolutely. Okay, so this is what you see here, a large lesion. So what is important over here, and what cut is this? Sir has already told you this. Axial cut, okay? So is it a homogeneous lesion or a heterogeneous lesion? Heterogeneous lesion, well defined, okay? Do you want to call it cystic? No? Kind of. It has, right? It's very well defined, heterogeneous, calcification, cystic spaces, solid spaces. So it's kind of everything is in there, all right? So in a child, if there is a lesion where all the elements are present, embryological element is present, dermoid, all are present, teratoma, perfect. Aishwarya, yes. All right, yeah. So this is again, multicystic, where all the components are present. So obviously it was teratoma. Now, teratoma can be benign and malignant, and it's very, very important to know that. Okay, so this was luckily a benign orbital teratoma. So what I did was like inferior transconj approach, a large approach, canthotomy, cantholysis was done so that the approach is really nice. Although this being a very, very large lesion wrapping around the optic nerve, this could be taken out along with the bone. All right, yeah, so this is how it was. So we have an orbital teratoma where it was excised surgically. Do we excise? What is the management of optic nerve glioma? Already I've written it there, damn. Anyway, so we don't operate it, okay? So mostly it's a clinical diagnosis. It's a radiological diagnosis. So the most recent management of optic nerve glioma is a non-surgical approach with systemic chemotherapy. We actually treat these children. And why do we treat these children? It's to stop the progression. Okay, now this child has bilateral. If we don't treat the child, okay, doesn't matter, we'll do yearly follow-up, mama calm, it's okay, anyway one optic nerve is gone, but then you're making the child blind. Okay, the other eye is going to grow, and this can even progress in the optic nerve radiation and the optic nerve pathway, leading to many complications in these patients. All right, so this is a treatment update. You should know these things. This is the advances in the management of optic nerve glioma. It's never observed. These children are treated with systemic chemotherapy. There is something called MEK inhibitors now. It is very recent. Selumetinib, all the MABs and the ABs, whatever it is, and it's FDA approved. And it causes 69% regression of these tumors. Even anti-VEGF, bevacizumab, is considered to be a treatment in optic nerve glioma. Now this is again a large lesion sitting here, aspirated. So what this could be in a child? Colobomatous orbital cyst. Okay, so this can also present as a proptosis in child. Now what is this? Someone gave me the diagnosis earlier. So this is a eyeball is there. It is cystic. What is that? Congenital cystic eyeball. Okay, so these are the cystic lesions that can happen in congenital patients. Now let's go on to adults. So these are the common, 22-year-old gentleman, bulging of the eyeball. Differential diagnosis, axial proptosis. Sorry? Cavernous hemangioma, yes. Anything else? Cystic again. Yeah, there is an extension into dermolipoma? Dermoid. Okay, so this is a dumbbell dermoid in the orbit and outside the dermoid, outside the orbit into the temporal fossa. So, dermoid cyst, it can be deep, it can be superficial. Usually in children, you can see in the embryonic fissure, fusion area. It could be medial, it could be lateral, and also. And what is so very important is when a child comes, a patient comes with a small baby coming with the dermoid cyst. The question of, we know it's benign, it can be observed. The question is, can we observe or not? The parents, doesn't want the child to undergo the surgery. So, what I say? Remove it. Because these can rupture. If a child falls down, these can rupture. And rupturing can cause severe inflammation. They can present as orbital cellulitis, in fact. So, a smaller the lesion, easier to remove, better the cosmesis, and you're doing away with the complications associated with that. Okay? Now, a 10-year-old girl, proptosis, diplopia, rapid progression. A trivial history of a very trivial trauma where the parents correlated it to the trauma that she has a hemorrhage. Okay, so this was how the patient was referred to me. Like it could be a retrobulbar hemorrhage, subconjunctival hemorrhage. What would you want to do? Observe for the hemorrhage to resolve. Proptosis is there. Imaging, that's what you say. Yeah, okay. So imaging was done. Okay, and this is what you see. A lesion here, lateral rectus seems to be involved. Heterogeneous again, all right, yeah. Anything else that you're seeing here? Apart from, there is involvement of the bone, okay, extending to the temporal fossa, extending to the cranial fossa, okay. Rhabdomyosarcoma is a differential diagnosis. So there are certain triradiate lesions, okay, we call it triradiate, in the orbit, in the temporal fossa, in the cranial fossa, okay. Now there is a list of it, okay. So this is the list of it. It could be neuroblastoma, it could be primary neuroectodermal tumor, sphenoid wing meningioma, plasmacytoma, leukemia, lymphoma. In children, the most common, this is a child, neuroblastoma, PNET, sphenoid wing meningioma is in adults. So it could be neuroblastoma or PNET, all right, yeah. So, this came out to be an Ewing sarcoma or a primary neuroectodermal tumor. Now, why I had put all these things here is oncology has really evolved and progressed. You listen to Dr. Kaustubh. So, it's just not diagnosing and getting a preliminary histopathological diagnosis. We do a battery of immunohistochemistry to get the diagnosis in place. There are different types of PNETs. We also do genetic testing now. Now, in order to know the prognosis of the disease, genetic testing and genetic markers are very, very important. So it's that level we actually diagnose these diseases in order to go for the management. Bone marrow biopsy is done, PET scan was done. Luckily, systemically, she was absolutely fine. She underwent chemotherapy, radiation, and this is how she is after the treatment. And 5 years, there is no recurrence. 3-month-old baby, girl with bulging of the right eye, 10 days, very rapid progression in 3 days. They were in the train, they were referred from Bihar. In 3 days in the train, it has started bulging. So rapid progression of a proptosis in a child. In fact, it was suspected to be an orbital cellulitis in the primary health center in Bihar, and this is how the child came. Very small baby, large tumor in the orbit. Okay, so there is this area that you see here is actually called central necrosis. That means the tumor is rapidly progressing and there is necrosis of this tumor. So veno-lymphatic malformation with acute bleeding is something that you really want to think about as a differential diagnosis, which I had in my mind, but it could be a high-grade malignancy because of the rapid progression. Went ahead, did a surgery. This was how the mass was seen. Went in for a rapid diagnosis, and it came out to be an orbital rhabdomyosarcoma. Rhabdomyosarcoma is usually seen in slightly older age group, but this was a 3-month-old presenting with rhabdomyosarcoma. It was embryonal, most common primary orbital malignancy. You should know that, okay? And it is lethal. Okay, and there are different pathological types. Depending upon the pathological types, the prognosis varies. There is an international classification of rhabdomyosarcoma, low, intermediate, high. I'm not going into the detail. You can take a picture or read about it. Okay, and depending upon that, again, it is grouped 1, 2, 3, 4, and then the treatment is given. Okay, it's chemotherapy and radiotherapy combination which is given to these children. Now, that child succumbed to the disease because it was a very abnormal early onset rhabdomyosarcoma, very rapidly progressive, severe, and then she died despite chemotherapy and radiotherapy. 11-year-old boy, history of fall, eyelid swelling, eyeball bulging, referred as a case of retrobulbar hemorrhage. Yeah, yes, yeah, he has ecchymosis, chemosis, proptosis. Is it only the left eye? Right eye looks normal? There is some amount of puffiness there. The child looks frail. The child looks so weak, right? Even the maxilla is swollen, right? Diagnosis. Someone? Yeah. What did you say? AML, absolutely, yes. So this was how his imaging was, very diffuse lesion in the left eye, again a lesion in the right eye. And the only thing that I would do here after imaging is a peripheral blood smear. No biopsy required. You saw, you just listened to Kaustubh showing you the chloroma picture, right? Yeah. So we don't even need a biopsy. We just have to go do a peripheral blood smear, prove that it is AML or leukemia in a child, and that's it. And it was an AML non-M3, which is a very poor prognosis. Metastatic neuroblastoma is yet another, ecchymotic, proptotic lesion in children that you have to think about. Now I'm going to adult. 32-year-old lady, blurry vision and bulgy eyeball in the right eye. 2 differential diagnoses I want. Thyroid ophthalmopathy. She doesn't have retraction of the eyelid. Okay, so there are eyelid signs in thyroid. That's how you actually, but yes, you're right. You should look for the eyelid signs, unilateral proptosis. Tumor-wise, cavernous hemangioma. We just spoke about intracorneal lesions. Come on, quick. Optic nerve glioma is seen in babies. We already spoke about it. Meningioma in adults. Okay. Then third, differential schwannoma. Perfect. Okay. So, this is how the tumor looked like. A very well-defined intracorneal lesion over here. And I'll come to the diagnosis. Yet another male patient. Okay. Axial proptosis. He came with 6/60 vision with compressive optic neuropathy. Color vision was normal, no RAPD. Okay, so these were the 2 cases with axial proptosis. Similar looking lesions here, right? We always go for contrast in order to look for the vascularity. Okay, and these are the 2 cases. So actually this was schwannoma here, okay? Grossly you can make out, and this is vascular, again the strawberry lesion. This came out to be a cavernous hemangioma. So important again, what you need to know about schwannoma and apical lesion is it's not prudent to go inside and take it because you're going to create more harm than good because optic nerve injury can happen in a benign lesion. So another thing that we do in these particular apical lesions of cavernous hemangioma is gamma knife radiotherapy. We don't surgically operate them if it is in the cone. So this is called the beware of the peer. Now again, proptosis. The third differential diagnosis that you gave me was meningioma, optic nerve sheath meningioma. Fundus. What is this? Shunt. Yeah, so ciliary shunt. Yeah, so this is something that gives a clue in optic nerve meningioma. This is the shunting of the vessels seen. And so dilated examination is very, very important. Obviously, you want to know whether there is compressive optic neuropathy, edema, hyperemia, or optic atrophy. Apart from that, these are the things that you want to look for. Well, and this is the typical tram track which sir has already shown you. So radiotherapy is the treatment of choice. So this is optic nerve sheath meningioma. Do you know any other meningioma? Who is that? Intelligent lot. Who is that? Sphenoid wing meningioma. Super. What's your name? Rishi? Nishim. Yeah, sphenoid wing meningioma. So there are different types. So meningioma can be arising from the optic nerve. So when you say axial proptosis, you have to be very specific, like optic nerve sheath meningioma. Now this can be abaxial proptosis. They can have a temporal fullness because it involves the temporal part also. 30 minutes done? Over? All right, perfect. Sphenoid wing meningioma. Okay, so radiotherapy is the treatment of choice. 20-year-old gentleman, proptosis, gradually progressive. What is this? Multicystic spaces. Huh? Oh, it's written. Where is it? Oh, sorry. Lymphangioma. Okay. So yes, the treatment is intralesional bleomycin. Well, another treatment is oral sildenafil. Okay, another indication of sildenafil in lymphangioma. Yeah. So other vascular lesions are low flow fistulas, which can come with proptosis and dilated vessels like this. So you have to, there is this classification A, B, C, D. You can just read up high flow, low flow, low flow, low flow. And then this is the classification of the ocular vascular anomalies. International Society for the Study of Vascular Anomalies, modified in 2018 from Amsterdam, Netherlands. So all vascular tumors, it's classified as vascular tumors and vascular malformation. So we don't call cavernous hemangioma anymore. We don't call lymphangioma anymore. So what do you call lymphangioma? What is lymphangioma? Venolymphatic malformation. Okay, venolymphatic malformation. Even cavernous hemangioma is non-distensible venous malformation. Okay, so the terminology has changed. Well, yeah, so this is basically a patient presenting with enophthalmos. All right, so what do you do? What are the differential diagnoses in enophthalmos? Varices and trauma, flow fracture. No, as far as orbital lesions are concerned. What? Any serous carcinoma metastasis. Breast carcinoma metastasis can cause so this is what we do, Valsalva's maneuver. Any patient coming with enophthalmos, you have to do a Valsalva's maneuver. Okay, I think I'm going to stop this here because time is out. 30 minutes over, right? Yeah, perfect. So, well, anything else we can discuss later. Okay, so just a broad overview. Yeah, thank you so much for your patient listening.
Thank you, Dr. Fairuz, for that interesting, interactive session. So now we move on to our next talk by Dr. Puneet Jain. He'll be talking about orbital inflammation. Dr. Puneet Jain is consultant oncology and oculoplasty IQ Super Speciality Hospital. Where is he?
I'm here only.
You can use alarm for him, you know, at 10 minutes. He won't mind.
Thank you. इसी को ना कर दो चालू. So already been told there is an alarm ready for me, though I am not infamous for overshooting my time limits, but still I think in paucity of for the paucity of time. So not a very conducive topic to be speaking at 6 p.m. after you have had everything basically entire oculoplasty and oncology since morning. We'll try to keep it brief. The purpose of this presentation would be to basically give you a heads up as to what is asked in the exam. These questions, these topics like orbital inflammation usually are not direct exam cases, or do not have a direct clinical relevance in that sense that most of them are pathological diagnosis. But we'll try to keep it a little exam oriented with respect to short notes which do come, and maybe some MCQs along the way to keep you engaged in this topic. So a very good evening to everyone. Okay, okay, some response. All right, so we'll skip the anatomy. I would like to give a minute to this slide. So it's very important to realize that there's something called the orbital septum, which is a thin fibrous sheet of tissue which arises from the periosteum of the orbital rim. And is attached in the upper lid. It fuses with the LPS aponeurosis, and inferiorly with the lower lid retractus and the tarsal plate. So with the eye closed, the septum along with the tarsi would completely cover the orbital opening. This is very important to understand, because not just with respect to inflammation, but with respect to infection, as ma'am has already spoken about, that preseptal space and orbital space are separate. There can be a spillover, there can be pathologies involving both the things, but today we're going to restrict our discussion in this topic with respect to what lies behind the septum. So, I used to find, as a PG, I used to find this terminology very confusing. Some OPD card would say pseudotumor, some would write IOIS, I would Google what is IOIS, then somebody would write NSOI. I'm just waiting for a card to say CID or NFS. I don't know. So this was actually a concern, and probably is with some of you students as well. So we will try to clarify this by the end of this presentation. So let's try to classify it first in a logical manner. So let's broadly classify the orbital inflammation into non-specific orbital inflammation and specific orbital inflammation. In the non-specific category, you have the orbital myositis, the dicryoadenitis, and the sclerosing orbital inflammation. And in the specific category, you have these 6 diseases. I'm not going to read them out. So I am a mnemonic person. So the mnemonic for this I made is MSD. That's Mahendra Singh Dhoni for the cricket buffs, and for this Virat the Great. So if you remember this mnemonic, at least you can remember the classification of orbital inflammation, which will help you in your short notes in your exam, and if at all asked as a differential for various diseases which orbital inflammation is, then you can elucidate some differential diagnosis to begin with to start your viva. So I think this will help you. Then this is the elaborate list of specific orbital inflammation. Now you see that this has a lot of overlap with uveitic etiology and uveitic conditions, and once you correlate the two, it will be very easy. It will not be very difficult. In fact, it will be very easy to memorize and summarize this if asked, and especially from the exam point of view. So some MCQs, these are my mnemonics, feel free to reject them. So orbital inflammation associated with rare diseases, this was one of the MCQs I came across during my PG days when I was preparing for the SRship exam at RP Center. So which of the following diseases not associated with orbital inflammation? So I made a mnemonic, Rosy Kim Castle. This way you can remember at least, okay, there were 4 diseases. This was also a question, is an important MCQ, which is the drug which is associated with orbital inflammation. So bisphosphonates or zolidonate would be the answer. High-less allergy and statins have also been shown to be associated with orbital inflammation. So let's now start the presentation. So let's cover the non-specific orbital inflammation first. This itself can be an exam question, and otherwise will also help you understand the entire terminology and everything. So it's a heterogeneous, so all these are keywords. You look for keywords when you speak out or when you write. So the keywords here are, it's an heterogeneous, benign, non-infective, inflammatory group of disorders with non-specific histological features in absence of local or systemic cause, obviously because that's why it is idiopathic. So it is a diagnosis of exclusion, meaning that this cannot be your first diagnosis. The incidence is about 10% of all reported orbital disorders. It is the most common cause of painful orbital mass in adults. Histopathology is usually non-diagnostic and diverse and can have any picture from diffuse polymorphous infiltrate to granulomatous inflammation to sclerosing inflammation to eosinophilic picture and vasculitic inflammation. So the exact pathophysiology is obviously not known, but infectious and immune-mediated etiologies have been proposed. Imaging, most of it, a lot of it has already been covered in the previous talks and by Sir as well. And we'll discuss this as we move on to specific diagnosis. This condition is typically steroid responsive. So back to the terminology, that's the same slide. So all these are one and the same thing. It is an umbrella term which we use when we do not or are not able to pinpoint the diagnosis. The term pseudotumor was introduced in 1905 by Birch and Hirschfield, and it's been over 118 years, and even now you see the paper in your OPD with a referral saying pseudotumor orbit. So that's how it is. I feel that it is a dumb diagnosis. We do not diagnose specific condition and then we label it as pseudotumor. It is a very overused and misused term. So let's try to classify this non-specific orbital inflammation. There are a lot of classifications based on onset. हर डिजीज़ का onset classification होता है, acute, subacute, chronic. जब कुछ नहीं आता होता तो ये लिखना ही होता है. हर डिजीज़ का histopathological classification भी होता है when it comes to orbit. So we'll stick to the most relevant one which I found in my PG days, and I think it still holds, is the anatomical classification. So the inflammation can either be localized or diffuse. Diffuse meaning involving the entire orbit, and localized can be just the muscles, the lacrimal gland, periscleritic tissue, periscleritis, perineuritis involving the optic nerve sheath, and the apex or the epicytis. So this I memorized as P3OD, which rhymes with PCOD. I know it's lame, but it somehow stuck my mind, so it always helps me. Might help you as well. So let's start with orbital myositis. I'm going to cover orbital myositis as a whole and not just idiopathic inflammation, so that if you are to write this in exam, you have your notes ready. The handouts will be given to you. They will help you. So orbital myositis in itself is relatively rare, but is the second most common cause of extraocular muscle disease after thyroid-associated orbitopathy. Very typically, it presents as an idiopathic, acute onset, painful diplopia in a young female, and usually involves a single extraocular muscles and responds very well to oral steroids. This has many similarities to uveitis in being an inflammatory condition which is often idiopathic, but is also seen in the setting of specific autoimmune, inflammatory and infective conditions. So this is how you can classify orbital myositis: idiopathic, associated with systemic and immune diseases; drug-induced, associated with infections; and paraneoplastic orbital myositis, which is very rare. Coming to the idiopathic orbital myositis, the most common type of orbital myositis, usually seen in young adults and more common in females. This is how you differentiate it from the general category of non-specific orbital inflammation. Typical presentation: acute onset orbital pain, diplopia. The pain is exacerbated by moving the eyeball in the direction of the muscle. There will be some lid swelling. If it is the upper lid that is involved, superior rectus involved, then there will be ptosis. There can be congestion at the insertion of the muscle site. Usually unilateral involvement is there. Single muscle involvement is there in more than 2/3 of the cases. Recti are more commonly involved than obliques, and the most common muscle involved is medial rectus. This is to contrast from thyroid ophthalmopathy. If asked, usually a single muscle presentation is not seen in clinically commonly in thyroid ophthalmopathy, but if asked, it is usually the inferior rectus. So this is one MCQ again. The muscle involved here can be either paretic, restricted, or both. This is also very important clinically. Now, contrast enhanced MRI is more useful than CT when it comes to orbital imaging. If you have to look at the muscle inflammation, the best would be contrast enhanced, fat suppressed, T1 weighted image. You'd find a uniform or a tubular enlargement of the extraocular muscle involving both the muscle belly and tendon. I think this all of you know by now. And there can be a spillover inflammation as well into the surrounding fat or the preseptal region. You should always look for lacrimal gland, orbital nerves, and paranasal sinuses also in the imaging to pinpoint any specific etiology you might arrive at with the help of clinical picture and radiology. So this is the same patient. You can see radiologically, this is the enlarged inferior rectus. The entire muscle along its entire path is enlarged, and you can see some spillover inflammation in the preseptal region also. So targeted investigations should be done in addition to the imaging. The investigations don't end at imaging to rule out specific causes. If there are atypical features, then one can consider a biopsy also. The natural evolution and the disease course is not well understood, so spontaneous remissions have also been reported. But that said, you cannot wait for the spontaneous resolution, as it may lead to permanent extraocular muscle dysfunction and fibrosis. So prompt therapy is usually recommended to preserve motility and to prevent any disease sequelae. The treatment of choice is oral corticosteroids. The dose is typically 1 milligram per kg per day, given for 1 to 2 weeks, and then tapered over next to 6 to 12 weeks depending on the clinical response. Severe cases might require a pulse therapy for a short duration like 3 days, and failure to respond to this treatment should spring up differential diagnosis and other diagnosis. So the good response, if the patient responds well, does not mean that it is idiopathic acute orbital myositis. It can also be seen in lymphoid tumors, orbital sarcoidosis, and venous granulomatosis. So one has to be mindful of that fact as well. So this is the similar patient, responded very well to 6 weeks of steroids. Recurrence is very common, so this has to be conveyed to the patient. Very important, especially in if you are in private practice. Parameters associated with recurrence are male gender and multiple extraocular muscle involvement. So you can prognosticate the patient based on the clinical picture. Recurrences can involve separate set of muscles or can also involve the other eye. Some clinicians feel that a slow, prolonged taper can prevent recurrences, but there is no consensus on this method of management. Coming to orbital myositis associated with systemic and autoimmune disease, again very repetitive diseases, but a comprehensive list. I will focus on 2 of them, IgG4 related orbital disease, where there is painless swelling of the muscles, involvement of the muscles, and the motility is relatively preserved. This is in stark contrast to the idiopathic variety. And in inflammatory bowel disease, where the muscle inflammation is very resistant to oral corticosteroids. You will get these lists in the handout, so no need to sweat. Drug-induced orbital myositis. Again, what is the most common drug associated with orbital myositis is ipilimumab, or the other option can be immune checkpoint inhibitors. These are coming in a big way of late in last 5 to 6 years, especially with respect to management of systemic melanoma and conjunctival melanoma, so might be a good MCQ to crack. And the other drugs, the third one we have already discussed, bisphosphonate, alendronate in our initial slide, and statins. Orbital myositis can also be associated with infections like herpes zoster, Lyme disease, Whipple's, Coxsackie, and parasitic infections, which ma'am has already covered. So orbital myositis versus thyroid ophthalmopathy, you already know all of this. Just one clinical point which you might like to answer in the viva, don't jump to investigations. Do tell that if the superior rectus or the superior rectus and LPS complex is involved, then a myositis patient would have ptosis, whereas a thyroid ophthalmopathy patient might have lid retraction. This is a good clinical differentiator. We usually tend to jump to fusiform enlargement and whole enlargement. End of the story, end of the table. That's not how it works. You have to give points in the viva, you have to give points in the exam. So these are, I have bifurcated the similar points, but these are relevant points. So unilateral single muscle involvement, bilateral more than one muscle involved, most common muscle involved, medial rectus, most common muscle involved, inferior rectus. The CT findings you already know, the imaging findings you already know. Coming to the second diagnosis. So with this you can write a good, you can have good amount of information in 6 slides on orbital cell myositis, and you might skip reading it if you have important topics to read. So dacryoadenitis, inflammation of the reclining gland. Please don't confuse dacryoadenitis with dacryocystitis. All right, this happened with me. I presumed dacryoadenitis. I kept calling it dacryocystitis in my exam, though I meant dacryoadenitis, but I kept saying it dacryocystitis. So this can happen. It's a human mistake. I'm not defending myself, but it's a human mistake, it can happen, so just be mindful of that. The overall incidence is low. Idiopathic dacryoadenitis is the most common type of idiopathic orbital inflammation, meaning the most common type of NSOID, most common type of IOID, most common type of IOIS, and most common type of non-specific orbital inflammation. Can be subacute, acute, or chronic in presentation, can be unilateral, can be bilateral. A typical patient presents with swelling over lateral half of the lid, with an S-shaped lid deformity, with tenderness, conjunctival congestion, proptosis, diplopia, and dry eyes, especially in chronic cases. There is no gender predilection, and it can be a presenting sign of an undiagnosed systemic illness. That's why tissue biopsy and systemic workup play a very vital role in diagnosing. Based on the etiology, again, it can be classified into infectious, non-infection, and the masquerades. We will fixate ourselves in this presentation to the non-infectious component. So non-infection can further be subclassified into non-specific and specific similar diseases. You can go through the list. It is again a diagnosis of exclusion. It is the most common pathology involved in lacrimal gland biopsies. It is not pleomorphic adenoma. This is again an MCQ. It is more commonly seen in females, 4th to 5th decade of life, can be unilateral or bilateral. Inflammation may be limited to the lacrimal gland or may spill over to the adjacent extraocular muscle, fat, and epithelial tissue. The onset is usually acute in more than 2/3 of the patient, and one should always evert or retract the upper lid and can see an enlarged and inflamed palpebral lobe of the lacrimal gland with engorged overlying blood vessels. Episcleritis can be present. There can be supratemporal conjunctival chemosis as well. Dry eyes are encountered less frequently than you would anticipate, and decreased anterior meniscus height can be seen. Sclerosing type is different in that it is a chronic presentation and is usually painless. So diagnosis is centered around lacrimal gland biopsy because it is an idiopathic condition and a diagnosis of exclusion. So a detailed systemic workup needs to be done. Orbital imaging, the investigation of choice is contrast enhanced MRI, which will show an enlarged lacrimal gland involving both the orbital and palpebral lobes. It will be an ill-defined enlargement with moderate to intense contrast enhancement and spillover to the surrounding tissue. The lacrimal gland is iso-intense to the muscle on T1 and T2 weighted images. Lacrimal gland biopsy usually is taken through the transcutaneous route from the orbital lobe. Usually prefer a multi-layer incisional biopsy. Avoid corticosteroids prior to biopsy as it can mask diagnosis like lymphoma. And histopathology usually reveals two different types of pathologies. It can be either a lymphoid type or a sclerosing type. Coming to the management can be medical or surgical. The drug of choice again is oral corticosteroids, similar dosage as to myositis. Cure rate remains high with 2/3 of the patients responding to this therapy. Intraglandular injections, which can be triamcinolone acetonide or betamethasone, can be used in non-responding cases with the help of a 25 gauge needle. Directly inject the drug into the orbital lobe. Transglandular injection can be used in sclerotic type variety where injection into the gland might not be feasible, and select and severe cases might require a pulse in IVMP therapy. 2/3 of the patients will have either incomplete response or might be recalcitrant to the steroid therapy. Risk factors for this include male gender, spillover inflammation to the extraocular muscles, and sclerosing variety of the idiopathic dacryoadenitis. Recurrences are also common. Other drugs that have been used in cases of steroid toxicity or patients who do not respond to steroid therapy include DMRDs like methotrexate, azathioprine, biological agents like rituximab. Radiation therapy is reserved for certain subset of patients. Surgical debulking has also been tried as the primary therapy for idiopathic dacryoadenitis. Now, this is a survey article that came out in 2022, which very nicely in tabular form elaborates the specific causes of dacryoadenitis and how you can clinically and with the help of investigations prior to biopsy try to pinpoint the diagnosis. So we'll break down this table now and we'll compare each of the specific diagnoses with non-specific dacryoadenitis. So let's take up IgG4 orbitopathy. IgG4, I think that was for you, wake up. So IgG4 orbitopathy, so you see that this is bilateral is more common than unilateral, which you would expect in a systemic disease, and it is a painless enlargement of the gland. 50% of the patients will have extraocular muscle involvement as well, and 2/3 will have systemic involvement. The drug of choice remains oral corticosteroids, but the relapse rate is very high. The next is venous granulomatosis, more accurately called granulomatosis with polyangiitis. Ophthalmic involvement is seen in about 2/3 of cases of venous granulomatosis. This is again bilateral but painful. Dacryoadenitis can be the presenting feature in about 16% of the cases. So that's important. Isolated lacrimal gland involvement is rare. It is more common in males, and the treatment is usually under the care of a rheumatologist, or a coordinated clinical care is required. But if once the therapy is started, the relapse rate remains low, which is in contrast to IgG4 related dacryoadenitis, where the relapse rate remains high post treatment. Now coming to sarcoidosis and Sjögren's syndrome, more common in females, so that's one thing, and both of them tend to be painless. Sarcoidosis unilateral is more common than bilateral, whereas Sjögren's bilateral is more common than unilateral, and relapse rate remains low. So I think if you can at least remember these key points out of this table, you can build around it and answer a lot of questions. So I will give this article reference at the end, and you can go through these articles from the same article. Coming to the third, orbital epicitis or orbital apex inflammation. So few points that have already been elucidated is that when it comes to the orbital apex, MRI is far superior than a CT scan. You can do away with an MRI if the patient presents with a CT scan in the OPD. But when it comes to the orbital apex, the cavernous sinus and the fissures, then it is very important to have a contrast enhanced MRI. So this is the least common of the all, but has the poorest outcome. Presentation would depend on the nerves that are affected at the orbital apex. I think this you should know. Orbital apex syndrome basically is cranial neuropathies with orbital optic nerve dysfunction. Now, optic nerve dysfunction is what differentiates it from cavernous sinus lesions and also superior fissure syndrome, which we'll cover in subsequent slides. Another MCQ, Jacquard syndrome. What is Jacquard syndrome? Orbital apex syndrome. All right. So from the orbit, inflammation can spread through the superior orbital fissure and the optic canal to the middle cranial fossa, and through the inferior orbital fissure to the infratemporal and pterygopalatine fossa. Intracranial extension, if present, the most common location is cavernous sinus and middle cranial fossa. Similar etiologies are seen with orbital apex syndrome, superior fissure syndrome, superior orbital fissure syndrome, and cavernous sinus syndrome. So if you remember this anatomy diagram of the apex, where the superior orbital fissure and inferior orbital fissure and apex, they form a boomerang and different structures pass through it, then you can easily differentiate between these three. Another MCQ, it's a difficult name. I don't have any mnemonics here. So you will get all this in the handout, so don't sweat out. There are numerous causes of orbital apex syndrome. We are focusing right now on inflammatory part, so we'll restrict ourselves to the inflammatory portion. So it can be idiopathic, it can be Tolosand syndrome, it can be sarcoidosis, SLE, Church-Strauss, GPA, giant cell arteritis, and IgG4 related orbital disease. You'll see that if you memorize the first table that I showed you of specific orbital inflammation, you can write up most of these answers very well. I'm sure you would not, at least I did not study orbital inflammation for my theory exam. So this would help you. So this is an MRI showing apex inflammation, and this is an MRI showing cavernous sinus inflammation. I think imaging has already been dealt with by sir in great detail, so we need not go there. Another hot topic these days is IgG4 related disease. This disease came after I was born, so 2003. Most of the diseases have a history. This was diagnosed in 1980, 1880, 1520. This came after I came. So that's why I find very interesting. So it was unified as a disease entity in 2003. So not very old, right? But there has been a vast expansion of knowledge on this over the past decade, because it has been eventually realized that a lot of conditions which were being labeled as non-specific orbital inflammation suddenly started fitting in the category of IgG4 related disease. This is very important, right? So Mikulicz disease, when I used to read for PMT, you would also have read for PMT, is associated with Sjögren's syndrome, bilateral enlargement of the lacrimal gland and the salivary gland, right? It is now related to IgG4 related. So this is one thing where So this disease was discovered before, but then the actual categorization has happened much later. I think 1800s, this disease was discovered, Mikulic's disease was named. So that's how this disease is important. I am sure you can definitely get a question on this in some form or an MCQ. So just pay heed to some of these points. This is the last bit of my presentation, so no more bells, please. The most common manifestations of this disease are type 1 autoimmune pancreatitis, salivary gland, lacrimal gland involvement, where we as ophthalmologists or oculoplasty surgeons come in, sclerosing cholangitis, which was the first diagnosis of IgG4 when the disease was discovered, tubulointerstitial nephritis, lymph node enlargement, and retroperitoneal fibrosis. So you basically see a multi-organ involvement. It can be localized to a single organ, can involve multiple organs, can be simultaneous cell involvement, can be metachronous involvement. So a patient can present with dacryoadenitis, and that might be the first presenting feature of IgG4 related disease in that patient, which is why it is very important. So IgG4 related ophthalmic manifestations, just remember these 7. So first two we have already discussed and elucidated. It can also involve the orbital soft tissue, sclera, eyelids. Neuritis is very important. There are case reports on IgG4 related trigeminal neuritis and orbital bones. IgG4 related disease, like other systemic diseases, tends to be bilateral. So if there is a bilateral involvement or lacrimal gland involvement, then there is an increased chance of extraorbital manifestations in these patients. The criteria for IgG4 disease are basically centered around 3 parameters. It's very easy, it's not difficult. One is organ involvement, which we have already spoken about. Second is one value, 135 milligram per deciliter. So serum IgG4 levels greater than this, and histopathology showing greater than 10 IgG4 cells, IgG4 positive plasma sites per high power field, and more than 40% ratio of IgG4 positive and IgG4 cells, right? Sounds very difficult, it's very easy. And then based on these, there are 3 diagnoses. Definitive diagnosis is all 3 are present. Probable diagnosis is that you have the organ involvement, you have the biopsy, but you don't have a raised serum IgG level. And possible diagnosis is when you have the serum levels high with an organ involvement, but either you do not have a biopsy or the biopsy is negative. This was revised slightly in 2020. You can go through this list. Basically, if you remember this, it's fine. Then speaking as a whole about the disease, the first aim is to induce remission. So glucocorticoids again are the first line of treatment. Patients typically respond very well. If the patient fails to respond to the glucocorticoid therapy, then the American College of Rheumatology has considered it as an exclusion criteria for IgG4 disease, meaning that if the patient does not respond, then it cannot be IgG4 according to them. Disease modifying anti-rheumatic agents, as we have previously spoken about, intend to reduce the glucocorticoid dependence and toxicity, especially if prolonged therapy is required. So you have to understand that the mean age of diagnosis for IgG4 is around 6 decades of life. Most of these patients will have comorbidities, and as we spoke about in the first slide, type 1 autoimmune pancreatitis. They might also have pancreatitis, right? So obviously giving steroids might be a tricky business, or you might not be able to give steroids, which is why all these therapies are very important. Role of biologic agents have also been elucidated: rituximab, infliximab, and the latest one is dupilumab. All tongue twisters. So now coming to the maintenance. So once you have induced remission, you need to maintain it. Long-term therapy is needed, but it remains a question and a point of debate. A lot of publications are still coming up on IgG4 related disease. It is a hot topic for research these days. The disease is prone to recurrence also, and the risk factor for recurrence include number of organs affected when the patient was diagnosed and the serum IgG4 levels. Low dose maintenance therapy can be considered for patients who have recurrence, and role of biologic agents is there. So that's it. There are a few articles to read which would basically help you go through all the examination part. Thank you so much for the patient listening.
Thank you, Dr. Puneet, for that wonderful talk. So what I have learned today is how to make a boring topic interesting. And the best part was the way you ignored the alarm.
I think we
Okay.
get used to it when we present a few.
Okay.
Thank you, ma'am.
So do we have Dr. Seema Das here? Because I can't, oh, yes, she's here. Okay, all right. Dr. Seema Das is a consultant ocular oncology and oculoplasty working at Shroff Charitable Eye Hospital. She'll be speaking on thyroid eye disease. Again, a very interesting topic. And as a PG students, you should know about thyroid eye disease, the clinical signs, classifications, and the management.
Thank you, Dr. Neelam. Thank you, Dr. SH, Rolika, and the whole CFS team for this opportunity. And great to see people still awake and still ready to listen. It's very surprising. So the last bit, thyroid, whether we like it or not, we can't avoid it. Thyroid is important to know because, as per Rootman, that's the most common orbital disease in adults. It has varying clinical manifestations, like you can see here. It can range from a very mild proptosis to something where everything is out. There is an auto-evisceration of the globe. But the most important reason we need to know thyroid is that it's a long case, it's a short case, it's a spot case, it's a theory question, everything which is possible in the exam. So we need to know everything about thyroid eye disease. So these are boring stuff. I'm sure you will get it in the books. But just to recapitulate, what is the pathophysiology? Thyroid is an autoimmune disease, and the culprit lies an immune process which is directed against the receptors in the thyroid gland, which are kind of, the similar receptors which are there in the orbital fibroblast. So that's how the whole disease process starts. The fibroblast in the orbit, once they're stimulated by the antibodies, can either go towards the myofibroblastic side or can differentiate towards the adipocytic lineage. And based on that, we get two different manifestations of the disease. One where the muscles accumulate all the matrix materials, fluid accumulation happens, the muscles get thickened, eventually leading to fibrosis. And the second where there is a lot of fat accumulation in the orbit. So that's how we differentiate them into either a muscle predominant disease or a fat predominant disease. Most of the time what we get is a combination of two. Out of these three patients, which one do you think is a thyroid eye disease? 1, 2, 3, all? Any difference in opinions? Is it all or is it some of them? Which one is definitely a thyroid eye disease? Second is definitely a thyroid eye disease. What about the first one? Okay, could be, may or may not be, right? And the third again looks like a thyroid eye disease. Again, all three are thyroid eye disease, right? So eyelid retraction we have been taught is the classical sign. For second one definitely has a retraction. Even the third patient has. The first one has a very subtle retraction. But if you see the down gaze, all of them has a lid lag in down gaze. So these are the two very specific signs which gives us a diagnosis of thyroid eye disease. And in TAD, diagnosis essentially is clinical. You don't need any laboratory investigations or any kind of fancy imaging or anything to diagnose a TAD. So here lies the importance of evaluation and to get a correct diagnosis, because sometimes the findings can be very, very subtle, which you can miss in the clinics. Not every day you see findings like this. These are staring at you. You know that these are thyroid eye disease. It could be unilateral, it could be bilateral. More commonly bilateral, but sometimes you can get an unilateral disease also. Here there is no doubt about the diagnosis, but sometimes things are not so clear-cut. So again, for theory purpose, it's important to know this criteria, which has been given some time back by Bartlett and Gorman. But just for the sake of theory, if you have eyelid retraction and if you have one of the, like what has been listed in the first box, like if you have a deranged thyroid function, along with the eyelid retraction, or if you have a retraction with a proptosis or with optic nerve dysfunction or with movement restriction, you still can label the patient as thyroid eye disease, even if the thyroid level or the biochemical test parameters are within normal limits. If the eyelid retraction is not there, which is one of the most specific sign, and if the patient has a history of thyroid dysfunction, then one of the other three findings, if they are present, then you can label the patient as thyroid eye disease. But again, this classification or this criteria has its own fallacy. It misses out some of the patients. Like for example, we know some patients can simply present with symptoms of dry eye disease, can have only lower eyelid retraction, which is not very specified here. So probably there is some need for modification of the criteria. This is one of the patient. There is some amount of upper eyelid retraction, but what is more prominent is the lower eyelid retractions. So especially in our population, we do see patients where the eyelid retraction is mostly in the lower eyelid, and sometimes there is no retraction in the upper eyelid. So whether we label these patients as thyroid eye disease, especially if the thyroid functions are normal, is again something which is debatable. The second one, as you can see, can be easily labeled as a ptosis in the right eye rather than a retraction in the left eye. Only when we make the patient look in the down gaze, take a detailed history, do a thyroid evaluation, then only we can get the correct diagnosis. So dry eye is pretty common, especially in our series. We found that that was actually the commonest presenting symptoms for most of these patients. And what was also surprising is compared to the world literature, maybe in our setup, we see more patients who are hypothyroid, and almost about 20% of the patients can be euthyroid at presentation and just can come to you with signs of eye disease. Again, this is something you need to know. Comprehensive evaluation, that what we do for all other patients in the clinic, needs to be done for all thyroid patients. And there are some specific things which we also need to know. And there is a whole list of, the protocol of workup, which whatever we do for all proptosis patients, we need to check for the visual functions. But the most important thing, other than what you do to know in the clinic, if we have to ask few questions, 5 questions to the patients in the clinic, we need to know what is the duration of the disease, what is the onset of the disease, does the patient have any history of smoking? Is he diabetic, hypertensive, or is there any history suggestive of sleep apnea? Sometimes the history of sleep apnea, diagnosis of sleep apnea might not be there because these are the 4 things which are possibly modifiable risk factors in thyroid eye disease. Rest of the things, it's autoimmune. Even if the patient has something, you really can't do much, probably just treat the symptoms of the disease and the rest of the other manifestations. So this is definitely something you must note it down in your chart, and this should be part of history taking for any thyroid eye disease patients. You do the thyroid function test, T3, T4, TSH. You also do the antibodies, TSH receptor antibodies, thyroglobulin antibodies, and the thyroid peroxidase antibodies. These are usually the 3 which are recommended, but the most important one is the TSH receptor antibody. And of course, an endocrinology consult, because thyroid management is like, it's a teamwork. Only ophthalmologists cannot do much. You need to have other people in the team. You need to have a good tie-up with the endocrinologist, and both the thing has to go hand in hand. There are probably 28 named signs of, the eyelid and rest of the periocular area. And there is a whole list. I'm sure nobody can remember, but some of the important ones which sometimes the examiners are very fond of asking, you should know. So what about these 2? These are the commonest ones, eyelid retraction and lid lag. So what do you call them? What is retraction? Named as Dalrympe. And what about the lid lag? Von Graffe. So at least these 3, I am sure, if you don't answer these 2, then you are gone. Okay, rest is fine, okay. But it's good to know some of them. Again, this is something you should know, modified the Werner's classification, what you call as the nose specs, taken as a mnemonic from the first letter of each specific category. Good to know for the theory purpose, though at today's era, there is not much important. We don't rely too much on this classification for deciding on our treatment, but I'm sure you will get it in the textbook and should know about it. Now, what is important now to know when you have to manage a thyroid eye disease patient is what is the status of the activity of the disease. All of you agree that these both are thyroid eye disease? Any disagreement? No, both are thyroid eye disease. But what is the difference? Do they look same or? Okay. The first one looks angry looking eye. It's almost like there is some amount of inflammation, cellulitis going on. The second one seems pretty quiet other than the proptosis. So the first patient has what we call as active disease, and the second patient has something called as inactive or quiet disease, whatever you call it. Basically, there are no signs of inflammation. So eventually in thyroid, the pathogenesis involves release of the inflammatory mediators in the orbit, and this is what causes most of the findings. And in the initial phases, you will also see some signs of the inflammation because of those mediators. So that's how the clinical activity score comes into the picture. So whenever you see a patient in the clinic, important thing to know is, one is whether the disease is active or not, and if it is active, what is the activity score. So these are the criteria, the CAS score which has been given, and there are certain points. These are basically all the criteria which you have been reading in the pathology, all the signs of the inflammation, pain, redness, swelling. These are all signs of inflammation, right? Color, rubor, dullor, and pain, rest of the things. So the same goes here. So pain is specific. Usually in thyroid, it's a retrobulbar pain, and sometimes there are pain on ocular movement. So for each point, if the answer is yes, patient gives a yes answer, the score is 1. If the answer is no, the score is 0. So based on this criteria, you give score. The maximum score which can be there based on CAS score is 10, and the last 3 are on follow-up visit. So in the first visit, you can have maximum score of 7, And on the follow-up visit, if there is an increase in the proptosis, vision has gone down, or the movement has got further restricted, then 3 further score comes into the picture. So this is how basically you score it. You can see the obvious redness of the eyelid, much more appreciated if the skin color is fair, might be difficult to appreciate in our population, but yeah, if you look for it carefully, you will find it. Swelling. Swelling can be as part of chemosis, could be swelling of the caruncle, could be edema of the eyelids, and then swelling can also be in the orbit, which will be basically manifested as an increase in the proptosis. So again, answer of yes to any of those will mean a score of 1, no is score of 0. So a total score of anything more than 4 is supposed to be an active disease, and you can categorize that the more is the score, more is the severity of the activity. So generally, it's important to know it because active disease, the management of thyroid is essentially medical. So the role of steroid is mainly for the active phase of the disease. There is no role of steroid for the chronic or the inactive phase of the disease. So generally, most of the time when you see a thyroid, the first instinct is prescribe steroids. So that's not correct. You must categorize the patient based on the activity and then only decide whether there is a need for steroid or not. The second thing which you need to know is the severity of the disease. So one is activity, the second thing is severity, how severe it is. Now the activity can be mild, activity can be severe, right? So this is again based on the UGOGO classification. It is mild, moderate, and severe disease based on how the disease affects the lifestyle and how much of it, how much is the effect on the visual functions. So severe, moderate to severe is actually one category, and the third category becomes your, the sight-threatening thyroid eye disease. So again, there are criteria given based on which you can kind of put them into whether it's a mild disease or a moderate or a sight-threatening disease. The third thing to know is the Rundle's curve. So Rundle's curve is basically a curve which you plot again in the chart of the patient, which will tell you what is the natural history of the thyroid we know has a peak. It increases, the active phase starts most of the time. It will plateau down after a certain time period, and eventually the body will take care of the disease. Since it's an autoimmune process, and the disease is going to die down on its own, even if you don't do anything, right? So the whole thing you plot it in the form of a curve, which is like and sort of a little, something like a bell shape, not really a bell shape, it's skewed towards the left side. But this is how a typical Rundle's curve goes. So the disease will start, it will become kind of, increase in severity, activity will keep on increasing, and eventually over a period of time, it will die down. This is a typical curve, doesn't mean that everybody will follow that curve. The curve can be something like this, it can be something like this, and it can be very flat. If somebody has started off with a disease, never had a very severe disease, but just died down with a mild retraction, then the curve becomes very flat. Sometimes it can be very steep like this, sometimes it can be, like this also. So based on that's why it's important to know the history, since when this problem started, was there any redness to begin with, so that you can put the patient into the Rundle's curve based on the symptomatology and the chronology. So again, it could be mild, moderate, severe, and more is the height of the curve, more severe the disease is. The Rundle's curve not only tells us about the, how severe the disease is, but also tells us how to treat the patient. So in the initial part, if the patient is kind of, if you plot the patient and if the graph comes more towards the left side, you know that, patient is still active, and I'm going to treat the patient with the medical means, which is usually steroid. Only when the curve becomes flat and the disease activity dies down, you are going to go for your rehabilitative surgery, decompression, eyelid, squint, whatever surgery you decide to do. So now quickly, can we kind of, score this patient based on the activity? This is an active disease, everybody agrees, right? So can you quickly put a score? How much do you think is the activity? So there is redness, there is some amount of chemosis, there is some caruncular edema, there is some lid erythema, there is some lid edema, so at least 5. So even if you don't know the rest, whether the proptosis has increased, whether the vision has decreased, whether the movement has been, so 5 means it's an active disease, right? So it's important to note that score on the file at every visit, and simultaneously put the Rundle's curve, which will be from the history. If the patient is saying duration is just 6 months, and already it looks pretty angry looking, so probably it could be something, he's probably somewhere here in the rising phase of the curve. So it might go like this, it might go like this also, right? So we don't know. So every time we need to take the symptomatology, do the CAS score, and try to put the patient on the curve so that we know how the disease is behaving. What about this? What is the score? Redness, no. Chemosis, no. Caruncular edema, no. Lid edema, no. Lid swelling, no. rest we don't know. So at least doesn't seem like an active disease. So this is almost probably a 0 score of CAS, so an inactive disease. So again, based on the symptomatology, if it's a 3-year history and the patient says, I never had any redness or swelling, it has been like this, the rundles will become probably something like that. She never had an acute phase or a kind of, more severe phase of the disease, just went into a chronic phase of the disease. So this definitely is an active disease. Over a period of 3 months, you can see the proptosis which has progressed, so pretty severe and possibly going into a site-threatening thyroid eye disease, right? The imaging is something which is probably, again, not required for all patients. We do tend to order it, an MRI or a CT, but it's not really indicated for your diagnosis purpose. It's a clinical diagnosis. Even sometimes for the management purpose, you really don't need a CT except for specific situation. So if your diagnosis is uncertain, you are not sure whether you're dealing with a TED or not, you want to see what's happening to the muscle, what is the status of the orbital fat, or you are planning a surgery, or you want to see the orbital apex area, right, if there is a compressive optic neuropathy, and those are usually the situation where we go for an imaging. So what kind of disease is this? Based on imaging, what do you see here? Does the muscle look thickened, or there is too much of fat in the orbit? The black thing is the fat, right? Dr. Santosh has already taken the image in a class, right? So it's a lot of fat in the orbit. The muscle does not seem to be too much thickened. The optic nerve is straight. Normally you don't see the optic nerve in one frame like this, so there is definitely proptosis. So it's possibly a fat predominant thyroid eye disease. What about this? First patient, not too much of a proptosis. There seems to be some squint, which indicates again more of muscle involvement, not much of proptosis. So possibly there is not much of fat involvement, which is again confirmed on the CT. There is bulky muscles, not too much of fat involvement, whereas there is too much of proptosis here. However, the kind of squint does not seem to be too much. We don't know the ocular movements. So this seems to be more of a fat predominant disease. So this is how the imaging findings correlates with your clinical findings, right? So steroid, again, it's important to know what are the indications. It's usually there is no role of steroid in the inactive disease. Severe active disease, if it's just a mild activity, just a congestion, you can simply manage with some lubricants or maybe some topical steroid, need not give systemic steroid, can just keep the patient on follow-up. Only if there is a severe active disease or there is a compressive neuropathy, corneal exposure, globe luxation, these are all signs of the site-threatening disease, there is role of intravenous steroid. Other things like active disease with ocular motility restriction, you can give either systemic steroid, either an oral steroid or IVMP pulse steroid can also be given. And if it's an unilateral disease and there are contraindication to systemic steroid like a diabetes and all, you can also give an intraorbital injections. This is the same patient we saw after a course of intravenous methylprednisolone. You can see the response of the inflammation has become much better, which again confirms your diagnosis that it is an active thyroid eye disease. What about this lady? Do you agree that this is thyroid eye disease? Does it look like a thyroid eye disease? Yes, no? Could be, maybe, right? Possible. Well, she is of course, her makeup of the eyelid is different, right? So you really can't make out the eyelid margin very clearly, but does look like probably some amount of retraction is there, which is hidden behind this fold of the eyelid, right? There is definitely a proptosis in the left eye, and there is some squint in the left eye. There is some congestion, and I don't know if it's apparent, she does seem to have a lower eyelid entropion. Not really retraction, but entropion. So with these findings, probably these are not the classical findings of thyroid eye disease, probably not a retraction. You, of course, need further evaluation. So we evaluated her further. She turned out to be hyperthyroid. And because of her orbital structure, we know that in the, in the non-Caucasian races, those who have a kind of, shallower orbit or a smaller orbit, the eyeball sometimes cannot bulge out as it does in maybe the other population. So it's a very tight orbit. These are the patients who tend to go very easily to compressive neuropathy with not much signs, eyelid or the orbital signs of thyroid eye disease. And sometimes instead of retraction, the eyelid tends to turn in because it's a tight eyelid, and that's how sometimes they can present with an entropion. So she did have thyroid eye disease. The muscles are bulky, both the sides, right? Which is a little unusual for a female, but yeah, she had. What about this? Active, inactive. He has an corneal exposure keratopathy, but active or inactive? Doesn't look like too much of active disease, but a lot of eyelid retraction, possibly a very severe lag of thalmus, and that seems to be the cause of the exposure keratopathy. So it's not that he has too much of proptosis, which has caused the exposure. So he has a severe disease, he has a site-threatening disease, but he does not have too much of activity. So it's not necessary that, site-threatening disease is always active. even in a non-active phase, you sometimes can have sight-threatening disease. All right, so this we already discussed. This is intraorbital steroid, sometimes in unilateral thyroid eye disease patients, early activity, those who have diabetes or other contraindication, they do respond. And steroids sometimes can also be used to differentiate an active from an inactive disease if you have any doubt whether it's active or not, right? Immunosuppressants, again, you can read from the textbook. A lot of them are there. If the patient is dependent on steroid, you can consider some immunosuppressants. Radiotherapy has a very controversial role, but low-dose radiation does seem to have some effect on modulating the natural course of the disease. Studies have shown that they can delay the dysthyroid optic neuropathy in patients where it has been given in combination with the low-dose steroids. Okay, this is important to know, might be an exam question because this is the first drug to be approved for treatment of thyroid eye disease, teprotumumab, again one of the difficult names, Tepeza, what it's called, and it has been recently approved, which is basically an IGF-1 receptor inhibitor, and this is one of the receptors which is involved in the pathogenesis of the thyroid eye disease, and this drug seems to have potential or promise in modifying the natural course of the disease. It's very recently approved. Over a period of time, we'll get to know the long-term effects. Tocilizumab, we all have heard about it during the COVID times. It's again an antibody against the IL-6 receptor. Again, IL-6 is something which is involved in the pathogenesis of TED. So some of the steroid-resistant cases which are not responding to a steroid, or you have already given enough steroid, or there is some contraindication, these are the things which can be tried. Rituximab, again, similar role, but mostly in the early mild to moderate diseases, does not have too much role in the severe diseases. As a temporizing measure, we don't go for surgery unless and until the active phase is over, but you can give some temporary measures like Botox injections if the retraction is too much and the patient wants something to be done for that. All right, so coming on to the rehabilitative surgery, whether you do eyelid surgery or extraocular muscle surgery, like this patient had a stable eye disease, thyroid was normal, ensured that the disease is systemic thyroid status is okay, and the eyelid disease, eye disease is sort of stable over a period of at least 6 months to 1 year before you plan any rehabilitative surgery. So eyelid surgery for eyelid retraction, you can either do a mullarectomy or you can do a levator resection. We did a resection for this patient. Orbital decompression can be done rarely in the active phase of the disease for compressive optic neuropathy, but mostly these are done as a rehabilitative surgery during the inactive phase of the disease, mostly for the cosmetic purpose. Now, depends on how much is the amount of proptosis. You decide whether to do an 1-wall decompression, 2-wall, 3-wall, or 4-wall. Fat is usually considered the 4th wall in the orbit. So based on the amount of proptosis, there are algorithms which are given, and I'm sure it must have been covered throughout the day in some other sessions. And what is done these days is something known as deep lateral decompression, where basically the expansion is done in the posterior part of the orbit rather than in the anterior part, because any volume expansion in the posterior orbit is likely to have much more effect on the amount of proptosis reduction rather than in the anterior part of the orbit. So this is a very small video clip about this is the fat decompression. This is not the deep lateral decompression. So fat is usually considered maybe sometimes the first walls. If it's a mild proptosis, you can just get away with taking out a little bit of fat from the orbit. So it can be done, the whole surgery can be done from the transconjunctival approach. You open up the conjunctiva in the inferior part like you do for any other orbitotomy approaches, a pharyngeal approach. Go right into the intraconal fat, identify the intraconal fat, which looks different, little different than the extraconal fat, and you just take out the required amount of fat, which is kind of, which you need for letting the eyeball go inside. So, and then simply close the conjunctiva back. Sorry. This is one of the patient. This is not the fat decompression. I think my videos got mixed up. So this was one of the patient where we did a bilateral 3-wall decompression because he had quite a severe proptosis. And as you can see in the post-op CT scan, all the lateral wall, the medial wall, as well as this, the supralateral part of the orbit, these are all expanded where the orbital soft tissues can go inside. So this is the fat decompression. And I'll skip the deep lateral video. And this is the same patient where we did the fat decompression and the eyeball has nicely gone inside. Really, you can also go for decompression in the active phase of the disease, not usually done as a last resort if the patient is not responding to your steroid or any other modality, and if there is a compression in the optic nerve. So usually done by an endoscopic approach. You can take help of your ENT surgeon if you don't do it yourself. Idea is to expand the posterior part of the orbit by removing the lamina papyracea in the posterior ethmoidal ear cells and letting the orbital tissue prolapse into the ethmoid sinus. So that basically expands the space in the posterior orbit. Now this is the same lady who had a dysthyroid optic neuropathy who was not responding to the treatment, and post endoscopic medial wall decompression, a posterior ethmoidal decompression, and neuropathy had resolved, and you can see the proptosis also is much better. So again, complication, decompression has its own set of complication, which you can again read from the books. So just to conclude, important thing in thyroid is to assess the stage and the activity of the disease. You should know how to assess for activity. You should know the clinical activity score. You should know the severity grading of the disease. And we must also know that thyroid is a self-remitting disease. Whether you do anything or not, it is eventually going to settle down. Your idea is to ensure that the patient does not land up with a site-threatening complication. So that's the purpose of the treatment. The purpose is not to sort of, make the disease die down or alter the natural course of the disease. Very few treatment can do that, possibly not. Mostly it's conservative management, and only when the disease has died down, any rehabilitative surgery, if it has to be done, it is usually in the inactive phase of the disease. Steroid should be used very judiciously, only in the moderate to severe active disease. Even in the mild active disease, there is not much role of systemic steroid. And rest inactive phase, you can go for all other management. So that's it. Thank you.
Thank you, Dr. Seema Das, for making this complex, disease so presented so simplified way so that PGs can understand this. So it was really very interesting talk, I must say. So with this, I think we will conclude this session here. And Dr. Rolika will coordinate with you people about the long and short examination cases. So with this, I would like to thank all the eminent speakers we had today. And of course, Dr. Santosh Honavar for giving us the opportunity to be here. And of course, PG students, I would like to thank, because the amount of enthusiasm and interest you have shown was really great, I must say. So thank you, everybody. Thank you so much.
Thank you so much, ma'am. So are you guys ready for an interactive session? Because here, we are not the ones who are going to talk. It's going to be you guys. So I'm just going to invite a couple of you to come forward. I think some of you already gave us your names.
So you remember that message that popped up which said some of you who have volunteered for the fun session, right? So we're actually trying to make it fun because we believe that it's easier to make it interactive, make it fun, for you to remember it forever, all right? So the teams that had put in their names, we'll be helping you out through this, all right? And you will enjoy, I assure you. And there are chocolates to be won, unlike the other sessions that we had. Cool? So the first team is Anushri and Ashrita. They're already hiding their faces. Come on. It's going to be fun.
It's going to be fun. It's just going to be a revision of everything that you've learned today. We're trying to entice you with these images, but these are not going to be your patients.
So you can take one mic each. That's fine. Over here in the center. I'll go down.
No, stay.
So these are very easy sessions, okay? So
basically what you need to understand is that when you get a case, coming to the diagnosis is not the aim. You just need to go in a logical sequence, just talk about, ask relevant questions to the patient. So we are going to be the patients for you. Just show you a picture. You can ask us whatever questions. We'll give you the answer for that. And then you go about with this. One of you can talk about the history. One of you can talk about the examination. And then already the management has been described by the faculty here. All right? So let's start with the first case. So this is a 48-year-old lady. And she came with a history of drooping of the left upper eyelid. So why don't you start? She comes to you. So what will you ask her? Continue. Yeah. I think the mic's not on. Can somebody just... Yeah, so just go on the type of questions that you're going to ask her.
Since when is it?
Right.
Is there any diurnal variation associated with it? Is there any pain? Is there any history of trauma?
Okay.
Any similar episodes in the past?
Right.
Any diplopia? Any
Okay.
decrease in vision?
Okay, perfect. So she's covered most of the things. I'm just going to list out the things and you just have to follow a logical sequence. Start with when did it start, like she asked. So basically this started about 4 years ago. It was a gradually progressive condition, chronic we can say, since it's 4 years old, and it's unilateral. It is slowly progressing. It's not variable. It doesn't show any diurnal variation or variation with, you know, the days that it is measured, or even when she's sitting in front of you, the times that you're doing her measurements, it's not changing with that. Any relevant past history? Well, not really. She doesn't have any surgical history, no birth history. And you should always ask the patient if they have their old photos. That kind of confirms when it started. Okay, that's more relevant in case of congenital ones, and we can also figure out whether it's been changing or it's been stable. All right? So, sorry, what's your name? Anushri. Okay, do you want to start with the examination?
Yeah, I would do.
Okay, go on.
I would start off with the position of the head and the ocular position.
Correct.
And then the symmetry of the face, and then go ahead with the visual acuity and the anterior segment examination under the slit lamp.
Right. What's important in that? What do you see?
Would look for the pupillary reaction.
Okay.
Also assess the extraocular movements, and then go ahead with the ptosis work.
Okay. So basically, initially you start with the inspection. So her vision is 6/6 in both eyes. Her pupils are well reacting. There is no evidence of any squint. Her ocular movements are normal. The other things to look for are the eyelid skin, the nature of them. There are conditions where they can be papery thin. There can be evidence of prior trauma, presence of some scar. Okay, there can be a mechanical component to the ptosis. Then you look at the eyebrows and the eyelashes, if there is any brow ptosis or any lash ptosis, because that determines what is the management approach that you're going to take. Okay, then you look for any variability while the patient is sitting in front of you. That's just the inspection part of it. And Schirmer's is important because any treatment that you do will ultimately lead to, even if it is for a short period, some amount of lag of thalamus. So we need to make sure that the ocular surface is good. Okay, so in her case, everything was more or less normal. Okay, so we start with the measurements in ptosis. Which are the ones that you will go for?
I would do the MRD 1, marginal reflex distance 1, and then the MRD 2 for the completion's sake, and then LPS action.
Okay. What about the palpebral fissure height itself?
Okay,
you start with that.
Height. Then would look for the Bell's phenomenon.
Okay, so just follow a sequence, okay? Always start with the palpebral fissure height, and that has to be measured in the primary gaze, in the up gaze, and in the down gaze. Why? What is the significance of that?
To differentiate congenital and acquired ptosis, if it is a congenital ptosis in the down gaze, there will be a slight lift, then the palpebral fissure height will increase.
Right, in the congenital one. Okay.
The senile one, it's lesser, the palpebral fissure in down gaze.
So we can call it the aponeurotic type rather than the senile variant. Okay, go on.
We will have to do the special test.
So you spoke about the LPS action. Anything else that you want to look at the lid? Any other measurement that you would want to take?
The lid crease
Correct.
distance.
Absolutely.
From the upper lid margin.
Okay. What is the significance of lid crease?
To differentiate between the different types of ptosis.
Right. Okay. I think that's already been covered for you. I'm just going to give you the measurements here. Okay, so basically you look at the palpebral fissure height that has to be taken as she explained in the up gaze and the down gaze, then the MRD 1 and 2, and I'm sure all of you know how to do the measurements. Then the lid crease distance, the LPS action, the tarsal platform show, that importance Dr. Kasturi covered, okay, and that's also important when we are going for the type of surgery, because if the tarsal platform show is less, you can actually correct it during the surgery because that has cosmetic significance. Then you should look at the Bell's phenomenon, of course, lag of thalamus, lid lag, and then as she said, the special test. So these are basically the findings that were there. So how do you do the ice test?
We ask the patient to keep the ice pack for 2 minutes. First, we measure the MRD1. That's
Right.
the thing which we'll be comparing. Pre and post ice pack for 2 minutes.
Okay. And what amount of difference is actually significant?
More than 2 mm difference from the pre-ice pack test reading.
Correct. And we should measure it immediately after removing the ice pack. The span for which it lasts is quite short. And then you have the phenylephrine test. Okay. So do you want to talk about the significance of that?
To check for the Muller muscle function, if there is phenylephrine positive, then a Mullerectomy would help. Like if it is a mild ptosis and phenylephrine is positive, and the other factors doesn't fit into the picture, then Mullerectomy would help the patient.
Right. So it is important to check that, because in mild ptosis cases, that may be one of the options for management. Okay. All right. So in this case, do you want to just talk about what the final diagnosis would be and how you present that? How would you diagnose this case?
48-year-old female patient present.
Just the diagnosis. All history is done, so you have to come to a diagnosis based on these findings.
Left eye, moderate ptosis of the upper lip.
Right. What kind of ptosis is this? I've shown you the picture here. You spoke about the importance. In down gaze, the PFH is less.
Aponeurotic.
Correct. So this is the aponeurotic variant. So you need to put it in the diagnosis. Okay?
So it's left moderate aponeurotic ptosis.
Go on. You're doing well.
No,
Say it out loudly. I think the others can't hear you.
Left moderate aponeurotic ptosis.
Right. Okay. And what do you want to do about it? Give me a very broad overview. I'm not going to ask you questions about the surgery. Do you want to operate on her?
Yes.
Okay. Which one?
LPS resection.
Okay. That is one of the options. All right. So basically, this was, you need to have a complete diagnosis with all the components. So you talk about the severity of ptosis, the type of ptosis, and also some relevant finding. This has good LPS action, so this is likely to be due to aponeurotic disinsertion. So you bring in the pathophysiology of it, okay? And I think in the ptosis lecture today, they would have explained to you about the different types of surgery for an aponeurotic kind of ptosis. So in this case, the most likely surgical management that you can talk about is LPS exploration and then reinsertion. Okay? So this is just some of the things that I told you about to look for in inspection. So you can have things like dermatochalasis, you can have rounding of the lateral canthus that also points towards involutional ptosis. Then you can have floppy eyelid syndrome. You can have lash ptosis, as you can see in the child there, or you can have blepharochalasis. These are important findings that will help you. You don't need to come to a perfect diagnosis, but your findings have to be accurate. Okay? All right. And this is just a table that is showing the difference between the findings in case of disinsertion, dehiscence, and degeneration. So I'm not going to repeat that again, but you can just take a picture if you want. Okay? So are you guys ready for the next case? Do we have the second team here? You guys did very well, and you guys get a chocolate.
So once again, I would like to interfere here.
Right.
These are the chocolates that you guys get. But I think she made me type that message and she made sure that she writes, it's a fun session. I think that's not fair, right? Because how is this fair? How is this fun at all?
But did you guys enjoy it? Did I question you? I'm not like a real Viva that happens, does it?
So let me be honest, this actually is a fun session. So she herself is my senior, and all of these kind of sessions she used to take for me. And trust me, I remember each and everything that she taught because of these fun sessions. So honestly, they are fun. Right?
I'm being very mild here today. So who's the
Yes,
next
she is
team?
being mild, ask me. Okay, so let's have the next team, Nishi and Dhwani, right?
Okay, come on. Are you guys having fun today? No, not really. Tired? Okay, good. You guys were answering quite a few of the questions I noticed. So this is your case, okay? So this is a 69-year-old gentleman, and he has this upper lid swelling, okay? So start.
How long is it for? How is it progressing?
Okay. Is the mic working? Can you guys hear?
You see no, it's working.
You can be as loud as you want to be right now.
How long has it been for? Is it progressing? Does he have any similar swelling around in the body? Or,
Okay. And why would you ask that?
For any syndromic association, if I'm suspecting
Okay, 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 good. All right. So basically, yeah, correct. You can also help her. It just doesn't have to be that one person asking the history, the other going for the examination. You can also help out here if you want. So what are the symptoms that he's having? It's not just the swelling. So he's complaining of foreign body sensation, and the swelling is painless. It's been progressive for over 3 years now. Okay? So there is a relevant past history. You need to ask him, has he shown it before? Has he been treated for it before? If so, how? So he gives a history of being treated for a chalazion with an incision and curettage. So you ask him, do you have any pathology report? He says no. All right? Anyway, so moving forward, his visual acuity in the left eye is 20/60. And we start with the examination, just the relevant examination, because we're not going to prolong this session. We're going to try to keep it compact. Okay? Go on.
So, starting off with inspection, I will like to see the, it seems like a yellowish multinodulated mass which goes beyond the margin.
So go again in a logical sequence with the description. Go on.
First on inspection. On inspection, I'll see it looks like it is crossing the margin, but there are no loss of lashes here. The skin surrounding the swelling does look mildly inflamed, but not to a gross degree. And there are no dilated blood vessels on top of the skin. And like she said, it is multi-nodulated and variably colored. On palpation, I would like to feel the consistency. It might be firm or soft to cystic. And I would definitely like to evert his margins and look through. And
okay, good. So basically, I think so. But so basically, whenever you describe a swelling, you start with relevant things like the location. It's in the medial 1/3 of the upper eyelid. Okay, it is involving the lid margin, and the posterior extent you still need to check, as you said, by everting the lid. You need to talk about the size just at this point. You need to talk about the color, which you already mentioned. Okay, and then, as she said, after the inspection, you go on to palpation. First thing is you talk about if it's tender. Okay, then the consistency. Skin you already spoke about, that also comes in the palpation. Okay, then the fixity to the skin and to the underlying structures. Okay, so as she wanted an everted picture, okay, so this is basically a nodular yellow lesion, and you talk about things in the lid margin because they come in inspection. So there is loss of eyelashes. Okay? Okay, maybe it's not that visible. Let me evert the lid.
Side, yes,
Okay, so this is the picture on eversion of the lid. Okay, do you want to describe it?
There are dilated tortuous blood vessels
Right.
on the conjunctiva, which looks like feeder vessels.
Does it look like a chalazion?
No, ma'am.
Okay.
This looks more inflamed and.
So if a 69-year-old gentleman comes with a chronic nodule, would you suspect chalazion in that case?
With a chronic nodule, yes, ma'am, because a long duration will give me a benign.
You can give it as a differential, but chalazion is not so common in an older age group. Okay? Again, unilateral blepharitis, unilateral blepharoconjunctivitis, start suspecting something more. Okay? So, I'll give you the findings. This is about 20 by 25 millimeter in size in its complete extent. It has intrinsic vascularity and the rest of the conjunctiva is also congested. Okay? There is some amount of chemosis. Okay? There is some amount of ropey discharge. Also, you need to mention that whether the puncta is involved or not. Okay? That's something that is important. So, would you like to elaborate on the diagnosis that you feel is most relevant? Your impression rather, not your diagnosis.
Sebaceous carcinoma.
Okay.
Of the upper eyelid.
Okay. Okay, so what do you want to do about it?
I would like to do a mass excision and then send for a histopathology examination. And it seems like the mass is covering less than around 1/3 of the eyelid, so it won't require any grafting. A direct closure would be fine.
Okay, so when I describe the conjunctival congestion, chemosis, am I pointing you towards something? Correct. So is there anything else that you would want to do? Go on. Yeah, correct. So basically we plan an excision biopsy with clinically clear margins, and intraoperative frozen section is important in these cases. If you don't have that facility, because they might ask you, what do? You wait for the diagnosis and you do a secondary closure. Okay? Then map biopsy is important in this case to look for pagetoid kind of sebaceous gland carcinoma. And then the eyelid reconstruction, that the techniques have already been described. In this case, we did a Cutler beard procedure, as you said. That's good. Okay, so that's done. Thank you very much. You guys did very well. And did you guys get your chocolate, Rolika?
Yes. On the way. Now, how much are we on the fun factor here? Like, did the scale increase? No? Huh? Yeah? Okay, you can go on then.
Okay. So do you want to increase the fun factor? Do we call Rolika onto the hot stage?
No. That will be a lot of fun, clearly.
Okay. So who's the third team?
Vipin and Anurag, right?
All right. So now we
So
have...
they are themselves a lot of fun, by the way.
Awesome. Okay.
Isn't that right?
And why is that right? Why should I believe her?
You will get to know, ma'am.
Okay. Wonderful. Okay. All right. So here's your case. So this is a 63-year-old gentleman. He's retired and he just comes to you. And okay, let's hear the fun part from you.
Hello, ma'am.
Okay. Hi.
Ma'am, duration of the problem, it's any watering, discharge or any...
Do you want to ask him what his problem is?
Diagnosis is
You've already made the diagnosis.
Bilateral...
No, don't tell me the diagnosis. This is not a spotter. This is a short case. This comes to you as a short case. So the patient is sitting in front of you. Okay? So now you start.
Sir, if you have any discharge or irritation from the last few months or few years...
So start with not so direct question. Just ask them, क्या तकलीफ हो रहा है? ठीक है?
First,
I told you we are increasing on the fun factor.
so if this problem you got from months or years.
Right, the time.
Yes, ma'am. And it's causing any irritation, pain, any discharge, or it's caused any
Okay, so it
inflammatory
is
symptom?
causing me foreign body sensation,
Yes,
a lot of irritation and watering since the last 6 months.
Yes, ma'am.
We'll ask for any history for any surgery if
Very
the
good.
Patient has underwent any kind of surgery in the past.
Okay.
Any history of trauma for
Right.
which he had undergone any kind of
No
procedure.
history of trauma.
And
No history of any surgery.
Then we will plan, basically that's our direct diagnosis will tell the patient that you have a condition.
Do you want to do any examination?
Yeah, we will do basic few tests to
Okay,
see
so
for
what
the,
are the examination things
to
that
see
you'll
for
do?
to look for the cause
So
of
I
the
know you know
endocrine.
the diagnosis. I know everybody knows the diagnosis here, but this is just a normal procedure.
Basically, we will look out for medial canthal laxity and lateral canthal laxity, and if the lower lid retractors are weakened, or so we will do a snapback test, a pinch test, and we will just.
How will you do that?
Uh,
How will you do the pinch test? And what is it testing?
We are testing that in what amount the eyelid reverts back to the normal position. So we will just pinch the lower eyelid, and we will see.
But the patient will scream if you pinch.
Slightly, like I'll pick it, and then we will see in how much time the lid goes back. Like if it is going back immediately, the test is negative.
So that is the snapback test. Okay? So there are a lot of tests. I'm sure you all know it, but they are a little bit confusing. Okay? So before you examine any patient, it is always good to explain to them the tests, what you're going to do. That is just because sometimes you're being observed during your exam that's going on. Your basic bedside etiquettes, they also matter. Okay? So his visual acuity was good. You need to look at the anterior segment, the cornea, whether there is any functional problem. Okay? Just on inspection, you look at the lower lid crease. Okay? In involutional cases, the lid crease is often very faint because that also indicates the laxity of the retractors or their disinsertion. Okay? Then you start with it depends on the pathophysiology, as has already been explained to you. So you look at the vertical laxity, you look at the horizontal laxity. Okay? So this is the vertical laxity where you just pull down the lid and you look for any amount of fat prolapse. Okay? This is just for vertical laxity. This is neither the pinch test nor the snapback test. Okay? Now, as he already mentioned, the different tests to look for the horizontal laxity. So there is the 3 types of distraction tests. What are the 3 types of distraction tests?
I don't remember the name exactly, but medial.
You
canthus,
already said it.
We will try to push the lid towards lateral
So
side.
if you're moving the medial canthus to this side, then that is lateral distraction.
Yes.
Okay? And when you move the lateral canthus medially, that becomes the medial distraction. Okay? And your pinch test is your anterior distraction. Okay? So we do an anterior distraction, and these are the measurements. Do you guys know the grading? I'm sure that is there in the books. Okay?
I don't remember it right.
That's okay. I'm not going to ask you. I'm just asking you whether you know it, and do I need to go into that? Okay? So the grading, I think I'm just going to show you the test, how to do that. So you just gently pinch it, not too hard, and then these are the lateral and medial distraction tests. So the medial distraction test is for the lateral canthus. Lateral canthus is not going to move too much. Okay? So if it's moving beyond 2 millimeter, that does indicate
Lateral tendon laxity.
exactly. Then we do the lateral distraction, that's for the medial canthus, and there you look for the position of the puncta. Okay, so you hold for the lateral distraction test, you hold somewhere at the junction of the medial 1/3 and lateral 2/3, and you gently pull and you see how far the puncta is moving. Okay, so then comes your snapback test. That is also a test for horizontal laxity. Okay, so here you just pull down the lid and you leave it. Okay, normally it's supposed to immediately go back in position. Okay, so I can show you the grading if you guys want in the end. Okay, and you also need to look for orbicularis the overriding. Okay, so how do you do that? How do you test for that?
Ask the patient to close the lid tightly and
right.
we'll
Okay.
Try to open.
Okay, now you can come to the diagnosis. Tell me the diagnosis based on the findings.
Both eye lower lid involutional entropion, most likely due to vertical laxity.
Okay, do you want to add something to it? Okay, does somebody from the audience want to answer? Sorry? Go on. Okay, so this is a case of entropion.
With cornea involvement.
Okay, so you talk about the grade of ptosis, that is important. You talk about, again, include the classification and the pathophysiology in your final diagnosis. Okay, so this is grade 3. Why is it grade 3? You guys know what is grade 1, grade 2, grade 3. Okay, so this here in the primary position itself, even the anterior margin is turning inwards. And this is an involutional entropion with both horizontal as well as vertical laxity as well as overriding of the orbicularis. So why is this important? Because this will automatically lead you to the management. Okay, this is very, very logical. Don't just keep reading about these are logical because you need to tackle each of these. So Jones procedure is going to tackle both your the vertical laxity as well as the overriding. It also does cover the horizontal part, but in addition, if it's more, we can always add the lateral tarsal strip. Okay, very well done. Thank you very much. And we are going to give them chocolates as well.
Yeah, you will have to go down and get the chocolate.
Okay, so now my partner in crime, Rolika, is going to take over. Is she?
Yes.
With her cases?
I hope the fun factor doesn't go down back again.
Right. Right. Okay, so thyroid we are not covering because Dr. Seema just covered.
Yeah.
Okay? Go on.
Okay.
Sorry.
Okay, the chocolates are coming to you as promised. 1 second. You can take this mic.
Okay, so this was basically her approach of how to make you anticipate the cases. Now, what I would like you guys to do now, I have only 3 pairs. There was another pair that had messaged me, is it? No? Okay, so let's have Aishwarya and Shrishti. These are the names I remember, okay? So go ahead. So basically what I want you to do is anticipate a story, okay? So if this is the photograph that is there in front of you, you have absolutely no information, no background. I want you to make up a story of what this patient presented with, what this patient has, and how would you like to go about it, right? So we have long and short cases. So let's take it like a short case, not that it's actually a long case, but let's take it like a short case and anticipate. What do you think this is? And what do you think is the history? So Shrishti, you can go ahead with the history. You make it up. And Aishwarya, you go ahead with the examination part, okay? Keep it brief and simple, absolutely. Let's just keep 3 minutes for it. Just hypothesize, whatever you like.
In your exam, don't make up the history. You're allowed to do that now.
Yeah, but sometimes in COVID era, we don't have, no? Correct? Okay, go ahead.
Maybe a 20-year-old female presented with static, non-progressive swelling, painless swelling on the outer side of her, below her left brow.
Okay.
And she has cosmetic reasons, that is why she has presented.
Okay.
Other than that, she does not have any significant complaint.
For how long do you think this has been there?
Maybe congenital, increasing in size.
Sorry?
Congenital, not increasing in size.
Okay, you think that it's been there since for a long time?
Now it has presented, gradually it is.
Okay, so do you think there is a reason why you thought that now at 20 years of age it is presented suddenly? Do you think that you have a reason for that? Because you have said the right thing, but do you know the reason for that?
It's on the sutural line, so probably dermoid. That is
No. I'm asking, why do you think that it has increased at the age of 20 years, or now that she's concerned about it? Is there a reason for that?
malignant transformation.
Sorry?
Maybe malignant transformation.
Okay, that's a very extreme part. No, I wouldn't say that. But this is basically due to the hormonal changes rather. In fact, it's around 13 years of age when they hit menarche. That is when they, present changes in the swelling texture, structure. Okay? Okay, now proceed. So you told about that this is a swelling that the patient has had for, like, say, since forever, and it has recently increased, and you feel that it is sorry?
It's painless.
It's painless, perfect. And then
And has.
do you think something to do with forward protrusion of the eyes? Do you think she would say that? No, but like if you look at her, like maybe like she might feel that there is something wrong, something odd. I'm kind of leading you to it because sometimes these patients present with something called as pseudo proptosis. It's not really a proptosis, but they feel that there is a proptosis in forward protrusion. This patient actually presented with forward protrusion, right? But there is no forward protrusion. Her complaint was swelling along with forward protrusion, correct? So, but there is none. And how do you know that? Because you do?
Valsalva.
No. Anything else? You do exophthalmometry, right? That is when you realize that, okay, there is clinical proptosis or not, correct? So, I mean, good job with the history, hypothesis, not bad. That is actually absolutely perfect. So, would you like to take the examination bit? So, I would say that when you see, mostly these cases are asymptomatic, okay? The patients have no problem with however it has been. I know you all have already decoded that this is just a dermoid. We just saw it. We just have read it. So, of course, we know it. But they don't have a problem with it, okay? It's mostly since birth. Painless palpable mass, and this patient presented with forward protrusion. However, there are patients of orbital dermoid which have a posterior presentation or like an intraconal presentation or like, the orbital part which will land up pushing the eyeball forward, that will cause proptosis, okay? Or redness and swelling. That is something which can happen if a patient with this particular presentation has trauma. Right? Sometimes it undergoes spontaneous rupture as well. So redness and swelling occurs only in that situation. It's very rare, around 4% or 10%. Okay? Right? So moving on to the examination. I'm covering only bits of it to keep it faster. Okay? Go ahead.
So on examination, on inspection, I can see a 10 into 10 millimeter swelling at the near the adjacent to the lateral canthus, and the swelling is normal in color and extending superiorly to the eyebrow line and inferiorly till the lateral canthus, and laterally till the lateral orbital, a few millimeter, 2 to 3 millimeter beyond the lateral orbital margin. And on examination of both eyes, eyes appear orthotropic and I mean, and examination of this eye shows normal palpebral fissure height, and this conjunctiva shows is normal, and anterior segment examination is normal, pupil dilated, and
pupil dilated.
And so I would like to measure the extent of proptosis if present. In this case, I would like to choose my exophthalmometer since the lateral orbital rim may not be reliable, so I can choose.
No, so I'm quite impressed by that you are able to, enlist whatever you are looking for, right? I think you've covered it pretty well, maybe not that completely accurate, but you have thought of each and every factor. That's commendable, right? One more thing is that while we are learning, like in postgrad, I request everybody to please avoid intercommunication, please. So what happens is when we are in postgrad, we have a tendency to follow the inspection, palpation. We have a tendency to follow because we have been taught that, and it is not wrong because it's been taught that because we're supposed to remember each and every examination step. However, what she has done is what I really required you to do, because when you're looking at the swelling, try to frame each and everything about it, then fit into every criteria, right? That's how you mature around it, okay? If you're trying to do inspection, then you're focused on inspection. You might miss something else, right? So put it both ways. So it's good how you present it. However, I do not agree with the size. Like, you know, the pupil itself is 11, no? So the size is way beyond that, correct? So you have assessed the extent, you have assessed the texture, you have been able to probably say, maybe on palpation, you will be able to tell whether the bony margin is felt or not, whether you are able to insinuate your finger or not, okay, whether the posterior extent of the lesion is felt or not, or palpable or not, right? So very briefly again, it was actually probably like a 16 by 16 and 6 mm palpable lesion. Again, this is not precise because this is a clinical finding. What will be precise is?
On palpation.
On radiology, okay, you will be able to assess the actual size of the lesion, okay? And also, you have to understand that there, on imaging, you will also be able to assess how it is housed in the orbit, right? Whether there is a dumbbell dermoid component or not, correct? So, it's a painless lesion, cystic to firm mass, not reducible, but compressible. We have put that specifically because it's important for you to understand the difference between reduction and compression, right? Compressibility, sorry. And restricted motility. Now, this is, I'm not talking about the ocular motility here. I'm talking about the mobility of the lesion. If it is restricted, that means that there is any bony adhesion, okay? That means that somewhere around the lesion, there is a bony involvement, right? Or, again, hurtles, as I've mentioned. In this patient, there was no exophthalmometry and non-pulsatile swelling, right? So we do not begin with valsalva, we sort of end with valsalva, right? So in these lesions, mostly you'll end up seeing a palpable mass, again, restricted motility, again, proptosis is a possibility, in which case, in anterior cases, you will not see it, but in anterior cases, you might see fixity that I mentioned, right? Motility, there you have to limit it out in cases where there is any impingement or adjacent structural involvement on the muscles, correct? And over here, you can see in the, which view is this?
Warm side.
Absolutely, right? So you can see over here, there's a nice posterior lesion pushing it out, causing the proptosis, okay? This is where you can see dystopia, right? You have to assess whether it's axial or abaxial, right? And an element of ptosis, which was also there in your patient, correct? And there's something known as oculoplasty on mastication, right? It's beautifully documented here, don't forget it, because when that happens, then you know that you have to look at the deeper extent. And again, diplopia when there is muscle involvement, right? So swelling, pain, and redness can also occur when there is rupture, correct? So not to forget that. And I only get one case due to limitation of time, okay? So this was an orbital dermoid, and I hope I did not let you down by the fun factor, right?
It was a lot of fun, and we would like to end with our best of luck slide because all of you are great and are going to do really, really well because you guys already know a lot, and good luck for the future.
But from the long and the short.
Thank you.
Thank you.
So moving on to the Uvea session, and today we have with us two stalwarts in Uvea that have been extremely kind to spare their time for you all and have come here. So I request Dr. Amit Khosla sir and Dr. Manisha Agarwal ma'am to please join the stage as the chairs for the session. Right. So We would begin with Dr. Manisha Agarwal, ma'am. Ma'am is a uveitis specialist at Shroff Eye Care Center, ma'am. So we would Shroff Charity Eye Care Center, sorry, ma'am. And the topic is Diagnosis in Uveitis Interactive. I welcome you, ma'am, to please take your talk.
So a very good evening to all of you. And at the outset, I would like to thank Dr. Honavar and iFocus team for making me a part of this wonderful teaching program. It's indeed very heartening to see that so many students are still sitting fag end of the day and attending a session like uveitis session. So I think that speaks volumes of the kind of interest Dr. Honavar has been able to draw from all of you. So when I asked Dr. Honavar that when he gave me this topic of diagnosis of uveitis and interactive session, I asked him that what exactly are you wanting me to present? So uveitis is such a large, a huge volume of pathologies. And the concern is that very often it has so many underlying systemic pathologies. So the best learning for any case of uveitis is primarily when we learn through cases. And believe me and Dr. Amit, we have been practicing uveitis for I think more than 20 years now. And still every case that we see of uveitis in our clinic is a learning for us because we really have to tax our mind. So having said that, let me begin my talk. So diagnosis of uveitis, you have to follow 5 principles. One is a detailed history taking. I think that's extremely relevant, especially when you are dealing with a case of uveitis. A very meticulous clinical examination, I think that applies to any other case. Supported by clinical investigations, and when I say clinical investigations, would be the various investigations that you do in your clinic, OCT, FFA, ICG, ultrasound. But in uveitis cases, it is also confirmed or supported by a lot of lab investigations. And you would have very often heard the term tailored lab investigations. And when we say tailored is because we don't want the patient to invest his money into irrelevant investigations, which are not going to really help you in coming to a diagnosis. So you have to tailor-made it according to your clinical suspicion or a differential diagnosis. And the last is that you have to evaluate the response of treatment that you are seeing in your patient, and accordingly, you are going to be modifying what you are seeing in your patient. So let me start with a few of the interesting clinical cases which I managed, and they were a great learning for me. So my first patient was a 38-year-old unmarried female patient who presented with pain, redness, blurring of vision in the left eye for last 5 days and also complained of photophobia and floaters in the left eye. There was history of hypothyroidism, nausea, vomiting associated with stomach ache, recurrent ulceration of breasts and hair loss, no history of any exposure, no history of any sex partners, on treatment for anemia, esophageal reflux, and hypothyroidism. So please be careful when I'm taking you through this case because that's where you're going to catch where we go wrong as clinicians. So the right eye was pretty normal and the left eye had hand movements close to face. The patient had some element of anterior segment inflammation in the form of keratic precipitates and AC reaction. And there were, of course, evidence of some broken posterior synechia in the form of iris pigments on the anterior lens capsule. Now, this is how the right eye picture looked. Any guesses on seeing this fundus photograph? It's like a spot diagnosis. So you have a huge patch of retinochoroiditis. What you are seeing? Is my pointer visible? So you have a huge patch. This is the entire patch of retinochoroiditis, which is very typically known as posterior placoid retinochoroiditis. And this is how the left eye picture looks. So you have a hyperemic disc. You have some kind of these pinpoint deposits. And you again have a patch of retinochoroiditis, which is not so classical as you saw in the other eye. And when the patient came to us, she already was carrying this entire gamut of investigations with her, right from anything you ask for. She had undergone RA factor, HLA-B27 negative. That means the person who had advised the lab investigations did not really clinically apply that what would be the differential diagnosis of this patient. Otherwise, somebody would not land up advising something like a HLA-B27 or an RA factor. So that is where I meant to say that you have to have tailored lab investigations. So things like RA factor and HLA-B27, if you correlate it with the clinical picture, was totally irrelevant and not required. And then you see all this. This also the patient was carrying like toxo, rubella, CMV, you name it, and the serum ACE. So the person has thought of viral, the person has thought of tuberculosis, sarcoid, everything. So it is like a battery of investigations advice without any correlation what you are dealing clinically. The patient was already being treated with antiviral and with oral steroids. And when we ordered certain investigations based on her clinical diagnosis, she disappeared. Now, when she came back to us, because obviously she had exhausted her funds in getting through all those investigations done. So when we said, nahi, aapko aur thode investigations karane, she thought these doctors have gone crazy, to investigations he advise kar rahe hain, and she vanished. 1 month later, she came to us, and now she was a little worried because her vision in the right eye was 6/6 when she had come back to us 1 month back. But now she started having a blurring of vision, and the vision had dropped down to 6/36 and 24. And now you see that in the right eye also she has this ground glass retinochoroiditis appearance. The left eye, you again have this retinochoroiditis with superficial retinal precipitates. So that entire patch in the right eye, which was initially there, had disappeared. And now she started having fresh patches of retinochoroiditis. And she also started having some blurring of vision. So this is just an autofluorescence we did for a complete documentation. And when you see, this is the fundus fluorescein angiography, what we have again done for this particular patient. So though clinically not evident, she has a much larger involvement involving the macular area. And when you do an OCT, you find that there are these typical precipitates that I was showing in the clinical photograph. You have these intraretinal precipitates which are present. So we investigated her further, and what was interesting, if you see the lab investigations initially, I'll just show you the Mantux was 0. That means this patient was immunosuppressed. Okay, so that is why we went ahead and now we investigated her for HIV. She did come out to be reactive. HIV-2 was non-reactive. Her CD4 counts were extremely low to 198. And now we find that the VDRL was reactive. Okay, so that was the first investigation. And then we ordered a TPHA, and that came out to be positive. So this is like a spot diagnosis case. It is a, what is it? It's a syphilitic retinochoroiditis, what you are dealing with. So if you capture that picture or that placoid retinochoroiditis, it's very classical picture of a syphilitic retinochoroiditis, and nobody should go wrong in diagnosing that. The patient, of course, was started on the heart therapy along with injection benzathine penicillin, prednisolone acetate eye drops were continued, and oral valcyclovir, which she was investing money, was all stopped. Steroids were also stopped. CSF analysis was done, and she was diagnosed to be a case of neurosyphilis. She was put on monoseph. She was treated with anti-syphilitic treatment in the form of benzathine penicillin. And after 3 weeks of treatment, the CSF sample came out to be negative for VDRL. So my learning by managing this patient was that when you do a CSF analysis, you have to actually tap VDRL and not TPHA when you want to be sure that the neurosyphilis element has got treated. And her CD4 count started building up. And this is how she looked after 2 weeks of treatment. This is after 6 weeks. and she recovers a good amount of vision in her right eye, but because the left eye was already pretty bad, she did not really recover much of the vision because there was a lot of sclerosing of the vessels that you appreciate in the left eye. And this is how she's followed up at 6 months, where she recovers a vision of 612N6 in the right eye. So we were able to at least salvage one eye vision in this particular patient. And on treatment, what you find is that all those intraretinal precipitates that I had pointed out in the OCT, they have all disappeared and the patient looks pretty good. Now, the problem in this particular case, why did we not think of syphilis when she presented the first time? My junior apparently felt that she's an unmarried female, so there cannot be any sex-linked disease in this particular patient. And when we went back to this lady, when my junior consultant got this patient to me, and I said, this looks like syphilis. So I said, why didn't you take the history? Ma'am, she says she is an unmarried female. Okay, but you cannot get carried away by that history, and that's how we published this particular case as syphilitic uveitis misdiagnosed as viral retinitis, a misleading history. So that is why when we went back to this female, she of course had a sex exposure, and that's where she was, having all these kinds of infections in her. Now let's come to the second example. So detailed history taking is extremely important, and I cannot highlight it more than the first example that I have shown where my junior consultant went wrong. Now let's come to a meticulous clinical examination and how this is relevant for the cases of uveitis. So this is a 68-year-old male patient, sudden diminution of vision in the right eye 10 days back, now having blurring of vision in the left eye for last 5 days. Patient has a history of paralysis of left side of face 6 years back, hypertensive for last 6 years, history of CAD bypass surgery done in 2011, and has stopped EcoSprint 6 months back on his own. He has already shown somewhere else, diagnosed with BRAO in the right eye and referred to the treating cardiologist for a re-evaluation, and also referred that please start EcoSprint again because patient has developed a thromboembolic phenomena because the patient has stopped a EcoSprint which was going on for last few months. The problem in this patient, why he presented to me, was that he was quite convinced, okay, I've lost vision, I did the mistake of stopping EcoSprint, I've lost vision in my right eye. He presented to my clinic and to me was because he started losing vision in the left eye, and nobody was ready to think why is he losing the vision in the left eye. So this is the right eye picture where you have ONH swelling. There's element of retinal edema secondary to branch retinal artery occlusion. Okay, so this patient is having an inferotemporal branch retinal artery occlusion, and the vision is as low as counting finger at 3 meters. Now this is how the fundus of the left eye looks. So when you briefly look, you again have a ONH swelling. Vision is 636 N36 in the left eye, and the patient has some element of vitritis, not too much, but some element. This is how the patient looks on a dilated fundus examination. Any guesses? What do you see? Sorry? You can just describe what you are seeing in the left eye picture. Dense vitritis, of course, but do you see something in the periphery? Is it visible? I don't know, I myself can't see the pointer. But in the periphery, you have these classical creamy tongue-shaped lesions which are suggestive of active retinitis. Now, if a person doesn't dilate and see the extreme periphery, you are very likely to miss these particular lesions, and this is what I mean. So when you see the extreme periphery of the left eye, you see these typical classical tongue-shaped lesions which are very classical of, so it's not basically PON, but basically acute retinal necrosis, okay, ARN. And we went ahead, we investigated this patient, and apparently everything came out to be positive. And the patient was put on oral valcyclovir. EcoSprint, of course, was restarted for this patient. The left eye was treated with ganciclovir, and oral steroids were started after 3 days, and the risk of RD was explained. The follow-up at 3 weeks, both eye vision was 3/60. Laser barrage was done in the left eye, 360 degrees outside the arcades because we wanted to salvage the posterior retina. The follow-up at 2 months, the patient had a vision of 636 in the right eye, and in the left eye, we could just salvage a vision of 3/60 because already a lot of ischemia had set in. There were a lot of sclerosed vessels, and you had an ischemia of the optic nerve head. Now, this was interesting because we were not aware that why did the patient present with BRAO? But when we reviewed the literature, BRAO has been described as a sign of ARN, and combined vascular occlusions very much can be the initial presentation of ARN in the fellow eye. And that is exactly what this patient was having. But because the initial ophthalmologist just focused on the BRAO, the patient had a very significant history of CAD, bypass, echo-sprain, all those things which very much connected with the BRAO. We did not even suspect that let's inspect the entire periphery and see what's going on. So that is where comes the relevance of doing a very thorough clinical examination. So this is what I told, that everything was fitting into a cardiac history leading to a BRAO, and we never thought of a infectious etiology in this particular patient. The possible mechanism which has been described in literature is the subclinical inflammation in the right eye, causing the release of inflammatory mediators which may disrupt the blood flow, causing a thrombus formation, and an arteriolar occlusion is the phenomena that has been described. So this is again a brief report that we have published where BRAO was the presenting sign of ARN, which is a rare association, but it does happen, and that is something for all of us to remember. So whenever you have patients of vascular occlusion, just don't focus or have a tunnel vision that it is secondary to some vascular phenomena, but viral infections are also extremely important. And now, since we have all gone through the COVID pandemic, we do know that a virus can cause a thromboembolic phenomena. What else can we relate it to this particular case that I just showed? So that is another thing you have to really keep in mind, and that is why you have to be very careful, because the prognosis depends upon your early diagnosis and management of these cases. Now let me take you through to another case where I would be highlighting that how you can support it by clinical investigations, and what do I mean by tailored lab investigations. So this is a 14-year-old female patient from Hathras, came with diminution of vision for last 7 days. She had recurrent skin rashes over the exposed areas for last 9 months, treated with topical medication. She was just regularly visiting a dermatologist. She had a history of painless oral ulcers with fever for last 1 year, under treatment for anemia, menstrual irregularity, and hematuria. She was on antiviral in the form of acyclovir, and she was also on steroids, and the dermatologists were treating her with fusidic acid ointment, which I really don't know what much it is for. And this is how the girl came to my clinic. Any guesses? Sorry? Okay, let's see. So this is how the patient is appearing, and this is how her hands are. And this is how her fundus picture is, where you have these extensive cotton wool spots. The vision is as low as 6/60. She has a serious detachment in the macular area, which is very well appreciated on the OCT. When we did her investigations, her hemoglobin was pretty low, her WBC counts were low, the ESR was raised, nothing else was very relevant. So when we went through, I mean, it is again a diagnosis. So this lady or young girl is suffering from SLE. And when we just correlated her, so she has a malar rash, she has a discoid rash, she has oral ulcers, and she has a hemolytic anemia. And this is the particular guideline or criteria for diagnosing SLE. So she had 4 of these diagnoses, and therefore we made a provisional diagnosis of microangiopathy related to SLE is what this young girl was having. So now, based on that clinical judgment or clinical provisional diagnosis, we advised her on tailored lab investigations. Is what I mean to say is that we went ahead and did a urine analysis. We did an ANA with immunofluorescence technique. We asked the dermatologist to take a skin biopsy. We did the renal functions. And all you see, anti-DS DNA antibody, anti-Smith antibody, an MRI was done to rule out any neurological involvement. And I do remember when I was seeing this patient, I actually called up Amit sir, and I asked that, you know, this is the young patient, and what all investigations, because I didn't want that patient to go back again and again to get the investigations done. And sir really helped me and said, okay, please get all this done, and, you know, we'll be sorted out. So this patient we treated with IVMP because she was in a very bad state, followed by oral steroids. And we also started her with HCQ, which was started for this patient. 10 days follow-up, you see what a drastic improvement took place in this patient. All the malar rash was gone, all the discoid rash was gone, her hands, they really responded well, and the patient was doing well. She recovered a vision of 624 N12 in 10 days treatment. The serous detachment started reducing, and the same was in the left eye is what we see. And we were waiting for the lab reports to come in, and rightly so, the anti-DS DNA antibody, the anti-Smith antibody, they all came out to be highly raised. The renal functions were within normal. The coagulation profile was within normal. And the skin biopsy, which we had insisted through our dermatologist, came out to be suggestive of lupus erythematosus, the tumor type, which we don't know much. So now we did have the patient where we had the 4 out of the 11 criteria, which the patient was already meeting. But the 5th one got added, that the immunological lab investigations, such as the antibodies to double-stranded DNA or the SM antigen, they also came out to be positive, and it did confirm that we were indeed dealing with SLE. And imagine the plight of this young girl. For last 1 year, she's been having fever, she's having these terrible skin lesions, and she's just being treated with some topical medication without anybody realizing that she's having a systemic pathology going on in the eye. And this is another lab investigation, a positive ANA test, which goes in favor of SLE. The case was discussed with rheumatologists, the oral steroids and HCQ were continued. The MRI was deferred because we wanted to do a little cost saving for this patient. And because everyone felt that she did not have any neurological symptoms, probably we can save an MRI for a later stage. And this is how the young girl looked at 3 weeks. BCVA had recovered to 618 N10 after she was started on treatment. So we need to realize that sometimes these uveitis patients can be dealing with multi-system disorder, and therefore we just cannot be just focused on either skin or on the eyes, but you have to see the whole patient in totality. And this is all a list of organ involvement in the course of SLE, and this is the entire gamut of ocular manifestations that you can see again in a patient of SLE. I'm sure you'll find it in all the textbooks. Now let me come to the last examples, which will be a response to treatment. And that is something very important. As a clinician, we always say, don't fall in love with your diagnosis. You know, I have made this diagnosis and I'm not ready to change it. Like, I don't want to change my girlfriend. You have to keep seeing what is the response of treatment, and you have to accordingly keep changing your diagnosis. So one principle for all of you, don't fall in love with your diagnosis. So let me see, a 45-year-old female patient, she has a diminution of vision in both eyes for last 4 months. There's no history of systemic illness at all. And she was diagnosed to have Harada's disease somewhere else. 3 doses of IVMP given, followed by oral steroids, and now on oral methotrexate once a week, and now also started on azathioprine. And she was known to one of my employees in the hospital, and I got a request that have a look at this patient because she's not doing too well and not happy because she's already been on this treatment for last 6 months. I was a little reluctant, but then I said, fine, okay, let me have a look at her. So the only thing which I was told was that not responding to treatment, Harada's disease, and already on so much of treatment which was already going on. Can I take a few minutes more? Thank you. So this is how the left eye picture was. She had extensive exudative retinal detachment. She had these subretinal gliotic bands passing through the macular area. And on OCT, you find that there was an element of this pigment epithelial detachment, which is very well seen. There is a bacillary layer detachment, and this is the high reflective subretinal gliotic band, what I have showed you clinically. And she also had some high reflective material which was present in the subretinal space. You had pockets of serous detachment, and this picture actually resembles a Harada's disease, a VKH, what you commonly see in your clinic. So it is well justified that the other clinician got a little confused and thought that it is VKH. This is the FFA picture, not very contributory. You just see a diffuse hyperfluorescence in both the eyes. So the disc, of course, you will notice is a little hyperemic. Now, what very strongly went against a VKH diagnosis in my mind was that there was no response to steroids, including IVMP, no response to immunosuppressants, both methotrexate and azathioprine. So if you're dealing with an inflammatory pathology, there's absolutely no reason why the patient should not be responding while being on 2 immunosuppressants and steroids for last 6 months. So that is something I hold against this particular diagnosis. So I go back to the patient and she gives me a history of alopecia treated with minoxidil for a year. Chronic CSR was the diagnosis which came to my mind, which had been badly managed and had worsened because of the high dose of steroids that this patient had received. So I gave her a trial of eplerenone and I reviewed the literature. I was very happy and thrilled. I've made the diagnosis and I'm sorted out. I stopped her on steroids. I stopped her on all the medications, started her on eplerenone and reviewed her after 2 weeks. Now after 2 weeks, there was absolutely no improvement noted. She said she was better, but I didn't find any change. There were no change in the OCT findings. But this time, I was a little lost because the PED, what I saw on OCT, made a diagnosis of CSCR for me. But what was very unusual or atypical in a CSCR patient was this bumpy RPE, what you see. Now, a bumpy RPE you are not going to get in a case of VKH, and neither will you get it in a patient of CSCR. Any guesses? Sorry? Say it loud, what is there? Okay, let's see. So this time I wanted to actually buy some time because I didn't know what the diagnosis was. So I went back to the patient again. And what I did was I started from a detailed history taking again, okay? I had already spent 2 hours taking minoxidil history and now I said, okay, let me start again and take a detailed history. And this time she came up with the history that I said, do you have any lump anywhere in the body? And she said, yes, I did have a small nodule in the right breast 2 years back, which was diagnosed to be benign. Being honest to all of you, I didn't know what I was dealing with. So I said, okay, let me start from here and send her back for a diagnosis, for a re-evaluation. I sent her back to the oncologist. And we said, okay, what came out in this particular patient? She was lost for 2 weeks. And when I gave her a call to her husband, she told me that she indeed has a huge lump in the right breast, along with the enlarged axillary nodes, and the opposite breast and axilla apparently were normal. And she was advised various investigations, including a mammogram, a PET scan, all those things, and she underwent a biopsy also. And finally, she was diagnosed to have invasive ductal carcinoma grade 3, which had metastasized to all possible parts of her body. So we had lost about 6 months initially, diagnosing her as Harada's disease and treating her with steroids and immunosuppressants. So this particular case, apparently I did operate on her because she was totally non-ambulatory. 6 weeks post-op follow-up, she had recovered a vision of 612N12. I had put in silicone oil. I did try to drain externally, but it didn't work. But you know, whatever life of this patient was left, we thought that we should give a good quality of life to this patient, and she was pretty happy to recover some vision because she was able to at least move around. So the clinical purse to run from this particular case is that the patient is not responding to treatment. I think it is time for you to revise your diagnosis. Restart by a detailed history taking, that is extremely important. Run through all the investigations again. So like I said, don't fall in love with your diagnosis. Be ready to revise and change your diagnosis. And if your mind is getting blocked, take another colleague's opinion or refer it to another expert and be open to the idea of changing your diagnosis. And we have to be careful that we may have something underlying which may be very fatal if not detected on time. So you have to be very careful. I'll miss this last case and I will just wind up my talk by saying that to avoid common mistakes in these uveitic cases, a careful history taking from the patient and detailed clinical examination often gives you a clue to the diagnosis. We must rule out an infectious etiology before diagnosing it as non-infectious and before loading it up with steroids and immunosuppressants. We should always be open to read up and revise our diagnosis in these cases, and a regular follow-up is extremely essential to avoid a permanent loss of vision in these chronic uveitic disease patients. Thank you so much for your patient listening. I'll disconnect this.
Thank you so much, ma'am, and thank you for keeping it very case-oriented, because that's the way we all end up remembering it the most, and it's useful for all of us as well. So would you like to add any pointers to ma'am's talk, sir?
So I have some photographs, maybe common photographs between her and me, I'll show them in my talk.
Right, sir. Okay, sir. So I invite Dr. Amit Khosla, sir, who happens to be a renowned vitreoretina surgeon and uveitis specialist, and with a special touch in immunology from Gangaram Hospital. And he will be talking on the management of uveitis.
Thank you, Santosh, for inviting me. So I'll talk about uveitis. You stood 12 hours sitting here. So I'll give you some tips which will turn your thinking upside down of the manager of uveitis. So I did my senior NC in 91 to 94 at AIMS in Uvea, and so I've unlearned what I have learned. So what I'm going to tell you is that you're going to unlearn what you have learned in uveitis and reboot yourself, okay? So this sort of I have learned from the rheumatologist. So we all have complications in long-term uveitis management. Do you ever think that the patient has been undertreated all these years? So this is a list of complications you'll see every day in your OPD. Just think, when you see a complication, could this have been avoided? So we as ophthalmologists think that immune reaction will last 2 to 5 years, while the systemic rheumatologists believe that disease will last 20 to 40 years. So you have to understand that immune response, eye is an immune privileged structure, but once you have a breakdown of the blood retinal, blood aqueous barrier, it's going to keep coming because your antigen has been exposed. So if you understand immunology, we have innate and adaptive responses. The innate is the T cell response, and the adaptive is one when you have a antigen, after a few weeks you get antibodies to that. So once you've gone to the chronic phase, so 1/3 of our uveitis patients go into the chronic phase and the barriers have been broken, you will require long-term immunosuppression. So long-term inflammation will cause maculopathy, hypotonia or glaucoma, optic neuropathy. So when you see a patient 20 years down the line and see, oh yes, 10 years back he stopped treatment or she stopped treatment, you realize that immunosuppression would have led the patient normal. So whenever you think in terms of uveitis, think of 5, 10 years, 15 years follow-up. So would you think managing uveitis and saying, I will not let my patient develop cataract or glaucoma? That's the aim. Why I started? I do pediatric uveitis. So aim in GI is no uveitis, no cataract, no glaucoma, even at 20 years of age. So you have to have an agenda. I'm going to be 6'6", so you have to stop steroid at 3 months. The same problem which steroid cause, you are trying to prevent that. So if you don't stop steroids in 3 months, you're going to have complication. The other thing is that, would you prefer to have steroid 3 months a year or to have a mild drug like methotrexate for 12 months? So you have to realize that 3 months of steroid is more toxic to the body than methotrexate for 12 months. So we keep classifying. The old dilemma, you'll have all case presenters say, oh, it turned out to be infective. But remember, 60% of your patients are non-infective. So in the fear of that infection, you are under-treating the immunological cases. So there is not a standard workup of uveitis. As Dr. Manisha showed, that a history taking, going back to the history after examining, it helps you make a better diagnosis. Now this patient is a child who walked into OPD, has been treated with steroid for vitritis and anterior uveitis. The moment I saw the child was wearing hearing aid in both the eyes. I asked the parent, any heart disease? Yes, heart surgery has undergone a heart surgery. So I said, rubella must be positive, stop all steroids. So all our immunological diseases are triggered. COVID has taught us that there is one infective phase, one immune response phase. So you don't treat in certain viral diseases, you don't treat at all. So this child is, after stopping steroid, is 6-12 vision. It's a child with rubella retinitis. So you do investigations confirming the specific diagnosis which you have in mind. Now if you're hypopyon, what would you think? So think the worst. First is endophthalmitis, a metastatic endophthalmitis presenting in hypopyon. So what do you need to do? You need to dilate the pupil and see the periphery. If you can't do it on day 1, don't give him steroid drops and say, come after 7 days. Call him the next day. Call the patient the 3rd day until you are able to see the retina. I have made these mistakes of diagnosing a end off as an anterior uveitis. You have to dilate and see the peripheral retina. Now the question is, do you investigate a first attack of uveitis? How many of you investigate, raise your hands or something? No, so you do. Today my OPD attendant of 22 years has a first attack of anterior uveitis with no cyclia. Should I investigate him or should I not investigate him? So you may not investigate a first attack which is mild, non-granulomatous, no hypopyon, no synechia, no cataract, no glaucoma. How many cases would you find like this? Rare. But yes, you could be HIV positive. You could have syphilis with anterior uveitis, and you could have TB, right? So you can still miss the diagnosis. So the UV experts feel that the old thinking of non-investigating a first attack is outdated. You have to investigate the first attack, take a history, could be HIV, syphilis, could be TB even, right? So in India, one physician asked me, 1 in 100 of your uveitis you say is TB. Why can't you get an X-ray chest for all your uvea patients? Which is right. X-ray may not pick it up, but at least you miss an open case. You won't miss an open case of TB. So the whole evaluation I do in the OPD is the patient infective? Is the patient non-infective? If the patient is infected like rubella, I don't need to treat. Does the patient require antibiotic, antimicrobial plus steroid, or purely antimicrobial? So how do I think about it? If you see non-infective, you have this HLA-B27 disease, you have a clinical pattern recognition, may have a systemic disease, and you have systemic the important thing is that you may have a spondyloarthritis which is HLA-B27 negative. So remember that these biomarkers may come in late. So I have had a patient with combined young female 18 years CRA or CRVO negative, nothing, no positive. After 1 month becomes anti-phospholipid positive. After 1 year gets ANA positivity in SLE. So you may have evolution of a disease. If you have done a test, there's no harm in repeating after 6 months, 1 year, your diagnosis will change. While in the infective one, any anterior uveitis which is viral means that the presenting feature with high pressure. If you have a uveitis who presents with high pressure, think of viral, who develops glaucoma down the line is a steroid responder. So between non-infective, standard teaching is choroiditis except TB, and in retinitis, majority are infective except Behçet's, right? And in India, TB is the commonest. X-ray chest will not pick it up. For me, CT chest is sacrosanct. How many TB I have picked up? If you can get a PET scan, Dr. Salil Mehta from Mumbai has shown us the way that even getting a PET scan picks up more TB if you suspect TB. Try to find the source of TB. Why? Because in today's world, 20% of the patients are MDR. If you can culture it, find the resistance. I have had a patient who came in with a biopsy elsewhere, negative for TB. We repeated it. Patient came to be rifampicin resistant. So the whole treatment changes. If you can document TB somewhere in the body and biopsy it and get a PCR done which shows resistance, then your whole treatment changes. Now for viral, you need to get a HIV, herpes simplex, varicella, and CMV. Now the TORCH test in the blood will not confirm. If I do a TORCH test of all of you, 30% will be positive for something or the other. So that doesn't mean you have had infected. So PCR, as it becomes available for aqueous, will become the main source. But at the moment, you don't have kits for the eye where you can get all of them done with a small 0.5 ml solution. So common mistakes you make, you get an ANA TAS and rheumatoid factor. Never will SLE or rheumatoid arthritis present as anterior uveitis or posterior. They will present as vasculitis or scleritis. So if you have anterior uveitis, do not get a rheumatoid factor. Now these two tests, ANA and rheumatoid, are done in children to diagnose JIA, a type of subsets of JIA. So ANA rheumatoid factor is done only in pediatric uveitis, not in adult anterior uveitis. The TORCH levels are of no value. Yes, you may be positive, or negative means chance of having that infection in the eye is less, but don't take TORCH too seriously. The next thing is that less than standard teaching is 60 milligram for 1 week, 50 milligram, 40 milligram, and you stink. None of the uveitis gets control in 6 weeks, so that is outdated. And don't think treatment based on MON2, because if you have VKH with MON2, will you give ATT, will you give steroids? So you must see the overall picture and don't take MON2 too seriously. Now X-ray chest or sacroiliac joint X-rays do not come positive in uveitis, rarely. The CT or the MRI of the sacroiliac joint will show you better. So an incomplete checkup, as I mentioned in the beginning, you must do an indirect on all anterior uveitis, with dilated pupil. The association, so we have this concept of genomics, proteomics, where the metabolites, maybe in the next series, iFocus on 15th, I'm talking about immunosuppressive online, I'll tell you about these parameters. So the first article of HLA-B27 came in the 1970s. Standard teaching, young male, recurrent, alternating, fibrin, standard teaching. But yes, it's all triggered by gram-negative infection. So remember, your gut is the source, bacteria are the source of all immunological diseases. They react, they cross-react, and you have all the immunological diseases. So any viral infection, any GI infection will trigger uveitis. There's a huge list of patients of uveitis with arthritis, reactive arthritis, rheumatoid arthritis, vasculitis. Okay, so ankylosing spondylitis is the most common one, right? So I'll just tell you that HLA-B27 does not mean angstpong. It means reactive arthritis, it means psoriasis, it means non-SPA also, and only a subset of patients will have X-ray positivity. Not working. So only a subset will have X-ray positive. Few will have MRI. So you can have non-HLA positive spondyloarthritis, you can have X-ray normal, you can have MRI normal. So it is a clinical diagnosis. So back pain which improves after exercise is a inflammatory back pain, which is more when you get up in the morning. So if you have an inflammatory back pain, think of spondyloarthritis, and you can have spondyloarthritis which is peripheral. The peripheral joints can also have it. So the classification of spondyloarthritis has changed. Now if you are treating, don't think HLA-B27 backache is important. You can have various features. So ankylosing spondylitis, reactive arthritis, undeficient spondyloarthropathy, psoriatic and inflammatory Crohn's and ulcerative colitis, also part of the same spectrum of disease of HLA-B27. So why should I investigate a patient for HLA-B27? It won't alter your treatment, but yes, 66% of HLA-B27 will develop spondyloarthropathy. 6% who HLA-B27 will develop spondyloarthropathy in 9 years. So it's important to help that patient from going to a bamboo spine. And the only treatment of preventing a bamboo spine who has spondylitis is biologics. So today, to say that interior uveitis is cured only with topical treatment, that is also outdated. So if you see this chart, which shows that the definition of spondyloarthritis is changing, so you need a rheumatologist. So when we started practice, there used to be rheumatologists you couldn't find, but today you have plenty of rheumatologists, so you people will have much easier sending this patient across and picking up the disease and helping them treat their systemic disease, not the eye disease. Now the second commonest cause of uveitis, interior uveitis, is keratouveitis. So in keratouveitis, you may have HSV, you may have simplex, you may have CMV. CMV will not present with a keratitis such severe. But how many of you believe that once this keratitis is controlled in herpes, we need preventive? Can you raise how many of you think in your institutions we give preventive acyclovir, valcyclovir for years to prevent a keratitis? Anybody gives? So now things is changing that if you have keratitis, you have endothelitis, you have stromal keratitis, and the patient has recurrent. So today a patient came who had herpes zoster disease, had a small cornealoplasty, came back after 6 months again with a large opacity. So the patient had active stromal keratitis, required antivirals plus steroids. So you need more frequent monitoring, otherwise these patients, they become all right for 6 weeks and they keep coming back. So please, all your viral uveitis, especially the herpes simplex and zoster, please follow them more regularly, and if required, give preventive treatment. Though there is no consensus, there is always a uveitis specialist consensus and a cornea specialist. You'll never find a consensus how much to give antivirals in these cases. So if you see a patient with corneal involvement, with iris atrophy, you think of a viral, of a high pressure at presentation. So this is a classical patient of iris atrophy, varicella zoster, who had iris atrophy, high pressure, and recurrent uveitis. And if you do a specular, you'll find that the endothelitis is there, and the stromal keratitis will cause a blurred endothelium. When it resolves, it will become clearer. Sometimes you cannot pick up a stromal keratitis. It's only in a dilated pupil with retroillumination you will pick it up, right? But sometimes the specular also helps you pick up the endothelitis. So what I do a tab for herpes simplex, CMV, varicella. Rubella is a diagnosis exclusion. So all the cases which we diagnose as Fuchs dystrophy, or we diagnosed as Posner-Schallmann's, are actually viral uveitis, where you may not have only rubella, but other viruses also having positivity. So do get a simplex CMV in varicella in all your patients with ocular hypertension. Right? Today I had a patient with ocular hypertension. I said, either I tap or you take valsaclovir for 2 weeks. If it responds, fine. Otherwise, we'll tap and rule out CMV, because valsaclovir or aceclivir will not treat CMV. It will treat the other herpes, but you need valganciclovir to treat CMV. Now let's get to intermediate uveitis. Last month, there was a intermediate uveitis lecture by Dr. Biswas on iFocus, and Dr. Biswas and Dr. Amod Gupta gave contrary views to the treatment of choice, right? So there's always a confusion how you treat, right? So idiopathic, systemic disease, TB. Now if you have a TB proven intermediate uveitis with minimal edema, you don't require steroid, they respond just to ATT. But yes, if there is structural damage, you will require. So Kaplan's 4-step method is outdated, which even Dr. Kaplan agrees. Now there is no standard classification to intermediate uveitis. Blurred vision, floaters, disc edema is not a part of intermediate uveitis, macular edema, relapsing. So you are always confused. I'm looking for pars plana exudates, just vitritis. Is it intermediate uveitis? But I can tell you I've been treating with immunosuppression for 20 years. The best patient to treat is intermediate uveitis. But in children, it's so bad, you require biologics. So when do we treat? Classical teaching Kaplan, 6-12. No. Only if you have floaters and 6-12. If you have macular edema, you have vitreous hemorrhage, you have ERM, you have tractional detachment, cataract, peripheral retinoschisis, treat. Treat at 6-6. And always look at the periphery. I'll show you a photograph, patient at 6-6. But if you see that picture, you'll say, yes, this patient requires treatment. So younger the patient, longer the life of sleep, longer chances of structural complications. So no longer the vision is a cutoff. Treat every patient of intermediate uveitis. If it's the mild variety which responds to posterior sub, if it's bilateral, immunosuppression. So we used to have this option of 4-step. No, but the step is steroids, immunosuppression, biologics. Lasers and cryo is out. Vitrectomy only for structural damage or ERMs, or you have a vitreous opacity. Try immunosuppression biological, they work wonderfully well. This is a child with pancreatitis with intermediate uveitis, 6-6 vision, right? But see the amount of aggressive pars plana membrane form. If I leave this patient, this is going to go to retinal detachment 10 years down the line. So you have to be aggressive. So in children, always press the pars plana and see for these membranes. And active membrane formation and aggressive membrane formation is at 6-6 is an indication for treatment. This patient sent to me for immunosuppression. I gave the steroid. Turns out to be toxocara. So don't think every hazy media is non-infective. It can be an underlying infection with a fungal, bacterial, toxocara infection. Now this patient was initially treated with aceclivir, thinking it's a retinitis of ARN, but the child had Behçet's, and 2014 we were able to start biologics. So one of the first child we gave biologics, the patient had 6-18 vision. So how various drugs helped let the child go to college. Now this is a child who came to me with pan-uveitis in lockdown. Pupil bound down, 3 millimeter, took a photograph through a non-video camera, did the OCT. So gave the child methylpred, gave the child, so every child of non-infective uveitis will not respond in 3 months, will require immunosuppression. Now if you want to start immunosuppression, they take 3 months to act. So within the first 1 month, if the child, any patient at 50% steroid is active, think that you require immunosuppression. So this child was given immunosuppression from day 1. At 3 months, was started on biologics, adalimumab. The patient has 6-6 vision. So you need to be aggressive. Think aggressive. At 3 months, what's going to happen? At 1 year, what's going to happen? Be aggressive enough to start biologics. Now this patient is a VKH patient, and you see that the patient had a recurrence, and I thought has a granuloma in the right eye. Left eye is normal, but it got an ICG done. It was still active, and see the FA is negative. See the activity at day 1, at 1 month and 3 months. The FA is normal, but the left eye ICG is positive. So you realize that you may have a VKH which is subclinically active and you need to treat. And I was thinking just if the granuloma in the right eye is healed, I will stop treatment. No, the patient is active. On adalimumab is active. So sometimes the clinical, subclinical biomarkers will tell you the disease is active. Now here's a patient who was referred to me who had tried VKH, methotrexate, was on having low counts. It was referred to me. I said, let's start MMF and see what mistake I had made. Just see that in patient that have any serious detachment, has 6/6 vision, the sunset glow set in. So it took me, my assistant to say, sir, doesn't the color change on the next visit? Just the fundus photograph, I missed the sunset. I should have given the patient, done ICG, done the adalimumab treatment earlier. The patient still comes to me, gone for MBA abroad, has 6/6 vision, still on adalimumab, but the moment I taper it, the patient starts developing vitiligo or some other feature. So I will stop this patient ADA only when has no skin problem, has ICG negativity for 2 to 5 years. So today immunological diseases, we understand has to be disease-free for 2 years. Even subclinical disease has to be free before you think of tapering a drug. This is one of my first patients. I got a digital camera in 2003, among the first in the country. And this patient came to be diagnosed as a CRO elsewhere. So this is one of the first patients I gave with the rheumatologist 2 years of methotrexate. The patient responded, still comes to me after 20 years, has 6/6 vision. So early attack, prevented from going into the chronic phase, you will have good results. If you start immunosuppression after 6 months, the chronic phase is started, you will never be able to control it. Let's go to scleritis, the worst disease. So if you have scleritis, yes, it could be infective, but 80% is systemic disease. It's the worst disease to have. You have to be aggressive. So this patient, a small nodule on the sclera, turns out to be GPA, has no lung involvement but a saddle nose. So patient after 17 months of methotrexate or rituximab is 6/6, as nodule disappears. So even a small nodule can be an indicator of a systemic disease. We all know that mydriatic encyclopedias are important. Atropine helps break the synechia the best, but it fixes the pupil. So you need a drug which keeps the pupil mobile also to prevent synechia. So one book by Nusenblatt has mentioned a line that cyclopentolate is chemotactic. It attracts neutrophils. So based on that one line, every conference somebody will say, don't use cyclopentolate. But I have found no other article besides Nusenblatt which says don't use cyclopentolate for uveitis. It works. But anyway, if we go by this, even moxifloxacin is supposed to cause uveitis. So we should not be giving moxiflox in any of our post-cataract patients. So the aim of treatment is induction like cancer. You need to induce the disease remission. So if you do remission, then you can suppress and prevent the patient going to the chronic phase. So you need high-dose steroids, aggressive therapy, use ointment at night. Sometimes patient will tell you, anterior uveitis, I have pain early morning because you have not put drops all night. So give the patient steroid ointment. Up till 2 drops of steroids per day, you can give up to a year. The risk of glaucoma of cataracts is minimal. But if the patient is pseudophakic, is not a steroid responder, you can go up to 4 drops of steroid drops. So systemic disease, remember, do not reduce at 10 milligram or 5 milligram. As you go down from 20 to 40 to 10 milligram, below 20 to 40, make it 5 milligram, and then below 10, make it 2.5 milligram every week. So do not taper. You can have 3 months to taper. Except for the 6 weeks, start tapering steroid with a 3-month agenda. Periocular steroids were very popular, but people were unhappy with the baggy lids. They wanted the oculoplasty surgeon to remove the baggy lids or the atrophy of the skin overlying. So periocular steroids are short-term when you are waiting for the systemic drugs to act. Remember, with intravitreal steroids, we have Ozodrex, but the problem it only works for 3 months. And we do not have Retisert or the Utique implant which works for a year. And every time you put a steroid, it works in a wave-like fashion. So the immunological drugs are more aggressive, better than the steroid implants. So the goal of treatment in your mind should be no inflammation, no steroid, and no steroid-induced side effect. If you see the side trial, which was done a retrospective analysis of all the immunomodulator therapy, showed that 50% of the patient was still active after 5 years. And if you use methotrexate, mycophenolate, or azathioprine, you will have some side effect, and you will require, in about 20%, 10 milligram steroids for remission. So it's a 5 to 7 year study. So we need to understand that a subset of uveitis will require long-term immunosuppression. So the various trials, the side trial is the retrospective trial, which shows that only about 50% effectivity at 12 months with individual drug. The MUST trial, which compared systemic disease to Retisert, was equal at 2 years, but at 7 years they found that immunomodulator therapy was better than steroid implant. So steroid implant favor has gone down, and we are moving towards immunomodulator therapy. And the POINT trial showed that intravitreal is better than subtenon. The FAST trial, which which showed that methotrexate and mycophenolate give equal result, and Arvind Eye Hospital was part of that trial. So what do we do? At present, we use systemic drug, steroid, bring it down to 10 milligram at 3 months, and then start methotrexate, azathioprine, and mycophenolate. Now, majority of the eye hospital, the consultants have never been exposed to these drugs. I remember referring a CGHS patient with MMF, and the patient went to a government hospital and said, what is this MMF? The resident went to find out what MMF is and said, oh, ma'am, this is a drug used for cancer, so we can't prescribe it. So 90% of the ophthalmologists have never heard of these drugs, and we didn't have exposure to them when we were residents. So you need to work with the rheumatologist, diabetologist. If you have transplant teams, nephrologists use these drugs, neurologists. If in your town you don't have a rheumatologist, work with the physician who used these drugs. So there are the various trials. In 2000, the first guidelines came for use of immunosuppression, and the latest 2018 focus guideline is very good. If you want to understand and use immunosuppression, read this guideline in detail. It gives you everything in detail how to manage patients with immunomodulator therapy. This is the article in lockdown we wrote for the IGO. I was a co-author. You can read this article, Systemic Immunosuppression for Uveitis in Developing Countries. So remember that certain diseases will require systemic treatment. So Behçet's, Wegener's, GIA, Serpiginous, birdshot, symptothalma VKH, you will require immunosuppression. Don't wait for the steroid to be tapered and then recur, and then you start it on day 1. So what is going to happen is, the moment steroid is tapered, the immunosuppression will take time. So at 2 to 3 months, there will be a phase where you will have recurrence, and you'll think, oh, am I on the right side of the diagnosis, or is it infective? So here are the guidelines from the focus trial. I won't go into detail. Please read if you're interested. The visual trial in 2016 showed the role of biologics to be superior in those cases which failed the immunomodulatory therapy. The Sycamore trial was done for JIA, which was stopped midway because the difference was too huge between the two groups. And these are the systemic diseases which have approval for use of biologics. So if you have any of these patients, biologics can be used legally. They are approved by even the American FDA. So Behçet's, rare in India, you can start immunosuppression day 1. Even JIA, if it's one-eyed or this bad, you don't wait for 3 months, you can start day 1. And the other drugs, you can wait for 3 months, depending on the severity, and then start biologics. So in step 1, we use steroid, step 2, antimetabolites, step 3, TNF. And in addition, the steroid implants are a short-term measure. Posterior, subtendine, intravitreal are going to be a short-term measure, not a long-term measure to control the chronic uveitis. But all of these drugs have issues. Antimetabolites will have GI upset, your platelets will go down, your hemoglobin will go down, and the fear of malignancy and infection will always remain, in whether you use antimetabolites or biologics. Alkylating agent, cyclophosphamide, is used in SLE rarely, or patients who can't afford biologics, but it has teratogenic effects. So remember, biologicals take time, 4 to 6 weeks to act. Azathioprine, other drugs take about 12 weeks to act, and steroid are the fastest. So you may have these abnormalities, whether it's dengue or chikungunya, no role of any steroid, but viral infection do cause vasculitis. Serpiginous like choroiditis is an immune reaction to TB. You will require long-term immunosuppression. This is a patient now that all of you have seen the first case. Diagnosed on day 1, syphilis with HIV, patient gets 6/6 vision if you diagnose on day 1. Patient of toxo, you find a satellite lesion. So infective, I'm going to the spectrum of infective one. So it is a pattern recognition. You don't need too much test, but again a toxo lesion, again a syphilis lesion, which responds. This is a choroidal tuberculoma, which had an exudate detachment. So Dr. Manisha has worked extensively on using intravitreal eccentrics with moxi for this leakage, and how this patient responded after 1 dose of moxi and eccentrics. Patient is an MDR patient who's been on ATT for 1 year. This patient was just referred to me, being treated for 8 years with anterior uveitis, had iris atrophy. I got the PCR done. My hospital has a PCR for meningitis. I used that kit, and I found herpes simplex 1 in this patient. Here's a patient who was diagnosed as HIV, TB, and had, this is a healing CMV retinitis. You can see the fibrosis around the upper quadrant. It's the same patient which I just discussed with you, the VKH. So sometimes in TB, you will find these patient tubercles coming subretinally. If the macula is not involved, you don't need to give any treatment. So in uveitis, make the diagnosis quickly, assess the severity, select the right drug, which modifies the long-term outcome, monitor for relapse, and use the help of a physician to help better. Majority of the time, we are too late in our treatment or diagnosis. You need to start therapies earlier. Thank you.
Thank you so much, sir. Ma'am, would you like to add certain points for the closing remarks?
I think Dr. Amit is a master of uveitis, and he's covered the very complex topic in very short while. The only thing I wanted to add was that when Dr. Amit showed the VKH case, where he said that he missed diagnosing an active disease because he did not do an ICG. Another thing which can be helpful is to do an OCT and see the choroidal thickness. So till you do not have the resolution of the choroidal thickness to normal, you probably don't label it as an inactive disease or a disease which is under control, because many of us may be working in setups where an ICG may not be available. So that is something again that you can keep in mind. And often the onset of VKH is an asymmetrical onset. So even though it is classically defined as a bilateral granulomatous disease, it may appear in one eye first and subsequently in the other eye. But when you do an OCT, you will find that the choroidal thickness is high in both the eyes. So it apparently is a subclinical disease in the other eye. So that is again. But I think as both of us are on the same page that uveitis cases have to be looked as in totality, looking at various systemic signs, a detailed history, and the ocular signs together. And then you target or label up some differential diagnosis and then investigate the patients. That is something to remember for uveitis. But I think I and Amit sir, I'm sure we both really enjoyed the session.
Right. In fact, I'm actually thankful to both of you for covering such a huge topic in 1 hour, and you've beautifully summarized it for all of us to remember and have a take-home message from. Thank you so much. Thank you for coming. Thank you. So, so that's our closing of today's day. And tomorrow we will be taking the day on retina, and followed by the Star of iFocus finals and the Dangle OPL. The details of Dangle OPL shall reach you very soon in the WhatsApp group. Thank you, everyone. Good night.